Where's the countdown? There it goes. It's a little delayed. It's about a 12-second delay.
Welcome to the 2026 Neuroendocrine Cancer Foundation's annual patient conference. Thank you for joining us today. I'm Kavya Veligapudi, Executive Director of the Neuroendocrine Cancer Foundation.
I'm Lisa Yen, Director of Programs and Outreach.
I'm Heather Davis, the Director of Community Engagement.
This year's theme, Navigating a Changing Neuroendocrine Cancer Landscape, reflects the rapid advances happening across diagnosis, imaging, treatments, clinical trials, and supportive care. We thank the sponsors of this event, Novartis, Exelixis, ITM, Lantheus, Crinetics, Curium, and RaceBio. Their support makes programs like this possible. The Neuroendocrine Cancer Foundation provides a community of support and education for people living with neuroendocrine cancer, as well as their caregivers. Our staff includes Lisa Yen and Heather Davis. Our board includes Donna Gavin, who is the sister of our founder, Giovanna Joyce Mbezi, and net patient and longtime advocate, Mary Dunleavy. NCF is also guided by our Medical Advisory Council, made up of distinguished neuroendocrine cancer experts committed to improving patient outcomes. Neuroendocrine Cancer Foundation, previously known as LACNETS, is also the successor of the Carcinoid Cancer Foundation, which closed its operations recently. We have been entrusted to continue its programs, such as the Luncheon with the Experts, Support Line, Find a Doctor database, and Stories of Hope. Please visit our website for more information. And with that, I'll hand it over to Heather to continue today's program.
Thank you, Kavya, for that warm welcome and informative introduction. To ensure you don't miss our future educational events like today's, be sure to sign up for our email and newsletters on our homepage at ncf.net and add events at ncf.net to your safe sender and whitelist email lists. Follow us on social media. We are on Facebook, X, and Instagram with the handle at NCF Cancer. And now let's start with some tech tips. For watching this live broadcast, please know you can pause, rewind, and fast forward. And when you're ready to catch up, click live to return to this live broadcast. Today's presentation is being recorded, and each presentation can be rewatched at your preferred playback speed on both our website, ncf.net, and our YouTube channel a few days after this broadcast. For audio, please make sure your sound and speaker icon is unmuted. Adjust the volume, control up or down to increase or lower the volume as needed. If you're watching from YouTube Live, there is a closed captioning feature as well. For video, if the screen looks blurry or hard to read, you can go to the gear or settings icon and click Quality to adjust the resolution. It can be changed when you watch it after the live stream as well. You can pause and rewind during this live broadcast and resume where you left off, or click live to reconnect to the live stream of the presentation. You may enlarge the webinar broadcast screen by clicking the full screen icon located in the bottom right-hand corner. Our YouTube channel now features 550 videos and podcasts. Click videos or playlists to find webinars on our previous annual conferences, various types of treatments, clinical trial snippets, and an array of patient and caregiver stories. Be sure to visit the valuable information and resources from our supporters on our virtual sponsor pages. Find information on treatments, clinical trials, and helpful patient and caregiver support resources from our partners. Go to ncf.net/events/2026 conference. After today's conference presentations, some of our esteemed speakers will join us live to answer your general broad-based questions. Please note they cannot offer specific medical advice on your personal diagnosis. To submit your questions now or during the live broadcast, please visit this educational event page at ncf.net/events/2026 conference. Scroll down on this page to the Slido feed and submit your questions now. I'd like to remind our audience that our webinars are created for educational purposes only and do not substitute for medical advice. The views shared in this conference are from the personal experts' opinions and insights. Please contact your medical team with questions or concerns about your individual care or medical treatment. And now I'll hand it over to Lisa.
Thank you, Heather. Today, you'll hear from an extraordinary panel of speakers, 18 physicians from leading institutions across North America, along with 5 individuals living with neuroendocrine cancer who will share their experiences and perspectives. Together, we hope to provide the knowledge, insights, and practical guidance needed to help you navigate a changing neuroendocrine cancer landscape. At the Neuroendocrine Cancer Foundation, we understand what it is like to navigate this disease. While much of today's program will focus on neuroendocrine cancer itself, we want to emphasize something equally important. You are more than your diagnosis. You are a whole person with relationships, goals, dreams, interests, and a life that extends far beyond cancer. Our mission is not only to help you understand and manage this disease, but also to support you in living as richly and fully as possible, even in the face of neuroendocrine cancer. I'm now going to welcome our moderators for today's conference. Welcome, everyone, to the Neuroendocrine Cancer Foundation's 2026 Virtual Annual Patient Conference. We're so grateful to have you joining us today. We're grateful to have NET expert Dr. Andrew Handafar and NET patient Mary Dunleavy return for their 6th year as co-moderators of our annual conference. Dr. Handafar is a medical oncologist who leads the neuroendocrine cancer program at Cedars-Sinai Medical Center in Los Angeles, and he also serves on our medical advisory council. Mary Dunleavy has been living with neuroendocrine cancer for more than 21 years, and she serves on the Neuroendocrine Cancer Foundation board. Thank you both for being here and helping to frame today's presentations with your valuable insights. This year's theme is Navigating a Changing Neuroendocrine Cancer Landscape. Over the past decade, we've seen tremendous changes in the understanding, diagnosis, imaging, and treatment of neuroendocrine cancer. And while this progress brings new hope and opportunities, it can also make the landscape feel increasingly complex and difficult to navigate. So today's conference is designed to help patients, caregivers, and advocates better understand this evolving landscape so they can feel more informed, empowered, and supported in making decisions along the way. Dr. Handafar, I'm wondering from you, when you look at the neuroendocrine cancer field today compared to 10 to 15 years ago, what do you think has changed the most?
That's a great question. Things have dramatically changed over the last 15 years for our neuroendocrine tumor patients. I actually remember when the treatment team was just the patient, a surgeon, and a medical doctor to prescribe and to administer the SSA. And since that time, we've had several medications approved. We've had the development of new cytoreduction techniques. Liver-directed therapy has become more commonplace. Peptide receptor radiotherapy has been FDA approved, and now there are studies for newer types of radioligand treatments. And the neuroendocrine tumor team is just getting bigger and bigger. Right now on our tumor boards, we have doctors from surgery and different parts of surgery, hepatobiliary, lung, GI, intestinal. We have interventional radiology to do liver-directed, nuclear medicine getting involved with radioligand therapy, pathology, endocrinology to manage some of the symptoms, and cardiology to manage the carcinoid heart disease. So every few years, as we get better and better at this, our treatment team is growing and the landscape shifts.
Yeah, wow. That's really exciting to hear. It's not just the landscape of treatments that's growing, it's also the diversity in terms of providers that's growing the team as well. And Mary, from the patient perspective, progress can be both exciting and overwhelming. How do patients navigate a landscape that has become increasingly complex?
Yeah, I would say that there is no doubt that, especially for the newly diagnosed, this is a very overwhelming diagnosis. But also in other stages, down the road when you're looking at new treatments or even looking to consult with different teams of doctors. But the most exciting part is the hope that stems from the progress in the diagnostic tools and the treatment tools that Dr. Hendafar just mentioned. Just a few short years ago, so many of these were not available, like he said. And in my experience, in 2011 was the last time I had a liver surgery, and I was told by my surgeon back then that I was non-operable. But in 2023, I was able to have another liver resection due to surgical advancements, robotic, laparoscopic liver resection, which wasn't even considered for years prior to that. So this is just one example of, the advancements that have changed our landscape. And this isn't always the case with a lot of cancers and rare diseases. So we're very lucky to have the incredible people working for us to get us to this point.
Yeah, amen to that. We're very fortunate and grateful. Dr. Handafar, I want to follow up on what you mentioned. Patients today are hearing those terms and concepts, many of which you just touched on, that may not have even existed when they were first diagnosed. So molecular imaging, theranostics, SSA, somatostatin analogs, radioligand therapy or PRRT, treatment sequencing, tumor boards, multidisciplinary. What do you think patients need to understand the most about how the field has evolved?
Yeah, another great question. As the field has grown, as our understanding has improved and the options have expanded and the treatment teams enlarged, treating this disease has become actually more complicated. And I think it's become more important than ever that you have a neuroendocrine tumor expert on your team. Many of our patients live very, very far away from an expert center, and that's okay. They only have to meet up with the expert maybe once in a while, once a year or so, just to review everything and to help organize the case, help organize the thinking. And I think more than ever, it's becoming important. Unfortunately, our general medical oncologists have to take care of all types of different cancers, and neuroendocrine tumors are quite rare, and they might only be taking care of 2 or 3 patients at a given time. So I think it's great, the developments and the new treatments, but again, it's always important to have a neuroendocrine tumor specialist on your team.
Yeah, highlighting the importance of seeing someone who sees a lot of neuroendocrine cancer. Mary, for someone who is newly diagnosed and suddenly entering this world, what advice would you give them about navigating all of this information without becoming too overwhelmed?
Yeah, I will say that the overwhelm part, like I discussed earlier, especially at the beginning, is really normal. So just kind of settling in with that. But one of the best ways you can put your mind at ease is what Dr. Handafar just said, is making sure that you do have a neuroendocrine specialist team that you're working with, because they're going to be able to explain that what is applies with other cancers may not apply with our cancer. It's often slower growing, and even hearing terms like stage 4, they don't carry the same meaning and the outcomes with neuroendocrine. So it's really important that you're with a specialist that can really share these important pieces with you. And then additionally, is your quality of life is definitely impacted by cancer. There's no doubt about that. But you can really impact the emotional side of the quality of life if you do have a team that you feel supported by, and family that can support you, and a support group where you're actually getting to talk to patients that are also living with the same cancer, so you don't feel alone. So all of these things I think are really important to feel supported. And we're going to talk about supportive oncology and palliative care in a moment, but I think that's also a really important piece of the puzzle.
Yeah, it's more than just treatment. It's the whole person that matters. Yeah. Well, we're going to introduce our first set of speakers. Dr. Hendifar, take it away.
Thank you. Our first presentation is Navigating an Understanding of Neuroendocrine Cancer. What should I know about my cancer? Which is presented by Dr. Udvair Graywall, a medical oncologist at Emory Winship Cancer Institute in Atlanta, Georgia. Following that, we'll hear Navigating Scans from Dr. Delphine Chen, nuclear medicine, physician and scientist, professor of radiology, and director of molecular imaging and therapy at Fred Hutch Cancer Center in Seattle, Washington.
Next, we'll transition into our first panel discussion, Navigating Supportive Care. This panel will be moderated by Dr. Dang Lee, a medical oncologist and director of the Neuroendocrine Program at the City of Hope in Duarte. And he will be joined by Dr. Banerjee, who is a palliative care physician and leader in supportive care at City of Hope, as well as Sheila Lindsay, neuroendocrine nurse practitioner at UCSF. And lastly, Victoria Ramirez, who's a licensed clinical social worker in palliative care, previously at the City of Hope and is now at USC. And this conversation will explore the many dimensions of supportive care and quality of life for those living with neuroendocrine cancer.
Hello, everyone. I am Uday Graywal. I am a GI and neuroendocrine medical oncologist here at the Winship Cancer Institute of Emory University in Atlanta, Georgia. And I will be talking about navigating an understanding of neuroendocrine cancer. What should I know about my cancer? I'm really passionate about helping patients navigate their cancer diagnosis, especially when you have a diagnosis of a cancer like neuroendocrine neoplasms or neuroendocrine tumor, something that's not often talked about. I think it's really important for you to understand some of the nuances that are critical to establishing a correct diagnosis. Before we dive into the details of the various categories that entail a diagnosis of neuroendocrine tumors, there are some core concepts that I think are really, really important for patients and caregivers to be familiar with. The most important concept is grade. And why this is really important, especially in neuroendocrine tumors, is the emphasis on grade is a lot more than some of the other more common cancers, where stage is the most important factor that is taken into consideration. So when your cancer diagnosis is first established through a biopsy specimen, our pathology colleagues, they look at it under the microscope. And what they're looking for is a proliferation index called Ki67. And what does that Ki67 really tell you is how quickly or how slowly cancer cells are proliferating when looked at under the microscope. So the higher the Ki67, the more quickly those cancer cells are proliferating. And similarly, the lower the Ki67, the more slowly those cancer cells are proliferating. So Ki67 is really important for establishing the grade of a neuroendocrine tumor. Similarly, you might hear terms like mitotic index, which are pretty similar to Ki67, and again tell you how quickly or how slowly cancer cells are proliferating when looked at under the microscope. Another core concept is differentiation. So, like I said, when you first get a biopsy, the tissue specimen is looked at under the microscope by a pathologist. And one of the other things that they're looking for is how are these cancer cells in the tumor tissue organized? If they're well organized, they're nicely put together, they form some shapes, some patterns, these are well differentiated tumors or neuroendocrine tumors. And these are also, as you would expect, better behaving. If what they see is just pure chaos, these cells are different sizes and shapes, and they don't really form an organized pattern, those are poorly differentiated neuroendocrine carcinomas. And as you would expect, these are more likely to be aggressive tumors or aggressive cancers. So the differentiation really tells you how organized or disorganized a cancer looks like under the microscope, which again gives you more information on how the behavior of this cancer will be in the clinical practice. Stage is a concept that is relatively easier for patients and caregivers to understand because how commonly this is talked about. Stage basically tells you how far a cancer has spread compared to where it originally came from. To give you an example, if there is a pancreatic neuroendocrine tumor, of course, that originated in the pancreas, if it is just limited to the pancreas, it would be stage 1 or stage 2. If the cancer has spread to lymph nodes around the pancreas, it might become stage 3. But if this cancer leaves the pancreas and goes to a faraway location, say the liver, that means the cancer is now stage 4. So basically, stage really tells you how far has a cancer spread compared to where it originally came from. And in many cases, the stage and grade, they need to be looked at together. They cannot be looked at in isolation because when we're looking at the prognosis, stage really does not tell you all of the information. It's really the grade and the stage put together that give you the accurate information that you need for getting an estimate of the prognosis associated with your neuroendocrine tumor diagnosis. After a diagnosis is made by a pathologist from a biopsy specimen, the next thing is to look at scans. And this is really important when we talk about stage. The type of scans that you get will make a huge difference in how much cancer are you able to see or appreciate on the scans. So CT scans are commonly done, MRIs are commonly done, but what I really try to emphasize in my practice is that patients should understand that not all CT scans are the same and not all MRIs are the same, especially in the setting of neuroendocrine tumors. CT scans, if they're done with a special contrast and the way the contrast is timed, that can make a world of a difference in how much cancer we're able to see or appreciate on the scans. To give you an example of the liver, this is a common site where the cancer likes to go, especially if it comes from the small bowel or pancreas. The CT scan is done with a contrast, but all we're looking at is how the contrast spreads through the veins and not really the arteries. There's a lot of cancer that we will not be able to appreciate. Now, take a look at these CT scan images on the left. In the image that is labeled as B, we see a liver that really just shows mostly normal tissue because all we have looked at is how the contrast is flowing through the veins. But if you do something called arterial phase imaging, where you actually look at how the contrast was flowing through the arteries, you can see these big bright spot in the liver that is all cancer. So how that contrast is timed and then the images that are generated based on the timing of that contrast makes a huge huge difference on how much cancer we're able to see or appreciate on the scans. Similarly, when an MRI is done, compared to a CT scan that has just looked at how the contrast is flowing through the veins, you get an MRI with a specialized dye called EOVIST, which I highly recommend getting for most of my patients. This lights up the background liver in a manner that allows us to appreciate the cancer spots much better. So this is a much more sensitive and accurate way of getting an estimate of how much cancer there is in the liver. So basically, the type of scans that you get are so critical in analyzing the actual extent and burden of the cancer, especially in organs such as the liver. Similarly, we have specialized PET scans. I'm sure most of you are familiar with scans such as gallium-68 dotatate or DOTA-TOC PET scan or copper-64 dotatate PET scans. And these have perhaps been the greatest advance as far as imaging in patients with neuroendocrine tumors is concerned. And these are the most sensitive and specific scans in terms of being able to determine the exact burden or where all the cancer has spread in the body, especially when it comes to neuroendocrine tumors love to go to the bones. CT scans and MRIs can really not as sensitively detect the spread of the cancer to the bones. And PET scans really are the best type of scan that you can get to make sure the cancer really has not spread to the bones. And in patients where I know the cancer has spread to the bones, I like to get this every so often just to make sure I'm keeping a close eye on how the cancer in the bones is really doing. So these scans serve not only a great purpose in complementing what we're seeing on the CT scans and MRIs and helping us get an accurate assessment of the spread of the cancer, they also help us identify patients who may benefit from specialized therapies that target receptors that enable us to get images on these scans. And those specialized receptors are somatostatin receptors. So patients that have cancer spots that light up on these PET scans are also ideal candidates for somatostatin analogs like octreotide or lanreotide and a targeted radiation therapy called peptide receptor radionuclide therapy or PRRT. Based on what we've understood so far, some of these core concepts such as grade and stage and differentiation, I want to highlight some of these categories that are used to put tumors into specific boxes so as to label them with a diagnosis. So tumors that come from the stomach or the small intestine or the pancreas, they're often classified based on the differentiation. Are they well differentiated or poorly differentiated? If they're well differentiated, they're called NETs or neuroendocrine tumors. If they're poorly differentiated, they're called neuroendocrine carcinomas. Within well differentiated neuroendocrine tumors, we look at the Ki-67 to then club these tumors into low grade, intermediate grade, or high grade. Low grade is Ki-67 index less than 3%, 3 to 20% is intermediate or grade 2, and anything above 20% is grade 3. Poorly differentiated neuroendocrine carcinomas are all grade 3 by definition because their Ki-67 tends to be very high, typically higher than 55%. And within neuroendocrine carcinomas or poorly differentiated neuroendocrine carcinomas, we typically have categories such as small cell or large cell type based on the appearance of these cancers under the microscope. Tumors originating from the lung and thymus are categorized slightly differently compared to tumors that come from the stomach or the small intestine or pancreas. We still look at the differentiation. Are they well differentiated tumors, are further categorized based on did we see a lot of tissue damage, something we refer to as necrosis, and was the mitotic index higher or lower? So basically, we're trying to see how quickly or slowly these tumors are proliferating under the microscope. Was there a lot of tissue damage that we saw? And based on that, we categorize them as grade 1 or typical carcinoid, grade 2 or atypical carcinoid. And if these cancers are just haphazard, poorly differentiated, they're termed as neuroendocrine carcinomas of the lung or thymus, which again, like we previously talked about, the stomach, small intestine, and pancreas cancers, these poorly differentiated neuroendocrine carcinomas can be further classified as large cell or small cell based on the appearance of these cancers under the microscope. An important thing to understand, and something that is being increasingly appreciated now, is looking at the differentiation, the Ki-67 mitotic count, These are just stepping stones to establishing a diagnosis, but they just don't tell you the full story. And the missing piece of this puzzle is adding molecular data or adding genetic information about your tumor that will give you information that is unique to the type of tumor that you carry. And my hope is that in the future, our classification systems will be revised to add some of these molecular or genetic information into the classification system. So we will be able to appreciate each tumor in a more individualized and personalized manner. To facilitate that, at least in my practice, I try to sequence almost all of my patients with a neuroendocrine neoplasm diagnosis, be it well differentiated or poorly differentiated. And the way we get it done is when the biopsy is done, we have a tissue specimen and I send it for something called NGS testing, or this is next generation sequencing. Basically, there are specialized tests that are run to look at some of the DNA and RNA changes in the tumor to see what kind of alterations are there. Are there some alterations that are usually seen in high-grade tumors, and you know for sure if the tumor has those alterations, then the biology is going to be more aggressive, the behavior is going to be more aggressive. Sometimes we may be lucky enough to find something that can actually be targeted with therapies that are either FDA approved or available on clinical trials. So there's a lot of information that you can get from molecular profiling. And what we can do with the tissue specimen is sometimes limited by what part of the tumor was captured. And so we are not able to appreciate all the genetic mutations or DNA, RNA mutations that are present in other areas of the tumor. So the way we can circumvent that issue is by getting blood-based testing, where we sample the tumor cells that are circulating in your blood and running the same tests that we ran on the tissue on these tumor cells to capture some of these mutations that we may have missed in the tissue-based testing. So when we combine the information from the tissue-based test and the blood-based test, that really gives you a full overview, a comprehensive understanding of what are the unique mutations or alterations that your cancer carries. And that gives us a lot of information about what to expect in the clinic and what to expect when we're looking at responses to different therapies. And in some patients, that may even open doors for personalized therapies because their cancer carries mutations that can be targeted with specialized therapies, either the ones that are FDA approved or yet other therapies that are available in clinical trials. Then an important question to ask is, after we've established what kind of neuroendocrine tumor or neoplasm you have based on the grade, differentiation, and stage, the next big question is, does your tumor make hormones? The most common hormone that is overproduced or hypersecreted by neuroendocrine tumors, especially small bowel neuroendocrine tumors, is serotonin. That can lead to something called carcinoid syndrome, and you may have symptoms like diarrhea, flushing, wheezing, and complications in the heart, something we refer to as carcinoid heart disease, where part of the heart valves can become fibrotic or scarred because of exposure to these hormones. Yet other patients may have other hormones that are abnormally produced that may lead to a host of different clinical symptoms and complications. So testing, or at least discussing with your doctor about the need for testing for these hormones, can be very critical, especially in the relevant clinical setting. Finally, I want to highlight the journey starts at the diagnosis, and especially making the right and accurate diagnosis is so critical and paramount. What is really critical right from the start of establishing a diagnosis to getting you on the path to the right treatments or selecting the right treatments is the involvement of a specialized multidisciplinary team. Sometimes oncologists that are closer to where you live may have more general focus and may not have a specific focus on neuroendocrine tumors. I think it's really important for you to discuss with them the need for a referral to a specialized multidisciplinary team where there's a host of different specialties like medical oncology, surgical oncology, interventional radiology or radiology, nuclear medicine, pathology. Along with these specialists, there are like nurses, registered dietitians, pharmacists, clinical trials teams, geneticists, all of these specialists that are focused on the care of patients with neuroendocrine tumors or neuroendocrine neoplasms. It's really important for you to get in touch with this team. And if you haven't already seen them, maybe discussing a referral to be seen seen by a multidisciplinary team, because these treatment decisions are so nuanced. And right from the time of establishing a correct diagnosis to then maybe exploring either currently approved therapies or clinical trials, at every step of the way, you really need input from multiple doctors to make sure we're making the absolute right choice and the absolute right decisions that are personalized to the type of cancer that you have. And it's important for you to remember that neuroendocrine tumors are not one cancer. Every tumor is different. And the decisions that we make or recommendations that we make in terms of the right treatment plan should be personalized to you and the specific type of neuroendocrine tumor that you carry. So I can't really overstate the importance of getting a specialized multidisciplinary team involved in the care of your neuroendocrine tumor. And lastly, I want to highlight that we really cannot take good care of you without our patient advocates and our patient support groups. Even though I spend a lot of time educating my patients, especially their first clinic visit or subsequent clinic visits where we're making decisions about next line of therapy and so on, even though I do my best to spend as much time as possible, I still spend a limited amount of time with my patients. And it's kind of impossible for me to discuss every little detail or nuance that is going to be relevant to the care of my patients in that short span of time. So I really rely on our fantastic patient advocates, especially at Neuroendocrine Cancer Foundation, and patient support groups to really help patients navigate right from their diagnosis for their treatment selection, getting on to clinical trials. I thank our patient advocates and patient support groups for the incredible work that they do. And I advise all of my patients to get in touch with organizations such as NCF to make sure that every step of the way they get all of the right guidance and support that they need. Thank you very much.
Hi, my name is Delphine Chen. I'm a nuclear medicine physician at Fred Hutch Cancer Center and University of Washington. And today I've been asked to talk about navigating scans. So I'd like to thank the organizers of the meeting for inviting me to present on this talk and talk about how we think about using imaging for patients with neuroendocrine tumors. So these are my disclosures. So let's start with the commonly used imaging modalities that we often order for patients with neuroendocrine tumor. I've ordered the modalities that we use based on the reason for the exam. So at the time of diagnosis, we consider things like endoscopic ultrasound to find the primary tumor, computed tomography and MRI, which people are very familiar with. Those provide us with anatomic imaging information, and potentially PET CT or PET MR, usually dotatate, and that's usually used to guide biopsy. Very infrequently, we might use FDG PET if there's a diagnostic dilemma. We also use CT, MRI, and dotatate PET for initial staging. Again, FDG very infrequently used, most commonly using dotatate PET. And then for restaging or monitoring or surveillance, again, using CT, MRI, and PET. And then we use dotatate PET for looking at treatment eligibility with PRRT or lutetium dotatate. In this talk, I'm going to focus primarily on CT, MR, and dotatate PET. So first, let's talk about computed tomography or CT. Everyone is pretty familiar with this modality as it is widely available, and it is often the modality that detects the presence of a neuroendocrine tumor. We commonly use it for treatment monitoring because we can get a good sense of the anatomic changes of the lesions. Because the liver is often a site of metastatic involvement with neuroendocrine tumor, we often get multi-phase contrast CT. Once we know that we are trying to find neuroendocrine tumor sites, we will use multi-phase contrast CT to better see those liver metastases. Additionally, as you can see, we can identify bone lesions as well, and then we use anatomic information such as the lymph node. If you see the arrow in the middle of the top axial slice right next to the spine. So it gives us really good anatomic information in addition to, as you can see, the liver metastases, the arrow on the left top image. And then in the bottom middle of the abdomen, there's a mesenteric node. And then on the right spine image, and with arrows showing sclerotic lesions, that shows where the presence of bone metastases are. The next modality we'll talk about is MRI. So with MRI, we again use multi-phase contrast exams to look at both pancreas and liver lesions. Again, the reason for that multi-phase contrast is that The neuroendocrine tumor sites are very vascular and they enhance really quickly, usually in what we call the arterial phase, which means shortly after we inject the contrast, the arteries deliver the blood flow to the neuroendocrine tumor metastases and they enhance really brightly on those early phase images or arterial phase images. So if you look at the top row on the right, that really bright spot in the middle is the contrast agent in the aorta, meaning it's in the arterial system. And then in the liver, you can see bright spots, and those are areas of enhancement that are showing that early contrast enhancement in the metastases in the liver. Delayed imaging with hepatobiliary contrast agents like Eovist actually help delineate the anatomic size and extent of the tumors really well also. So if you look in the second row on the right-hand image, that is a delayed phase image using Eovist, and it shows those dark spots. Those are the metastases. And as you can see, it shows them really well. In that second row to the left, that's an earlier phase of contrast, meaning when we do an MRI, we're getting multiple pictures as the contrast is injected. So as the contrast moves from the arteries into the organs and then into the veins, we get a number of different pictures along the journey, if you will, of the contrast agent flowing through the body. So that's why when you look at the top row, that arterial phase image that I showed you, it's again somewhat arterial phase, but it's a later arterial phase image. So now you can see that more of the agent is going through the liver and you don't see the metastases as well. And then on the right side, you can see the metastases really well because now the agent is taken up really well by the liver, not so much by the metastases. And so we get a really good look at the anatomic information. Finally, we get more biological information from diffusion-weighted imaging. So if on the bottom row on the right, you can see that there are multiple bright spots that correlate with the dark spots seen in the second row image. And so those are areas showing diffusion restriction, and that further confirms that these locations are metastases. And so MRI really gives us a nice view of the anatomic extent of liver metastases, and that you can see similar findings with pancreas lesions. Now for dotatate, we have two agents available, gallium-68 and copper-64 dotatate. These are generally considered the most sensitive for detecting well-differentiated neuroendocrine tumors. They may not detect very small liver lesions, which is why it's important to get a multi-phase CT or MRI to put together with the dotatate PET that will improve the sensitivity. And for small lesions in the bowel, when you're trying to find the actual primary lesions, sometimes intraoperative ultrasound can also be more sensitive. But dotatate PET can often be used to find those small bowel lesions as well. And so putting those imaging modalities together increases the likelihood that we can find those disease sites, particularly the primaries. Also, we use dotatate PET for determining lutetium dotatate or PRRT eligibility. And so we won't go into that in as much detail. We'll focus more on the diagnostic utilization. In terms of gallium-68 versus copper-64 dotatate, there are no published direct comparisons of the two different tracers. There is a single study that compares gallium-68 dotatalk with copper-64 dotatate. And on the right, you'll see a screen capture of a figure that was in that publication showing that there is a small bone metastasis that you can see on the copper-64 dotatate scan, which is in the middle row. But in the top row, which is the gallium-68 dotatalk scan, you don't see that lesion very well. On follow-up, so you can see the dates of the scans there, about a year and a half later, they obtained a gallium-68 dotatalk scan, and now they can see that image. So this preliminary study suggested that copper-64 dotatate was more sensitive than at least gallium-68 dotatalk. However, dotatate is the same ligand. So when you're comparing gallium-68 dotatate versus copper-64 dotatate, we are using the same peptide to target. So it's a little less clear whether there's really a difference between gallium-68 dotatate and copper-64 dotatate. So in practice, we treat them equivalently. Some of the advantages where you might want to use copper-64 dotatate over gallium-68 dotatate for specific reasons. Copper-64 has a longer half-life, so potentially we may be able to use that for dosimetry. It's also not indicated for pediatric patients because the radiation dose potentially is a little higher, although we do give a low dose for imaging. So for adults, the radiation exposure is fairly equivalent. Gallium-68 dotatate is indicated for pediatric patients, and so that's usually the preferred tracer for our pediatric patients. In terms of detecting the tumor site, so I'm going to show a few cases. This is one case where we used the dotatate PET showed very nicely that there was a rectal primary. So first on the left, you see what's called a maximum intensity projection image. So it's a whole body image. On an image display workstation, you could rotate that to get a 360 view of the images. And what you see in this particular case is that there are multiple liver metastases. And then in the pelvis, you can see several black spots. And I have focused more on those black spots in the axial images to the right of the screen. So in the top row, you can see arrows pointing to a bright spot that looks like it's in the colon. So in the very right images, you can see the CT and you can see the bowel, which is what we call serpiginous, but very curvy looking structures there. That is the bowel. And you can see that focal hot spot in there that the arrows are pointing to, and that was considered the primary site, and that is most likely the primary site given the images that we see here. Additionally, there was another black spot, that larger black spot, and on the bottom row, you can see that there are arrows pointing to that as well. And when you look on the CT images on the very right, you see a soft tissue mass with some white spots in it. That's a calcified mesenteric node, and so that further confirms that that was probably a rectal primary with a mesenteric nodal metastasis nearby. In terms of visualizing bone metastases, dotatate PET can also be very sensitive and helpful for identifying those sites. So this is a comparison with this patient actually ended up getting an FDG PET and a dotatate PET in the workup while they were trying to determine whether they had a neuroendocrine tumor or not. And on the top, you can see the dotatate PET shows a really bright spot, and that bone is called the left ischium. And you can see that focal spot that on the CT, it's very hard to see whether there's actually a lesion or not. So if you're looking at just the CT, it would be very hard to say that there was a metastases based on the CT appearance. When you look at the FDG PET, it didn't have any FDG uptake. So these imaging features together suggest that this is a site of well-differentiated neuroendocrine tumor. And so in terms of following these bone metastases, we still don't often get the dotatate PET just to follow bone metastases, especially if they're small volume, they're likely not going to cause any problems. And what we're more concerned about is liver and nodal metastases. That said, though, in some patients, when they have extensive bone metastases and they're hard to see on the dotatate PET, we may consider using the dotatate PET for surveillance in that situation. This is another example just showing the benefit of putting together the dotatate PET and contrast CT and comparing the contrast CT findings with non-contrast CT. So you can see on the top two rows show it's a contrast enhanced CT in the arterial phase. So we have obtained an image on the CT very shortly after injecting the contrast. And I have two arrows pointing to two liver lesions that we're just going to focus on. So they're very bright on that arterial phase image on the CT. So you can see that there's a lot of enhancement. On the dotatate PET, you can see there's really high uptake. And so again, confirm that there's dotatate uptake, and that does confirm that well-differentiated phenotype for the neuroendocrine tumor. On the bottom row, you can see the delayed phase image. So this is what we call the portal venous phase image on CT. You can still see those lesions, but you can see that they blend a little more into the background. And then on the right side on the bottom row, you see the non-contrast CT. In this case, you can actually still see those lesions, but oftentimes on non-contrast CT, it can be very hard to see those lesions. So in this case, you see what we call hypodense lesions on the non-contrast CT images, and that's what those two red arrows are pointing to. But if you look at the rest of the liver that you can see on the top row, there are multiple other sites where there's uptake on the dotatate, and then there's arterial enhancement. But on the bottom rows, especially in that non-contrast CT, you don't see those as well. And even on the portal venous phase, some of those aren't as easily seen as well. So that is why we like putting together the multi-phase CT and dotatate PET images. And then to compare the contrast CT with MRI, you can see that on the different contrast CTs on the two left columns, it's somewhat hard to see that lesion that we have the arrows pointing to. But on the MRI, which is on the very right side, you can see those neuroendocrine tumor sites very clearly. And so when there are a lot of liver metastases, there are advantages to potentially using MRI. If we can't see them well on CT, we can use MRI to follow the anatomic extent. Finally, this leads me into some of the reasons why we might choose a PET MR over a PET CT. So this is a PET MR case. You can see that, again, I have yellow arrows on the bottom two rows that point to the liver metastases. And even without contrast, you can see these liver metastases really well on the non-contrast MRI, and paired with the dotatate PET, we can then potentially use those to follow those as well. So non-contrast MRI is not a standard technique for doing anatomic measurements. When precise anatomic measurements are needed, you still need a contrast MRI, especially if you're using this for PRRT eligibility. This can be a nice way to see the liver metastases well on the MRI and still correlate those with the contrast CT or contrast MRI. In terms of how we think about frequency and scan selection for surveillance, because I get that question a lot, like how often should I get scans and which scan should I get to see if my tumor is progressing? So first we look at the biology. So is it a low grade, intermediate grade, or high grade? And this is just a visual illustration of how we think about how often you need to get the scan. So if you have a low grade lesion, generally we don't get them as frequently as, for example, if we have a high grade lesion. Also, if you're on treatment and you're getting active treatment and wanting to assess response, that might be another reason why you would get more frequent scans. And CT and MRI are really the core of surveillance imaging for looking at changes in known metastases and assessing treatment response. Dotatate PET is used less frequently. While we can use it potentially for functional response, that data is not solid, and so we don't commonly use that. We most often use it at the time that there's progression and we're thinking about PRRT, and that's when we would use dotatate PET once we've established the diagnosis of neuroendocrine tumor. In terms of recommendations and data, so there was a large retrospective series published by the Australian group looking at surgical resection, but there are also multiple other cooperative groups and groups that you know well, like ENETs and NANETs, that have brought experts together to try to identify what those imaging recommendations are. So I'm not going to read this all for you. You can take a look at this. The slides will be available to you, but these are some of the recommendations that have come out for what kind of imaging should be done after surgical resection. And when you have low grade with certain types like appendiceal or rectal neuroendocrine tumors, if they're completely resected, sometimes follow-up imaging is not recommended based on the recurrence rates that we see. And so just to highlight, this is just a summary of what the methods were in that particular study that published all the different recommendations from the different societies and expert groups. But the single most important factor that drove the follow-up decision imaging selection was histologic grade. So this really plays into how we decide which imaging should we do and how frequently. And finally, a word of caution when looking at and interpreting dotatate PET scans on patients who have been started on a somatostatin analog. Sometimes we can see what is called pseudo-progression after starting a somatostatin analog. What I mean by that is, generally, when you get your first dotatate PET at the time that they're either diagnosing your neuroendocrine tumor or they're performing initial staging, usually those patients have not been started on a somatostatin analog. Once they've determined what type of neuroendocrine tumor there is, they'll follow them by CT, but in the interim, they may have started a somatostatin analog for disease control. Then the dotatate PET is obtained to confirm. The typical scenario is there's some concern about progression on the CT or MRI, so they obtain a dotatate PET to get a better picture of the full extent of disease and confirm whether there's progression or not. But then now this dotatate PET has been obtained after the patient has been started on a somatostatin analog. What a somatostatin analog does is that it decreases the background activity within the spleen and livers. So if you see the thick red arrow on both scans that's pointing to the spleen, you can see on the post-SSA image that it's less black, and that is because of the presence of the somatostatin analog. And so because it decreases that background, you can see an increase in the uptake intensity in tumor sites. And so some tumor sites that were seen on the prior scan are now visible. You can see the green arrows pointing to a lesion up in the upper chest. You can see that that uptake intensity is increased. And then if you look at the lower part of the image, so you can see that black spot on the post-SSA image at the very bottom, that's the urinary bladder, and you can see several spots in the pelvis just above it. You can see more of them than you could see on the baseline scan. And this is a frequent phenomenon that we see on patients who are getting their first dotatate scan on somatostatin analog. So it's just something to be aware of, that when we see this, we don't necessarily call that progression, because those sites might have been present before, but it was just that because we didn't have the benefit of the somatostatin analogs decreasing the background, we could now see those tumors better. But I'm going to now start summarizing how we think about cross-sectional imaging at Fred Hutch. So CT, as I said, is the mainstay for imaging the gastroenteropancreatic neuroendocrine tumors. We use MRI if there are liver metastases. Those are usually the modalities we use to determine whether there's progression or whether there's treatment response. And then dotatate PET we use primarily for initial staging. We use it at the time of progression to characterize the full disease extent and to confirm how much progression or if progression has occurred. Again, looking at PRT or lutetium dotatate treatment eligibility. And then we may use it to characterize sites if we're having a difficult time determining whether something is a neuroendocrine tumor, or if we are trying to figure out where to biopsy, we might use dotatate PET then. And then we do prefer PET-MR if liver metastases are present, but that's not a hard and fast recommendation. If you have PET-CT with an MRI or with a good multi-phase contrast CT, that can also be sufficient. And then finally, just reorganizing when to use each modality. CT and MRI and dotatate PET are often used at initial staging. Surveillance, again, CT and MRI primarily, and then dotatate PET at time of progression. So thanks so much again for the opportunity to talk about how we use imaging. I'd like to acknowledge our multidisciplinary team. Dr. Jen and I and Dr. Iravani led our neuroendocrine tumor program. And then we have a robust nuclear medicine technologist and coordinator team, as well as our nuclear medicine. And on our oncologists, our interventional radiologists, led by Dr. Grace Laidlaw, and our surgical oncology and endocrinology teams. So thank you.
Welcome, everyone. So in our next session, we're going to be really discussing how to navigate supportive care. I think this is a very important topic, as for many of our patients with neuroendocrine tumors, it's truly a lifelong journey. And throughout the journey process, you're going to need a lot of help, whether it's physically, emotionally, psychologically. All of that plays a pivotal role in terms of getting the best quality of life as well as outcomes while you're going through the treatment journey. So for this session, I'm joined by several of my colleagues. My name is Dr. Danae Lee. I'm a GI medical oncologist at City of Hope Comprehensive Cancer Center, and I'll let each of my esteemed colleagues introduce themselves. So I'll start with Dr. Banerjee.
Hi, I'm Dr. Banerjee. I'm an associate professor at City of Hope National Medical Center. I specifically work with palliative care and also do a lot of end-of-life and hospice care. Nice to meet you all.
Wonderful, welcome. And next we'll go to Sheila.
Hi, my name is Sheila Lindsay. I'm a nurse practitioner. I work at UCSF Medical Center in the Neuroendocrine Center for Excellence there. I work with several colleagues at UCSF and help to navigate the patients through their journey. And I'm super excited to be here, so thank you.
Yeah, thanks for joining us. And lastly, Victoria.
Hi, yes, my name is Victoria Ramirez. I'm a licensed clinical social worker. I also have advanced certification in hospice and palliative care. I have about 12 years of experience as a social worker working with oncology patients, and I'm very glad to be here. Thank you.
Welcome to you as well. So I think we're going to just jump in right into the session. So as I mentioned, for many patients with neuroendocrine tumors, it's really a complex and long journey. And I think while you're going through this journey, partly, I think one of the biggest challenges is really navigating this uncertainty, right? How do you cope with the diagnosis of having neuroendocrine tumor, fears about potentially its prognosis, really kind of addressing the question of how long do I have to live with this disease? And then potentially it could be a long journey. You're going to be getting a lot of tests as well as scans, and there's kind of this phenomenon of scanxiety. So really focusing on this broad topic of supportive care, supporting patients in their journey and navigating them through uncertainty. I guess, what are your pieces of advice in terms of how they should go about it, and potentially what services have you seen been used to effectively help them navigate this type of uncertainty? So I'll start with you, Dr. Banerjee.
Thank you. This is such an important topic, and it's so important for patients, and not just patients, but I think their caregivers. I think it impacts the entire family when someone has cancer, and especially with something like neuroendocrine tumor, as you said. Navigating is one of the hardest challenges. So my advice always is really get palliative care involved early. Many people wait too long to get palliative care services on board, being whether it's the stigma that palliative care is something that's only to be used when things are going bad. But the fact is that palliative care is that glue that involves really interdisciplinary teams. It involves social workers, nurses. It involves really the oncologists working together and really making sure that the patient's disease is managed, but also their quality of life remains while they're navigating this journey. Palliative care, also really brought on early, is an excellent source for caregivers. We know that the patients impacted with neuroendocrine tumor, the caregiver burden is also extremely high. And if caregiving is not addressed while patient care is, that might be impactful in a negative way for the patient's journey overall. So I say get the service on early, talk to your oncologist so that they can refer you to palliative care early. And then when you are referred to palliative care, I think don't be afraid to ask the difficult questions.
Yeah, I think that's, so true and really helpful. I think oftentimes patients may, perceive palliative care as end of life. And I think we have to try to reframe that and everything. And, being able to have our supportive care services certainly have, many of our patients, throughout their journey. So I'll go to, you, Sheila, like, you guys have an amazing program at UCSF, with wonderful colleagues and everything. How have you seen different ways supportive care services have been able to help, maybe in your practice, to help patients navigate kind of this idea of uncertainty with their diagnosis as well as tests?
Yeah, I 100% echo what Dr. Banerjee had just said about early implementation and bringing in palliative care early on. It may be that the patient at that moment doesn't have a lot of symptoms, but this is a long journey for a lot of our patients, and navigating the psychosocial aspects of things, I think palliative care does a very, very good job of that. I find that there's often this stigma of palliative care means end of life. And I kind of turn it on its head. I like the analogy of it's the umbrella, not the rain. And it's important to have that umbrella before it starts raining. And it's kind of a tool in our toolbox. I also think navigating this and having like psycho-oncology or psychiatry, if that's needed, they've been very, very helpful for our patients in navigating this uncertainty and this possible longer journey than other cancer patients. This is also kind of a rare tumor out there, right? And it can be a little bit isolating for patients. And I do think neuroendocrine tumors are a little bit unique in their patient advocacy and community support that they can have as well. And so I like to try to investigate for my patients, are they interested in that? And can I kind of hook them up with somebody who's going through something similar, a peer? So I think peer support helps as well.
Yeah, thank you for those wonderful insights. I absolutely agree. I think patient advocacy has been able to help some of our patients with their anxiety and everything and how to manage that. I think that's a really good point. I'll move to you, Victoria. I think we've been talking about, maybe how patients face, anxiety or uncertainty and trying to navigate it. But, one of the things that also comes up is certainly their caregivers, family, friends. So it's kind of this idea of, how do you navigate relationships with this diagnosis? Like, should you disclose to your friends and family, particularly, especially if you have children? How has your clinical practice, what have you seen in terms of supportive care services, whether it's social work or others, how have they been able to maybe help to navigate relationships for the patient as they go through this diagnosis?
Yeah, definitely great question. And I think it ties into what Sheila was just saying about advocacy. And I think one of the biggest important things for patients and caregivers is to advocate for themselves. But I do see that need where you need other people to help advocate for you as well. Because it's a lot, on patients, they're going through the symptoms. It's a lot of things to remember. Dr. Banerjee mentioned, caregivers have that burden as well. So anybody extra that's supportive, I've seen neighbors, siblings, anybody that is close enough. And sometimes it's people that you wouldn't necessarily think are as the closest to you end up being the people that have been helpful. So you mentioned children, if you're going through this treatment, you have children at school. Sometimes, other parents have been helpful with drop-offs, pickups, asking for that help or being open, which can be difficult. But I do know there's a lot of forums as well, to kind of organize those around you. I think Caring Bridge, or there's, I think, a couple of other ones that we've talked about in support group, just to kind of help give others an idea of what you might need. But that can be very difficult because sometimes people want to help and they don't know exactly how they can help. But with social work, I think what we try to do is, have those conversations with patients and caregivers to see what ideas can we help with providing, or what communication do they need bridged? Is that, difficulty with communication with family members, with relatives? Sometimes it's with, when you're in the hospital, there's a lot of people on the team. So we've also done family meetings and different things like that. But I think, just trying to tie together and connect you with those resources, I think is where we might be able to help.
Yeah, no, so certainly. And Dr. Banerjee, I know you've been a little bit involved in kind of this area, for focusing on kind of the caregiver and everything. Like, what are some of the things that you've seen, kind of through your focus and everything that might be able to help them in terms of kind of navigating this, relationship with the diagnosis?
Yeah, so actually, Victoria and I are involved in that, and we work with Neuroendocrine Cancer Foundation. We actually lead a support group for caregivers once a month. I'll tell you this, that more and more I find that caregivers are as scared as patients are. I see that more and more. They may not voice it because obviously they have to be strong for the patient, but as you get deeper into working with caregivers and really engaging them in the caregiving, we find that they have similar fears. They have anticipated grief. They really are navigating not just the patient's health and wellness, but they're navigating multiple other people in their families. If it's a mom, it's the kids. How do you keep everything in balance? So I often find that if you engage caregivers early in patient care, and you develop that relationship for the patient as a caregiver, not just a spouse, set boundaries and create a healthy caregiving relationship, often things are much more balanced for the patient and the caregiver. Caregivers get thrown into the situation. You don't decide that tomorrow I'm going to be a caregiver for someone with neuroendocrine tumor. So I think them being thrown in the situation along with the patient really leads to a lot of concerns with just caregiver stress, patient stress, just the burden for the patient and the caregiver, not only with the disease, but also in their relationship. So it's really important to talk to them together, but also talk to them individually so that you can really pull out aspects of this disease and this journey that might be a hindrance or barrier to the overall well-being and care of the patient as well as the family. I think that's in the best interest. Often we leave caregivers out until the very last minute, or patients may not want to involve the caregivers due to the psychological impact. But I think it's important to also stress to patients that this is one of those tumors where having caregivers and having support is going to be extremely important for the journey.
I absolutely agree with that. I think, it's so important. I always tell my patients that their survival is probably not dependent on maybe the treatment that I give them. It's actually the level of support that they have from their closest, family members. Because I really see that those patients that have a really good support system oftentimes, do the best in that sense. So thank you for that point. So, I think we'll switch to kind of the next topic that, oftentimes patients encounter. These patients, like you have all alluded, are maybe connected through patient advocacy or other programs. So they seek out multiple different types of opinions. So they can go across the entire country, get different opinions from top academic centers. But something that kind of comes along with getting kind of these second opinions is that oftentimes these opinions will be very different in terms of what's the ideal management, because there might not be necessarily concrete guidelines on the next step. So, Sheila, in your practice, I'm sure you guys see a lot of patients for second opinions or third opinions, or they go to other places, they come back to you. How do you help them, potentially navigate kind of the confusion and the stress that, kind of comes potentially with these different opinions that they might get regarding their diagnosis and treatment?
Yeah, I think this is a super important topic, particularly for this tumor type. There's no easy way, I think, to get through it, but I think there are multiple tools that can help for patients. One is to encourage it. If we're the primary oncology team or primary treating team, but the patient is interested in seeing other people, I want them to feel open to ask the question or get a recommendation. And I think that alone can take a little bit of that stress off for patients and their family or caregivers. So that's step number one. I think also important is to help them sort of figure out how to get out of analysis paralysis. You can have multiple opinions and really get stuck in the weeds. And there's not oftentimes the right or wrong choice. It's the right choice for them in that moment. And one other thing that I think can help is to just kind of let them know that you just have to, in this moment right now, none of us can predict the future, but right now, what is the best decision for you? And we'll help navigate that decision for you. So I think those kind of approaches for patients can just sort of take the edge off, if you will, of the anxiety that can come with these conflicting or multiple opinions.
Yeah, thank you so much for that, insight. Victoria, I would say, maybe go one step further for this in the sense that a lot of times after a patient gets a second or a third opinion, they might actually be upset with their primary physician who provided the initial opinion. So then they might actually, file a complaint against them and say, like, why did he make this recommendation? Like when these other doctors had said, other things and everything. And am I really getting kind of the best care possible? So from the social work side, I'm sure you're involved when, kind of these complaints come in from the patient, and certainly there's distress on their end and everything. How do you help them to potentially navigate this distress, but maybe help to also retain that physician and patient relationship for these patients? Because oftentimes they'll still want to be treated by the same initial physician. They're just upset about this differences in opinion that they've been provided.
What I've done before is we're oftentimes, one of the first people that they're talking to about this. And so I definitely listen. And I think that's such an important thing for patients and caregivers both to be heard. And so I think, having somebody to let kind of ventilate those feelings about, I'm confused about this. I'll ask them, okay, tell me more about that. What was your experience, talking with this person versus talking with that person? And sometimes along the lines, what I've seen recently was, like, would you like to have a conversation? And they kind of are, oh, you know what? Actually, now that I think about it, yeah, I would like to have a conversation and maybe I could ask those questions, because I'll ask them, what are your specific questions that you're confused about or things that you'd like to talk more about? It depends on the presentation. If sometimes you do get patients or, family members that do still want to go that extra step after having a conversation, and I will let them know, hey, well, this is one thing we can talk to the patient advocate, or, this is kind of how you can file a grievance if that's something that they're still not happy about. But I think the first step for me is kind of asking them more about the situation. And I do find a lot of the times that talking about what their experience has been and having a place to do that and having that heard and accepted really helps. And then bridging that, okay, maybe we can address that. And then I will let the provider know, hey, I spoke with this patient. They have these questions or concerns. Maybe we can address them at the next meeting or their next appointment. And so by that time, I think once they've had that time to kind of get that off their mind, they're able to have a conversation and kind of ask those extra questions that maybe they weren't aware of, that communication behind the scenes or whatever it might be. It ends up being a good conversation.
Yeah, I think open dialogue is really important here, as you highlighted. I think acknowledging the distress and then having an open dialogue is really pivotal, because I think as Sheila mentioned, oftentimes there is no right answer, right, and everything. So I don't think in most cases no one's doing anything incorrectly and everything. So it's not a situation in that sense. So I think those are things to kind of keep in mind and have an open dialogue. I always tell patients, like, if we're not the best fit, then let's see if we can find someone who might be the best fit for you to take care of you, because we truly want the best, for you. I think, one of the other very important topics that, we should discuss is, kind of personal values and goals. So patients individually might have different values in terms of what they want to get from their treatment and their overall goals. So Dr. Banerjee, how do you go about really have the patient kind of express this, especially if their goals might differ compared to some of their goals of their caregivers or their family members and everything? And how do you make sure that, whatever we do for the patient is really aligned with potentially what they would want?
Yeah, that's really important, especially with neuroendocrine tumor, which, as we know, can have a different trajectory for various patients, right? I think the first thing is building trust and honesty between the providers and the patients and caregivers. If that trust is not built, and often palliative care is a great way to build that trust early on, it's going to be very difficult to get the patient to express really what they want or what the frustrations are at this point in the disease process. I think one of the most important things is to be transparent with the patient and the family about the disease itself and every symptom and every progression along the way. I think if patients don't have that knowledge, it's hard for them to make decisions for themselves. So transparency in really what this disease looks like, what their particular neuroendocrine tumor looks like, perhaps discussing symptom burden, discussing the various treatments is important. Once you have that trust and once you have the patient understanding what their disease actually means and what it would look like as it progresses, I think that's when you can start discussing what quality of life is for them, what do they want out of the treatments, at what point do they consider symptom burden too high, what is it that they need in their day-to-day to make sure that the treatments are going well. Many times we forget that treatments might be readily available or offered, but sometimes patients have very different situations at home that may not allow for them to get the best treatments possible. What are the barriers at home that are preventing patients from really getting their treatments? Are they not considering various modalities, or when the disease has progressed a lot, are they not considering hospice or even something like DNR because they have children that they're afraid for? So I think there are so many multifactorial issues that really are dependent on what the patient is seeking and what the patient might actually want for themselves. I think if we don't do a holistic assessment of what the patient wants and needs, as well as the environment, that is going to be the most challenging aspect of getting to the core of what the patient wants in their journey and in their goals ultimately for this disease.
Yeah, I think that's so important to kind of keep those, kind of their goals in mind and everything, and what we are trying to do for them through everything that we're offering. And Sheila, I think I'll end with you here in the sense that whenever there's a time when, a patient has to make a decision kind of during their treatment course, oftentimes what they're asking is, what is the best treatment, for me at this period in time, especially as we discuss when there's a lot of uncertainty in terms of not necessarily having one correct answer. What have you seen in your clinical practice in terms of helping patients feel like they are making the best decision for them at that time, while keeping in mind what Dr. Banerjee had said in terms of their ultimately their goals and preferences as well?
Yeah, so I think the rapport is crucial, right? So that the patients feel like they can ask that question to their care team. So, and hopefully over time, we've built that rapport so they do feel they can ask that question and be open and honest. And oftentimes when we're making these treatment decisions, or we're at a point where kind of a turning point, or other modalities need to be considered, could be a glimmer of an opening to discuss or bring up and readdress their goals of care. And I often kind of take that moment to just ask that direct question as far as what's important to them. Just a very open-ended question, because one treatment option or another may align with that a little bit better than another treatment option. And so I kind of feel like that's a window or an opportunity or a door, whatever metaphor you want to use there, to kind of get back to the heart of what the patient really wants and what is most important for them. And that, I think, can be that sort of North Star for a treatment choice that might be good for that patient in that moment.
Yeah, I think that's an amazing point. I think getting to the heart of everything is, really crucial for all of our patients. So I want to thank all the panelists again, for joining me for this, amazing discussion that we're having in terms of navigating supportive care to all the neuroendocrine tumor patients. I think we can all agree that you're not alone in this and everything. There's certainly a lot of support out there from all of us, whether it's social work, nurse practitioners, the medical team themselves and everything. So really take advantage of that support and everything, because we can help with addressing a lot of the uncertainties that you may have as you go through your diagnosis and ultimately throughout your treatment journey. So thank you, everyone, and look forward to seeing everyone soon.
Thank you.
Thank you.
Thanks.
Thank you, Dr. Graywall and Dr. Chen, for those insightful presentations, and thank you to Dr. Lee and the supportive care panel for such an important and compassionate discussion. In this next section, we're going to focus on navigating surgery and local regional therapies. Mary, I'd like to hear from you. One thing patients quickly learn is that expertise matters, as you highlighted in our previous discussion. How important is it to seek specialists who truly understand neuroendocrine cancer?
I mean, I would say there's literally no more valuable piece of advice that I can give. It's the most shared recommendation I give to any patient I ever come in contact with in our net world. And you can love and trust your local oncologist, and they can still be part of your team. For instance, maybe doing the monthly injections or labs, but you need a neuroendocrine cancer specialist on your team. It's such a unique cancer, and the standard diagnostic tools and treatments just don't always apply. I mean, I've talked to patients that have had needless surgeries and or treatments, and if their doctor was well-versed in neuroendocrine, they would have known that that wasn't necessary, or even patients that haven't received surgery when that would have been their best course of action. So I really believe that, in my experience, the long-term outcomes and quality of life for patients are much improved when they have a neuroendocrine specialist as part of their care team. And that's one of the reasons I feel very lucky to have Cedars-Sinai and Dr. Hendafar on my team.
It's clear it's important to you. Thank you, Mary. Dr. Hendafar, I love that in our previous discussion, you highlighted how the changing landscape has also changed the members on the team that's taking care of patients. So patients are often told that they need a multidisciplinary team, but they may not know what this word means or how to find one. Can you further expand on what this word multidisciplinary means, and how do patients find multidisciplinary neuroendocrine cancer care?
It's really it's an organization of specialists who focus on neuroendocrine tumors, and it's a back and forth dialogue. And currently, most of the teams that exist dialogue in an organized way with a tumor board. But they don't have to use a tumor board. It can almost be, people who talk to each other regularly. If you have a surgeon, an oncologist, radiologist, nuclear medicine, if you're talking together and going back and forth, discussing the peculiar characteristics of a case, offering your expertise to the rest of the group so the best decision can be made, that's what I think of as a multidisciplinary team. In the modern sense, it usually revolves around a tumor board, which is an organized time of day where cases are discussed, pathology is reviewed, imaging is gone over, and all of the members of the team are present and offer their input onto the case in order to help make the right decision for the patient. Now, without all the team's input, you could overlook expertise or unique aspects of the case that a certain professional would bring. So therefore, right now, most of the major centers that treat neuroendocrine tumors do have an organized tumor board, although it's probably not necessary to have a team, but a tumor board is probably the best way to get a team together and to get actually, document what the recommendation is so that everyone in the organization on the team can see it, and to make sure the patient's care is going forward appropriately.
Thank you so much for your explanation. And now we're going to introduce our next set of speakers.
Yeah, before we begin with our next medical presenters, we're going to hear from a special neuroendocrine patient and caregiver from Sarah and Quentin, and who were recently married.
Next, we'll hear Navigating Surgery, presented by Dr. Julie Halle, surgical oncologist at Odette Cancer Center, Sunnybrook Health Sciences Center, and associate professor of surgery at the University of Toronto. Following that is Navigating Liver-Directed Therapy, presented by Dr. Michael Solon, who's the Director of Interventional Oncology at the Abramson Cancer Center and Professor of Radiology at the University of Pennsylvania.
Hi, my name is Sarah Caffelli.
My name is Quentin Brenner.
It's my husband and also my partner and caregiver throughout my NETS journey. To give you a little background, I was diagnosed with small bowel neuroendocrine cancer April 2024. It was found incidentally. I had a uterine fibroid that had been growing for the past 5 or 6 years, and I needed to get it removed. The surgeon at Duke said, okay, let's do a MRI, let's do a body scan to make sure everything else is okay. And that led to them finding a swollen lymph node near my ovary. And then that led to a PET scan, which then led to a liver biopsy. And then from there, it's just been a snowball effect. Yeah, roughly 30% of neuroendocrine patients have carcinoid symptoms. And I thought for me, oh, this is happening because I'm getting older in age. But, if any little blip, if you get redness, if you get whatever, just go to your doctor immediately. Unfortunately, I did neglect the doctor a little bit. But yeah, if you feel anything, I think the carcinoid symptoms should have been my warning sign, should have been my wake-up call, because unfortunately, some neuroendocrine patients can go even longer. And so since my diagnosis from April 2024, I immediately, my mom got me in touch with Lisa Yen, who's amazing, through NCF, and with Lisa's amazing connections, and through NCF, I got surgery with Dr. Boudreau in New Orleans in November 2024. He removed part of my small bowel. They found 35 tumors there. They removed my ovary because there was a tumor there. I had a partial hysterectomy, and then they removed my uterus, and then they removed half my liver, appendix, gallbladder. That surgery was 6 hours. I was in the hospital for around 8 days. July 2025, Dr. Boudreau did the second part of my surgery, where he removed 17 tumors that were sitting on my liver. Luckily, those were all grade 1. I'm technically grade 2 because the second half of my liver was less than 3%. But yeah, and ever since then, I've been on lanreotide. I think I've had 25 shots at this point. No real side effects from that. The only thing is that I'm on Creon right now, which has taken a bit to get used to, but I feel like I'm in really great shape. I've probably been in the best shape since college. Dealing with stage 4 cancer can be scary, especially this past week I had scans, and I was telling Quentin, my husband, that does make me feel like a cancer patient when I get these scans, but just having an amazing support system and just my family, friends, NCF, all these resources really bounces me back and makes me even more resilient to keep marching forward.
I guess coming from a caregiver perspective, I was obviously there for Sarah for both of her surgeries and stayed with her in the hospital. I think, it's just playing into the strengths that you have as a person and as your personality, identifying that and leveraging that as your caregiver role. For me, I think then what I sort of reiterated in our vows when we got married was I like to sort of bring a sense of levity and lightness to a lot of these kind of hard to deal with situations. I think it helps Sarah kind of just deal with not the best news all the time. You're not always guaranteed to get the best news every time you go to a doctor visit. It helps her prepare for what might someday be not good news, but most of the time it is good news that you get.
Yeah, and another thing to add was that, when I was first diagnosed, they said I was inoperable. I'm seen locally at Duke for my shots and blood work, but then I got a second opinion with Dr. Wolin in New York, and then ultimately through Lisa Jens and the NCF group, they put me right in touch with Dr. Boudreau, and I probably wouldn't be here today if it wasn't for that. To have that such warm, welcoming community has really saved my life, to be honest. And being told I wasn't operable was scary, but having a surgeon like Dr. Boudreau who took me on and made me feel hopeful for the first time in a while. It is very scary at first to hear you have stage 4 cancer, but knowing that it's neuroendocrine and the more research that we did into it, even if it's grade 3, from my understanding that it's still slow growing, and using whatever resources that you have available to you, just take advantage of it. Speak to as many people as you can. Really, really urge you to go to the group, join the meetings if you can. I try to join every Wednesday, even if I don't have anything to contribute. I just want to listen and help people if I can, because it's not an easy thing. I never thought I'd be going through this in my 30s, and especially I didn't think Quentin would either, but it's making life interesting. And since the diagnosis, we got engaged, and then we also got married in Amsterdam, Netherlands, 3 weeks ago. So for me, that was just a really, really great thing to keep me going, the past 2 years, and just makes me really hopeful for the future, even though really sometimes it can be really scary to think about my future. In addition to planning our wedding for the past year and a half, I think it's also really important to maybe plan out little staycations or little weekend trips, maybe every 3 months. I just think having something fun on the horizon will also really help you be more motivated and hopeful for the future. Just have a support system ready by your side, have people go with you to the appointments, and also for them to have your MyChart logins is really helpful too, because for me, I don't like looking at my scans. And so yeah, just having a support system from the start really is very helpful.
Hi everyone, my name is Juliella and I'm a surgical oncologist and associate professor of surgery at Sunnybrook Health Sciences Center at the University of Toronto, and I specialize in the care of patients with neuroendocrine neoplasms. Today I was asked to talk to you about how to navigate surgery for neuroendocrine tumors, and so what I'll do is really take an overview of surgical care. We're not really going to go into the specific details of each types of procedure because there's so many different types of procedure here that would actually take an entire day of conference to do. I'll start by saying that one of the important things when we talk about why do surgery in neuroendocrine tumors is that we need to understand we're dealing with a chronic cancer. In a lot of cancer care, we tend to want to approach it as a sprint. We want to outrun the malignancy so that we can cut it short and get it to stop immediately. In neuroendocrine tumors, we know that we're facing more of a marathon, where people, like some of you, even with active disease, will go on to live for years with that disease. Much like some people have diabetes or hypertension, and we need to make sure that we use our therapeutic tools in a way that allows us to run that marathon for the longest time possible. And so the first question I'll address here is whether surgery is right for you. And for that, we'll try to understand why we do surgery and how we think about that decision. To me, there's kind of 3 main buckets here in terms of the types of disease that we'll treat with surgery. The first one is we're dealing with local regional disease. So that means tumors that are still confined to the original organ, sometimes maybe to the lymph nodes. But in that setting, what we want to do is really aim for a cure to completely remove the tumor. Then in the metastatic setting, once the tumor has spread to other organs, we're not able necessarily to cure anymore, but we may want to use surgery for long-term control. And then finally, in those that already had treatments and either have progression of their disease or the disease is coming back after being eradicated the first time, we can consider surgery again down the road. And we'll go a little bit deeper into those topics. But what I wanted you to understand here is really that we can consider surgery across the full spectrum of neuroendocrine tumor diseases. And so it's important that the role of surgery be reassessed at each of the key time points in your care journey. And how do we make that decision? Well, as you know, there's as many types of neuroendocrine tumors as there are stripes on a zebra, and that really depends on the type of tumor we're dealing with. So we'll look at what's the primary tumor site, like pancreas primary, small bowel primary, gastric, or rectal are completely different approaches. We'll look at the extent of disease, again, whether it's confined to the original organ or is metastatic. And even in metastatic, how many metastases sites, how many tumors do we have? We'll look at how that is impacting your life and your symptoms. We'll look at how aggressive the tumor is, looking at the grade, some genomic alterations, and also some clue that we can get from functional imaging. That's this infamous PET scan. And then we'll balance all of that where you're coming from as a patient with neuroendocrine tumors and what your goals and priorities are. So lots to take into consideration here. That's why every decision has to be tailored to the tumor and to you. And the good news is when we're able to do that, after surgery, patient can go on to live a very long life. So those are numbers that were put together by Léa-Marie Meloche-Dumas, who's a fellow with us in Toronto right now and is going on to start practice in neuroendocrine tumors in Montreal. And what we looked at is amongst all patients in Ontario who had surgery for neuroendocrine tumors, and that's thousands of people over about 10 years. And if we take everybody, so all tumor types, all extent of diseases together, the 5-year survival is 82% and a 10-year survival is 66%. That means 66% of people still alive 10 years after their first surgery. That may look different for every person, but that's an excellent number. And what's important to realize here is when we have such a long survival for people that have tumors, there's a high likelihood of dying from things other than the cancer. In fact, when Léa-Marie looked at this, we have 44% of death over 10 years after surgery for neuroendocrine tumors that are not related to cancer. So I think this is important to understand so that we make sure that a therapy we give with surgery is not more toxic than the cancer itself, because people are going to live for a long time. And so that's why the first thing I want to talk about whether surgery is right for you is that sometimes surgery is just not needed. There's a few scenarios that I'll cover quickly. The first one is folks with small pancreas neuroendocrine tumors, so less than 2 centimeter, that are non-functional. By now, that we mean that have no hormonal secretion, and that are not a genetic syndrome, so not MEN or VHL or things like that. Those tumors can be safely watched, and this is information we got from over 1,000 patients that were monitored with small pancreas neuroendocrine tumors. A few were operated. That was a decision made by the treating team at the time. And what happened is we realized that there's actually no real benefit to operating and that there's high risk for harms. So what this means is to harm one person with this type of tumor with an operation, we had to operate on 6 people. So for every 6 people operated, one gets harmed with complications that maybe were not needed. And there is no true benefit. So in order to prevent one person from having a progression, we had to operate on 285 people. And so that's exposed a lot of people to harm without necessarily benefits. So in that setting, those tumors can now safely be observed. So all very grateful to Stefano Partelli's team in Italy for running this trial and bringing us these data. Other similar scenarios are some very specific types of gastric neuroendocrine tumors, small duodenum nets and small rectum nets. Again, that's not for everybody, but in specific circumstances with good features, surgery may not be needed, and that's important to understand. Now, the second question is, what are we really trying to accomplish with surgery? And I hope that that can help you navigate the decision-making a little. So like we talked about at the very beginning, the intent depends on what we're treating. In local regional disease, so limited to the original organ and the lymph nodes, we intend to cure or to eradicate the tumor completely. In metastatic disease that has spread beyond the original organ, we're not curing the cancer anymore, but we can control it for a very long time. And so those are different mindsets that bring different surgical treatments. When the intent is to cure, what we want to do is remove all the visible disease to eliminate the cancer that we can see and that we can feel. That's often the case when we're looking at small bowel or pancreas neuroendocrine tumors that are limited to the original organ. We can do this if we're able to remove all the tumors without impacting vital structures that are necessary for life. That can reasonably control the cancer, so it has to be cancers with good what we call biology, so that are not too aggressive and the surgery can reasonably control. And then finally, we have to have a balance with potential harms from the operation and make sure that you can fare well with the surgery from a medical perspective. And when we do this, the way that we operate for these tumors is completely different than in other types of cancers. So we want to forget about the typical resections we do for those cancers and get into a sparing mindset that we call mesenteric sparing. And this means that sometimes for small bowel neuroendocrine tumors, we have to get very close to the tumor. We cannot get wide margins, and we do it on purpose so that we can spare intestine for you, for your function now and later when the tumor may come back and necessitate other treatments. What does that mean? Well, I like the toppings on the pizza, but I don't really like the crust. And so that's where this analogy comes from. What we really want to do when we're operating small bowel neuroendocrine tumors with lymph nodes is we want to get as many of the lymph nodes as possible. So that's the toppings here, those tomato and olives. And we want to get as little of the crust as possible to maintain the length of the intestine and maintain function for quality of life and then for the potential for other treatments. What this looks like is, for instance, in this case, like what is in yellow here is the typical resection we often do, and that's okay in most instances. What we want to avoid is in folks that have very, very large nodal masses, so like a lot of toppings in one area here, we don't want to resect the typical way because then we would end up resecting too much intestine. We want to do something a little bit more tailored like we have here in the green so that we get as much toppings as possible without getting too much of the crust. And so this is how I think about this. This mesentery sparing resection is really tailored to how this tumor behaves and the spread and the pattern of the tumor. So we remove only the nodes that are needed or that are at risk of creating trouble in the future for you, and we spare the length of the intestine as much as possible. So again, a different mindset than what we do for other diseases. Then when we look at the flip side, so metastatic disease, the goals of therapy change to controlling the tumor. So we want to control the amount of tumor, the volume, the amount of hormone, the endocrine activity, and prevent complications from just a tumor sitting there. We do that because if we use surgery in that way, we can delay the time for your next line of therapy. So we can make it so that the therapies you're on right now can work for longer and that you don't need to jump to another line right now. We're sparing options for the future. And this is in particular with the somatostatin analogs, the infamous shot, so either LAR or lanreotide. If we can reduce the volume of tumor, these therapies tend to work better. So even removing the majority of the tumor, even if we cannot remove everything, can help prolong the options for you. What I'm trying to say here is surgery still has a role even when we cannot cure. Because we cannot cure doesn't mean it's not worth doing. We know this is a disease that eventually is going to progress. So we want to buy time between the times where there's going to be progression. We know that surgery can also relieve symptoms right away in about 96% of cases, in particular with liver metastases. And we want to preserve options for the future so you still have ammunitions to run your marathon for as long as possible. And again, here, what we do is different than in other types of tumor. So we want to avoid the typical traditional liver cancer surgeries where we take big chunks of liver and do something more tailored where we go and enucleate each of the tumor sites. The reason is that even when we think we got it all with a really big liver surgery, there is always more. There's some pathology studies saying there's always 100% more metastases than we would think. And what this look like is something like this. What you see on the panels on the left-hand side is what a typical surgery would be, which would really sacrifice a lot of liver. Whereas on the right-hand side, you have what we would do for neuroendocrine tumors with enucleation of one tumor at a time. And with that, we want to aim to resect about 70% of all the tumors to provide good control. And then with the intent to control, we're also looking at the primary tumor. There's some instances that even when the metastases or the spread to other organs cannot be operated, we will go and operate on the small intestine. And that is to relieve symptoms and prevent future problems from the fibrosis from the tumor. So when we operate on those, in 80% of instances, we see symptom relief for folks. And then we also know that if we do that early on, we can prevent future unnecessary hospitalization or the need for other surgeries in the urgent setting. That is a bit different in the pancreas. There can be a role to remove the primary tumor even in the setting of metastases that cannot be removed, but that is much more limited. It would only be for tumors in the tail of the pancreas that all have very good features. And the reason for that is that the risk of complications after pancreas surgery is much higher than after small bowel surgery, so the balance is different. And then I'll finish by telling you a little bit what to expect around the time of the operation. First off, before surgery, you need preoperative preparation. If you have small intestine or metastatic tumors in particular, know if you have carcinoid syndrome. And then if you do have it, you need a heart workup with an echo to make sure there's no heart damage from it before getting under anesthetic. You get medical and nutrition assessment for readiness for surgery. And in terms of medication, you don't need any specific preparation. That's what we know now. You can just continue your usual medications, and you don't need add-on prophylaxis or preventative medicine. In the operating room, we want to look for the carcinoid crisis in those of you that have carcinoid syndrome. But the big change now from an international consensus from experts from all over the world is that you do not need octreotide either prior to surgery or in preventative at the beginning of the operation. And if you have a crisis, the first line of treatment would be vasopressors with octreotide used only as an adjunct if nothing else is working. This is the profile of complications within 3 months of surgery for pancreas, the small intestine, and the liver. This is, again, information we got from Dr. Milosh-Juma's work with our Ontario data set here. So things, again, that will depend on the specific surgery you're having, but important to ask and know about. The good news is when we looked at how much time folks will spend at home after their surgery, the vast majority of people will spend most of their time at home. About 82 out of the first 90 days are spent recovering in the home setting, which I think is very good news for everyone. We also looked at how symptoms go after surgery. It's work that's been done by Carlotta Sarzo, who's a resident in surgery in Milan, working with my team right now. And what we know is the main symptoms after surgery will be tiredness, poor well-being, and anxiety. And that those will go up right after the operation. It's normal. They will peak at about 2 to 3 months. And after that, they will come back down and then plateau at around 6 months. And then finally, those are the milestones you need after the operation before you're able to get home, eat, walk around, and then be able to climb stairs if you have them at home. We'll get an analysis of your specimen after the surgery. That takes a few weeks just because of all the stains and the tests that are needed, and that will be reviewed with your surgeon when you come back to the clinic for a visit. There can also be some long-term impact of the operation. I'll leave that there. You can look at it, but essentially all that can be monitored and can be managed after the surgery to help you. And right now, I just want to put a plug for a study we're doing about quality of life after surgery for neuroendocrine tumors at all the sites that you see here in Italy, Canada, and the United States. And hopefully I'll have more information about quality of life to report to all of you in a few years. And the last thing is after surgery, you'll need to have a monitoring program. What this is will depend on whether you had a complete eradication of the tumor or if there's some residual tumor in case you had cytoreduction or a debulking. The important thing here is that this is a long term, so minimum 10 years after complete resection or indefinite for your tumor treatment if there's still tumors left behind. And this, of course, will be tailored to your specific tumor. And then the last point I want to make briefly is how do I get the best care? Because I get a lot of emails and questions about this. It's important to get your care for surgery for neuroendocrine tumors in a place that has a multidisciplinary team that works together and consistently and constantly talk to each other about your particular care. And you don't have that in all centers, and not all large cancer centers are neuroendocrine centers. You want to look for a dedicated neuroendocrine clinic and tumor board. You want to ask what's the volume of neuroendocrine for surgery in that center. You want to have access to all the potential treatment options for neuroendocrine tumors. And you want physicians and clinicians, their level of familiarity with the net specific treatments that I mentioned today. And so with this, I'll leave you here with a few questions that you can screenshot this of what you can have in mind when you're looking for a center or looking to consider surgery for your treatments. And then finally, I received specific instruction to have a summary of how people can navigate things. So this kind of covers everything that we talked about today. Again, you can screenshot it and have a look if you so wish. Thank you very much for having me.
Hello, everyone. I'm Michael Solon. I'm the Director of Interventional Oncology at the University of Pennsylvania Abraham Cancer Center, and I'm happy to talk to you today about navigating liver-directed therapy. So liver metastases, as you know, are super common in patients with neuroendocrine tumors. Neuroendocrine tumors, in fact, are the second most common GI malignancy after colon cancer. So there's a lot of you out there. And patients develop liver metastases about 9 out of 10 times over the course of their disease. It's the most common and often the only site of disease progression, even if there's disease outside the liver, and ultimately leads to death in the majority of NET patients. So controlling them is super important. I'm going to start with biopsy. So as an interventional radiologist, of course, I do liver-directed therapies, but we also do your biopsies. And this is really, really important in helping us plan the type of treatment that is optimal for you, because every patient is unique. It's not as simple as you're a PNET or a lung net or a GI net, but there's lots of nuances that are unique to you and your tumor that we can understand by looking at the tissue. So we biopsy everybody pretty aggressively. One of the fundamental things you probably learned about is tumor grade already. So we grade patients as grades 1, 2, or 3, primarily based on the Ki-67 stain of the tumor, which is a stain that helps us calculate the percentage of cells that are growing within the tumor. So on the bottom left, you can see sort of the generic stain of a neuroendocrine tumor, and then the right-hand image is the Ki-67, and all the black staining cells are the ones that are growing. And we count those and determine what percentage are growing, and that gives us a sense of the likelihood that this tumor is going to progress or not. But you have to take this with a big grain of salt. Remember, when they do a biopsy, the pathologist is looking at a teeny little speck of your tumor, not the whole thing. So the sample we happen to get on that biopsy could be a hot spot or a cold spot relative to the remainder of your tumor. So it's not necessarily the most reliable predictor of how you're going to do, even though we do pay a lot of attention to it. I have patients with low-grade tumors who progress sooner than expected. I have patients with higher-grade tumors that sit there and behave very quietly for years. And it just means that the spot we biopsied at that day was not really representative of the whole tumor. And in fact, something that's much more predictive of how the tumor is going to behave is if we look at serial imaging over time. So if we scan you every 3 months, where we're looking at all your tumor and see how collectively your tumor behaves, that's a much more reliable predictor of the likelihood of tumor progression than the Ki-67 is. So just keep that in mind and don't obsess over it. That being said, we do know that the Ki-67 can change over time. So this is a study we did at Penn where we looked at hundreds of biopsy specimens, either from surgery or biopsies, and looked at what happened in individual patients to their Ki-67 over years. And although it's quite a scatter, some patients stay the same, some they went up, some they went down. On average, the Ki-67 number goes up 1% a year. And what that means is if you look at the right-hand box, 30% of our patients had a change in grade on serial biopsies over time. So, the Ki-67 you start with might make you a grade 1 or grade 2, but on the next biopsy, you might be a 2 or a 3. Conversely, it might actually go down, which just goes to show that you had a hot spot one time and a cold spot another. But we do like to rebiopsy patients every 1 or 2 years to see if the biology of their tumor has changed. Another important thing is genetic sequencing. This is not something that was so routinely done in the past for neuroendocrine tumors because they tend not to be very mutated compared to other kinds of cancers. But what we've learned, because we biopsy everybody, is that if you actually sequence people, you learn things that you would not know otherwise. Although not common, it's possible that you have a treatable mutation. So for example, just this year, I had a patient who had burned through all the standard therapies for a neuroendocrine tumor. I kind of reached the last stage. She was on camposatinib. She was very symptomatic. Her tumor was progressing. But as it happened, I had biopsied her when I treated her, and I got back her genetic sequencing, and it turned out she had what's called a RET1 mutation, a mutation that's more commonly found in lung cancer, and she was thought to have a pulmonary carcinoid. Well, it turns out there's a drug for RET1 mutations, so we got her hooked up with an oncologist who could give her that drug, and now her tumors are melting away and all her symptoms are gone. So, not the most common scenario, but if you're one of those lucky people who has a treatable mutation, you'd want to know that. Also, as we're going to talk about later, there are some mutations that actually help us predict which treatment we should do that would be better for you. So, for example, ATRX-DAC mutations are fairly common, especially in pancreatic neuroendocrine tumors. If you have that, that predicts that you would be resistant to TACE or bland embolization and more sensitive to radiation or TARE. So if we knew that ahead of time, that would help us decide which liver-directed therapy would actually be best for you. So genetic sequencing is super important. You want to ask for that from your doctors when you get biopsy. So let's talk about principles of liver-directed therapy. This is a little bit of a dense slide, but this is the page from the NCCN guidelines on principles of liver-directed therapy. All the NCCN guidelines have a patient-friendly version, and you can access that for free, and you all should become familiar with this. So this is the one page out of the entire guidelines that kind of summarizes liver-directed therapy, and I'm just going to walk you quickly through the key points. One is, what is liver-directed therapy? So liver-directed therapies can be surgery. They can be transarterial therapies, some form of embolization. They can be percutaneous ablation, where we put a cryoprobe or a microwave probe in and cauterize a lesion, or it could be targeted radiation therapy like SBRT. So why would we do this? So if you have liver-dominant disease that's progressing on a somatostatin analog, octreotide or lanreotide, or is symptomatic despite being on octreotide or lanreotide, or if you just walk in the door with bulky liver metastases where we don't want to risk waiting to see if an SSA would work for you, those are all reasons why you might say, okay, you should get some form of liver embolization. And then the question is how to do that. And there are multiple ways of doing that. So most common are TAE, transarterial embolization or bland embolization, TACE or chemoembolization. And then there's also radioembolization or TARE. And we're going to talk about each of those in more detail. In the big picture, regardless of how we do it, how useful is embolotherapy? How does it help you? Does it control symptoms? Does it shrink your disease? What's the price you pay in terms of side effects or risk? And how long does it last? So control of symptoms is actually what it's best for. 75 to 85% of patients with carcinoid or other hormone-related symptoms from neuroendocrine tumor will have relief of their symptoms after having their liver embolized. If you look at debulking or shrinkage, the response rate is more like 55 to 60%. So a complete response means all your tumor disappears, but partial response, remember, has a very strict definition. It means that if we measure the diameters of your tumors, they shrunk by 30% or more. So if your tumors only shrunk 29%, that's not a response. That's considered stable disease, but that might be enough to make your symptoms go away. So that's why the symptom response rate is actually better than the shrinkage rate. And then in terms of the price you pay, most patients will get post-embolization syndrome, which is this constellation of pain, nausea, vomiting, fevers, loss of energy, loss of appetite that can last from days to weeks. Serious complications happen about 6 to 10% of the time, and almost all of those are just bad post-embolization syndrome that will go away on its own. And then the question of durability, this is an important question because many people think of it, well, you get embolized and how long does that last? But you have to think of liver-directed therapy as a line of therapy. No one would ever give you one dose of chemotherapy and then wait and see what happens, or one dose of PRT. If we give you one cycle of embolization and you get a great response and it lasts for 1 to 3 years and you progress and you're still progressing in your liver only, we can embolize you again and again and again. So you can get multiple cycles of liver-directed therapy as one line of therapy without necessarily needing to go on to the next best thing. My personal record is 16 times. I embolized one patient 16 times over 12 years before he had to go do something else because it stopped working. So if you look at durability by each cycle, so this is a study from France. They looked at 200 patients that had over 500 embolization procedures, and they had 8 years of follow-up. So the interesting thing was the response rate was the same. So if you responded well the first time, you'll respond well the second time and the third time. What did deteriorate over time was how long the benefit lasted after each cycle. So it was about 20 months on average from the first embolization cycle, but then the second and third each lasted only about a year. But you add that all up, that's like 3.5 years of benefit from 3 sequential cycles of embolization. And in fact, if you looked at the whole group, about a quarter of them needed 5 years before they had untreatable progression and had to go on to the next line of therapy. So that's pretty good for one type of treatment, and sparing all those people needing to go on and fire the next bullet of PRT or chemotherapy or whatever. Of the patients who developed untreatable progression and had to go to a new line of therapy, mostly it's because the tumor just progressed either outside the liver, so they needed systemic therapy, or they progressed in the liver fast enough that they said, okay, this isn't really working anymore, we need to do something else. Only very uncommonly, 6%, was because the repeated cycles of embolization had done enough damage to the liver that you couldn't go back and do it again. So it's rare that we sort of burn the line of therapy due to injury from the embolizations. You usually can repeat them over and over. So now, which technique do you want to use? And as I said, there are 3 major flavors. So there's bland embolization, where we just inject small particles into the artery of the liver and cut off the blood flow of the tumor. So the tumors die because we choked off their blood supply and deprived them of oxygen and nutrients. And that goes back to the 1970s. Chemoembolization is a similar technique, except instead of just injecting sort of bland particles, we make an emulsion. We use an oil-based contrast agent, and we emulsify that with a solution of chemotherapy drugs. And then we inject that until we saturate the vessels of the tumor. So we fill up the tumor blood vessels with this oily emulsion that contains chemotherapy, which we can see on the X-ray image. And then we chase that with a small amount of particles just to cut off the blood flow and trap the emulsion. So that's chemoembolization, or TACE, and that's been around since the 1980s. And then finally, we have radioembolization, which is a completely different technique. With radioembolization, we use tiny little radioactive microparticles or seeds. We instill them in the artery of the liver. They sail out in the liver. They get embedded in the tumor, and they radiate the tumor from the inside out, but they don't cut off the blood supply because they're so tiny. So what to do? So we finally have, the NCCN guidelines actually don't distinguish between bland and chemoembolization because up to now, there haven't been any comparative studies. But now we've completed the RETNet trial, which was the randomized embolization trial for neuroendocrine tumors. And for this study, we took patients who had the usual indications. They had liver-dominant disease that was progressive or symptomatic on an SSA or had a heavy tumor burden. It could be any histology, so lung, GI, pancreas. The major exclusion was no prior biliary interventions, no interventions in the bile duct, because that can increase the risk of infection. We'll talk about that shortly. And we took those patients and we randomized them equally to 3 arms. So bland embolization, conventional chemoembolization with oil emulsion, or something called drug-eluting beads or drug-eluting embolics, where the drugs are loaded onto the little microsphere particles instead of using an oily emulsion. And then they were treated, and then they were followed up every 3 months for 2 years clinically and with labs and imaging and assessment of how they felt. So the first important lesson we learned was that the drug-eluting bead technology is way too dangerous in NETs. So we had a safety review after 10 patients to each arm, and the DEB arm was closed because 4 out of the 10 patients had major severe adverse events. 2 ended up in the intensive care unit. 2 had permanent hepatobiliary injury. That picture you see is a CAT scan of the liver with all those black holes or necrotic liver and bile ducts from the drug-eluting beads. 2 had to drop out of the study after the first treatment because of their toxicity. So this confirmed what had been suspected from some prior single-arm studies, that the drug-eluting bead technology was too toxic to be used in neuroendocrine tumors. And in fact, it's already been stated in the NCCN guidelines you should not use this technique. So that left us with just the bland arm and the conventional chemoembolization arm. And these graphs just sort of sum up the final results, which is they work equally well. So the left-hand curve is the hepatic progression-free survival for the tumor to progress within the liver itself. And it was the same between the bland group and the chemoembolization group. The right-hand curve is overall survival. Now that's a little premature because almost nobody dies in 2 years, so it's not very mature data. But again, really no difference in survival between the 2 groups. And then that bottom curve is what's called the carcinoid symptom severity score. So that's a numerical score for patients who actually have carcinoid syndrome. They have diarrhea and flushing, and we can see that in both arms, that score dropped rapidly over the series of embolizations and then stayed down now to 2 years. So basically, the benefit of bland embolization and chemoembolization was the same. Given that, how do you choose? So when would you choose bland embolization? Well, the most common reason is there are patients who we don't want to give chemotherapy to. So if you walk in the door and you have kidney insufficiency or low blood counts, things that would be made worse by getting chemotherapy, then we're just going to do bland embolization because we don't want to cause other problems based on your risk factors. Sometimes it's the patient preference. There are some patients who just don't want chemotherapy in their body, which is fine. But one thing that's important to remember that we've known from some retrospective studies and also was shown in RETNet is that bland embolization actually has more toxicity than chemoembolization. Most people don't realize that. But the rate of serious adverse events in the RETNet trial with bland embolization was 50% higher than with chemoembolization. And the little data box I'm showing you in the middle is actually from a big retrospective study we did. If we just look at pain, the incidence of pain with chemoembolization or reembolization was around 40%, but with bland embolization was about 70%, significantly higher. And that's because you're using tiny particles and you're embolizing to a much harder endpoint than with the other techniques. So it just hurts more. Even though people think that, if you're not giving chemotherapy, it must be safer. But in fact, that the opposite is true. Bland embolization is more toxic, mostly because it hurts more. Okay, when to consider drug-eluting beads? Never, right? You should never get these. So if you're consulting with an interventional radiologist who's going to do chemoembolization on you, and they're saying they're going to use drug-eluting beads, walk out the door, call me, I'll find you somebody else. But you should never, ever get these products used for your disease. Now, what about radioembolization? So one of the nice things about radioembolization is it is much less toxic because there are tiny little seeds and you're not cutting off the blood supply. There's almost no side effects. Most people have none. Maybe a third of patients will get some fatigue from the radiation, maybe 10% get nausea, but it's a very well tolerated treatment in the short term. So some people are just too frail to get chemoembolization. You don't want them to get a bad post-embolization syndrome. So if the patient is frail, or if the patient is a caretaker for a family member and can't afford to be disabled, or if there's someone who's employed a job where they can't be off for 2 weeks and lose their income, reembolization is a much less disruptive to quality of life. And so it's good for those patients. Also, as I mentioned before, patients with prior biliary intervention, so you've had a Whipple surgery for a pancreatic tumor or a biliary stent in place, the risk of infection in chemoembolization is quite high because when you've had a Whipple or a stent, the bacteria in your GI tract now colonize your bile ducts. And so when you embolize the liver, you cause injury to the bile ducts, and there's about a 20% risk of an abscess with bland or chemoembolization. If you do reembolization because you're not actually cutting off the blood flow and causing as much damage, the risk of infection is only 7 or 8%. So anyone who's had a prior biliary intervention, we will prefer to do TARE in. Also, if you're refractory, so if you had bland embolization or chemoembolization, you didn't get a durable benefit, then we'll switch. If you progress in under a year, we just switch to TARE because you're probably one of those people who has a tumor that's resistant to ischemia, but more sensitive to radiation. And in fact, we just completed a study that we're writing up right now where we showed that patients who got TARE in the setting of being refractory to TACE actually had much better benefit in terms of the duration of tumor control than they did with their TACE. Another reason we use it is when we want to combine it with chemotherapy. So some chemotherapy drugs are what we call radiosensitizers that make radiation work better. And it happens that CAPTEM, the oral chemotherapy regimen that's commonly used in neuroendocrine tumors, both those drugs are radiosensitizers to make radiation work better. So for patients with higher grade disease, grade 2 or grade 3, especially if there's disease outside the liver that the oncologists want to treat, we will combine CAPTEM with Y90 reembolization and get really, really good results with that. We actually just completed accrual to a multi-center phase 2 study to better understand the benefit of this, but it really seems magical. Another question that comes up frequently is, well, what if I want PRT? I mean, PRT is radiation too, right? Would it be dangerous to get TARE and PRT? And in fact, although that's a very common concern, there is no evidence that that's true, regardless of the order you get them in. The available published data of patients who've had TARE and PRT in either order is there does not seem to be any increased risk in those patients. To me, that's not a serious concern, but it frequently comes up. However, a real concern is late radiation-induced liver failure. So there are 3 studies from 3 different institutions, including my own, where we looked at patients who had radioembolization and then went on to live for 2 to 10 years later. And it turns out 10 to 20% of those develop late radiation-induced liver failure. So that's particularly true in patients who have had their whole liver embolized. So they needed both sides done. So given that, we try to be cautious and try to avoid whole liver radioembolization and spare a couple segments of liver just to avoid this risk of late radiation-induced liver failure. So that's a little bit of a trade-off in terms of risk that doesn't happen with bland embolization or chemoembolization. And then the other question is, there are all these other therapies out there that you could get that are systemic, such as CAPTEM if you have pancreatic neuroendocrine tumor, or PRRT, peptide receptor radiotherapy, Lutathera, which you can get for any kind of neuroendocrine tumor. And these are all approved treatments, and they're all available upfront. So if you fail extrahepatic lanreotide, you are eligible for any of these treatments or liver-directed therapy. And so in some places in the world, people tend to get, for example, PRT as their second-line therapy, even if they have liver-dominant disease. So how do you decide? Not so easy, but we do have some data. So the NETTER-1 trial, the prospective trial of Lutathera in the United States, had a median overall survival of 4 years, a 5-year survival of about 37%. The trial of CAPTEM had a median overall survival of about 60 months or 5 years. We don't have prospective survival data from big trials in bland embolization or chemoembolization, but we do have about 40 years of retrospective data, and it looks like median survival is about 64 months, and even better if you responded well, at the 5-year survival is over 50%. So this would suggest at least that the benefit of liver-directed therapy is comparable or perhaps superior to systemic therapies, and it does make an argument that if you have liver-dominant disease, that liver-directed therapy is the next line of therapy might be appropriate, and we can, in that way, stall time or buy time before you need to fire the next bullet, which might be a systemic therapy like CAPTEM or PRT. And that's certainly how we think about it at Penn. Patients who have liver-dominant disease or localized disease get triaged to localized therapy, whether it's embolization or surgery or whatever, for as long as possible, because someday they're going to need PRT or CAPTEM or whatever, and why fire that bullet too soon? You can save that benefit for later in the course of disease. So I hope you found this summary helpful. Thank you.
Thank you to newlyweds Sarah and Quentin for sharing your story. And thank you, Dr. Julie Halle and Dr. Michael Solon, for those excellent presentations. One of the biggest changes in neuroendocrine cancer has been the expansion of treatment options. While this progress has created new opportunities and hope, it has also made the treatment landscape significantly more complex to navigate. Dr. Hendafar, patients today may hear about somatostatin analogs, chemotherapy, PRRT, targeted therapies, liver-directed therapies, and clinical trials, to name a few, sometimes all within a single appointment. How do clinicians approach navigating this growing number of options?
Yeah, the treatment landscape is very large, growing and expanding, so many options, so many different ways to approach a particular problem, a particular patient's clinical situation. I think one of the ways is we've been talking about is getting the neuroendocrine tumor team involved to help whittle down which options make the most sense for a patient. But I think that another not well recognized is that doctors are starting to come up with principles of neuroendocrine tumor care. For example, if the patient is going to outlive the tumor, maybe they don't need treatment. For example, how much disease does the patient have? What is their tumor burden? Is it high or is it quite low? Another important characteristic of the patient that can bear on which treatment to choose is whether or not the disease is confined to the liver, what we call hepatic predominant, or extrahepatic. And these help us sequence and approach patients, even though they're unique, in some kind of algorithm that's more generalizable. But I think in general, we try to, we're developing these principles as time goes on. There's a lot more consensus today on how we should approach particular problems than there used to be in the past. And I think that's because we do a pretty good job of talking to our colleagues and getting team members involved in everyone's care.
Yeah, getting involved and really finding that way to have common ground and consensus. Mary, I think many patients struggle with that feeling that they need to become experts almost overnight. How can patients approach treatment discussions in a way that feels informed without also feeling overwhelmed?
Yeah, as we've mentioned, overwhelm is so common at the beginning, and it's really challenging to become an expert on NET. It is complicated. And everybody manages this differently. There are people that immerse themselves in education, and there are people that are completely paralyzed by their diagnosis. And this is when I say all approaches are okay. Everybody's going to do this differently. And wherever you fall on the spectrum, it's just important to be educated. And if it's not you, is have a caregiver that's able to support you in this at a comfortable pace and still be present in your life, still be with your loved ones, separate from this life with cancer. It can envelop you and your life is still going on every other aspect. So I would strongly recommend living your life with your loved ones and not just concentrating on the cancer if you can help yourself do that. And then a practical piece of advice I would give is the overwhelm comes a lot of times from feeling as though you have so much to talk to your doctor about. And I would say taking notes on symptoms, on feelings, on questions you have while you're waiting for your appointments as they come up in your life is so important. So you feel organized, and sometimes just writing them down kind of calms you a little bit. And then even submitting them through your portal to your doctor prior to getting to the appointment so that your doctor is able to see what your concerns are before you come in can be really helpful for both of you. So those would be my practical pieces.
Yeah, organization and communication. Dr. Hendafar, one of the realities is that patients really worry about making a right or wrong decision. They want to make the best decision. How do you help patients navigate uncertainty when they worry about this and maybe there are multiple reasonable approaches?
Yeah, this happens every day in the clinic. You have multiple good options and you're trying to figure out which is the best one for the patient in front of you. And the way I navigate it is I make sure that we go into a detailed risk benefit of each of the options. And then we kind of go into the patient themselves. Where are they in their life? What's going on with them for the next year or two? Are they working full time? Are they planning big travel? And then, it's kind of tough, but I think it's really important that the patients weigh in at this point and saying, okay, since these are all reasonable options, this probably based on this discussion, this option's best for me. And, play off the physician and go back and forth and try to figure that out. It's really tough if the physician just gives you options and makes you decide on your own. So I think it's important a dialogue, just a discussion, maybe asking your doctor a bunch of questions about, okay, so how am I going to feel on this treatment? How is it going to affect the other things that are going on in my life right now? And try to, develop the dialogue a little bit more between the doctor and the patient.
Yeah, that dialogue is key. Again, communication. We're excited to introduce our final set of speakers.
Our next presentation is Navigating SSAs and Chemotherapy by Dr. Guillaume Will Pena, medical oncologist at Oregon Health and Science University, Knight Cancer Institute in Portland, Oregon. Following that, we'll hear Navigating Targeted Therapies and PRRT presented by Dr. Jennifer Chan, Clinical Director of the Gastrointestinal Cancer Center and Director of the Neuroendocrine Tumor Program at Dana-Farber Cancer Institute in Boston.
And then next after that is Navigating Clinical Trials, presented by Dr. Thor Hefdonerson, medical oncologist at the Mayo Clinic in Rochester, Minnesota.
Then we'll be hearing Navigating Treatment Sequencing from Dr. Pamela Coons, Professor of Internal Medicine and Director of the Center of Gastrointestinal Cancers at Smilow Cancer Hospital and Yale Cancer Center.
And then we have a presentation, Navigating Treatment Side Effects, with Dr. Jason Starr, who is a medical oncologist at the Mayo Clinic in Jacksonville, Florida.
We'll then transition into our second panel discussion, Navigating Treatment Decisions. This panel will be moderated by Dr. Heidi Del Rivero, who is both a medical oncologist and endocrinologist at the National Cancer Institute at the NIH in Bethesda, Maryland. She'll be joined by Dr. Chandrika Chandrasekaran, a medical oncologist at MD Anderson Cancer Center, Dr. Calissa Clark, Division Chief of Surgical Oncology at Froedtert Hospital and the Medical College of Wisconsin, and Dr. Eric Mitra, nuclear medicine physician at Oregon Health and Science University.
And finally, we're going to close with another patient story, and this one's reflecting on the lived experience and navigating the treatment decisions while living with neuroendocrine cancer.
Hi, my name is Will Pena. I am a neuroendocrine tumor medical oncologist at OHSU in Portland, Oregon. And today I will be talking about navigating somatostatin analogs and chemotherapy for neuroendocrine tumors. So starting off, these are my disclosures. All right, the goals of our talk today are to, 1, understand what somatostatin analogs and chemotherapy do, 2, to learn when each treatment is typically used, and 3, to know what to expect and what questions to ask your care team. So as we jump into this discussion here, it's important to see where it fits within the neuroendocrine tumor journey. And what I mean by this is that neuroendocrine tumors are not just one disease. As you know, these tumors can originate from multiple diverse primary sites, and they can behave very differently from slow-growing to much more aggressive cancers. There are even certain of these neuroendocrine tumors that can secrete hormones that can cause severe symptoms in and of themselves and affect organs that are otherwise cancer-free. So along this line, neuroendocrine tumors are often treated over a period of many years, if not decades. And as such, treatments are oftentimes added step by step. They may be recycled, they may be reused, and they're really driven by patient context, and really with an idea in mind of 3 goals. For all patients, we're hoping to control tumor growth, to control symptoms. And for many patients, as I mentioned, there's this idea of controlling hormone secretion, which is part of controlling the overall symptoms and the long-term disease course. So to start off with this, we'll start talking about somatostatin analogs, oftentimes shortened to SSAs for short. These are medications that are similar to the hormone somatostatin. If you look here, many of you have seen dotatate PET scans before. So if we really zoom in on the neuroendocrine tumor and we look at it at a cellular level, many neuroendocrine tumor cells will express a somatostatin receptor on their surface. This somatostatin receptor binds to the hormone that naturally exists in our body called somatostatin, and that receptor binding sends a signal through the neuroendocrine tumor cell, which is really a stop signal. This indicates to the tumor to slow down its growth, slow down its reproduction, and also to reduce hormone production and secretion. So our somatostatin analogs are medications that look very similar to the hormone somatostatin. They include octreotide LAR as well as lanreotide. There's also a short-acting version of octreotide that also is available as a subcutaneous injection. Common side effects of these medications include injection site discomfort, mild gastrointestinal symptoms such as diarrhea or even constipation in certain cases, and over long-term use, gallstones. So starting off with tumor control, somatostatin analogs are oftentimes the very first treatment that patients will receive for their neuroendocrine tumor, and both octreotide and lanreotide have been shown to delay tumor growth. What I have on this slide here is an oncologist's favorite graph that comes out of clinical trials. This is called a Kaplan-Meier curve. Although it seems complicated, the general idea is on the vertical axis here, you can see the percentage of patients who are alive and their tumor has not grown. And on the horizontal axis, you have time. So in the original studies, both lanreotide and octreotide over time showed that proportionately more patients were alive with their tumor not growing, really over a period of multiple years. And so we have both of these drugs available for the purpose of slowing down tumor growth, controlling the tumor, oftentimes when it is first diagnosed. And the selection between these, we'll talk a little bit more about this, but this is based on practical factors as well as patient preferences. Now, somatostatin analogs also play a critically important role in hormone control. And as I mentioned, they send this stop signal that's acting to directly stop hormone production and secretion. And as such, these are the mainstay of treatment for many of our hormonally related syndromes that can occur with neuroendocrine tumors. So what are these syndromes? Most often coming from small intestine neuroendocrine tumors, less often from lung neuroendocrine tumors, is the secretion of serotonin or serotonin-like peptides that can cause the classic carcinoid syndrome, including diarrhea, flushing, wheezing, and in its most advanced and kind of its most severe state, heart disease, valvular dysfunction, and even heart failure. Pancreas neuroendocrine tumors are much less likely to express hormones, but they can also create very severe syndromes as well. Some of the hormones that can be secreted include gastrin, which triggers acid secretion in the stomach, which can lead to ulcers, insulin, high levels of which can result in low blood sugars, glucagon, which can cause the opposite and very high blood sugars, VIP, vasoactive intestinal peptide, can cause severe diarrhea, or a very rare entity where somatostatin is actually secreted, which results in gallstones. So really, somatostatin analogs are critically important for the purpose of slowing down or stopping hormone release. And even if the tumor grows, we oftentimes will continue the somatostatin analogs in spite of this because of their continued impact on hormone control. So going back to the question of which one, lanreotide or octreotide, while they've never been compared head-to-head, we generally consider them to be similarly, if not equally effective. And so the choice of which one to use is usually driven on practical and patient-specific factors. It used to be that we were a little bit limited by insurance, one over the other, but nowadays really it mainly comes down to sort of patient and provider preference. And what this comes down to is how these drugs are given. So lanreotide is given as a deep subcutaneous injection. So the idea is that the injection goes through the skin into the connective fatty tissue that's below the skin, whereas octreotide LAR is a deeper injection that goes through the skin, through the subcutaneous tissue, and into the muscle itself. So octreotide, this IM deep injection, may be preferred in patients who have very thin skin or otherwise have less subcutaneous tissue, less subcutaneous fat, whereas lanreotide may be easier when intramuscular deep injections are difficult. So now comes the question of what do we do if symptoms break through? Well, from a hormonal perspective, we can always consider increasing the dose or the frequency of both octreotide LAR as well as lanreotide. But from a tumor control, there is also some experience and even some clinical trial data suggesting that there may be some benefit from increasing the dose. Now, what I have on this chart here is another Kaplan-Meier curve from the original NETTER-1 trial that led to the approval of PRRT, but the PRRT, the Lutathera, is being compared to a double dose of octreotide LAR, or what they call high-dose octreotide. What we can see in this graph is that although, yes, Lutathera is clearly superior in terms of progression-free survival benefit, at 8 or 9 months, more than 50% of patients, their tumors had not grown during that time period with this high-dose octreotide. So this at least suggests that this is a possibility for continued disease control. And as I mentioned, we oftentimes will continue the octreotide or the lanreotide in order to control hormonal symptoms, even if the tumor has progressed. In certain cases, we may even continue it if we think that it may be slowing down the tumor, if not altogether stopping it. So somatostatin analog therapies have been along for quite a long time, but these are actually an active area of research at this time, with goals of research including to improve the hormonal and symptom control, more convenient administration, and more consistent and higher average drug levels. Examples in development include CAM 2029. This is a bi-weekly subcutaneous octreotide depot option with a possibility of self-administration. And then paltusotine, this is a once-daily oral non-peptide somatostatin analog being studied for the control of carcinoid syndrome symptoms. Now, importantly, we need to know that these drugs remain investigational. They're not currently available outside of clinical trials, but we do have some hope that maybe some of these will move through clinical trials and be available in the future. So when do we move beyond somatostatin analogs? For one, of course, if the tumors are clearly growing through multiple CT scans and we don't think they're providing that disease control. Second, if we're getting breakthrough symptoms, be it hormonally or other symptoms, in spite of dose optimization and otherwise for these drugs. Then also, if the disease starts behaving more aggressively, oftentimes the somatostatin analogs are not the best option for controlling disease. Similar to that, on initial diagnosis, if a patient has higher grade disease, we may jump to different treatments such as PRRT, Lutathera, or even chemotherapy in certain situations. So this transitions us well into talking about chemotherapy for neuroendocrine tumors. So chemotherapy works by directly killing tumor cells. They are oftentimes used for pancreatic neuroendocrine tumors as well as for faster growing or higher grade disease. The main goal of chemotherapies tends to be tumor control, including stabilization or shrinkage of disease. But they may also sometimes be beneficial for hormonal symptoms, but this is really not the primary goal or expectation of these treatments. The side effects are very different from somatostatin analogs and really depend on the regimen that is used. So it's impossible to not talk about chemotherapy without including a NET oncologist's favorite combination, which is capecitabine and temozolomide, or CAPTEM for short. This is an oral-only chemotherapy regimen that combines capecitabine given on days 1 through 14, as well as temozolomide on days 10 through 14, followed by 14 days off. This combination tends to be exceptionally well tolerated compared to many traditional chemotherapy regimens, though it does have some side effects, including fatigue, nausea, low blood counts. Constipation is also possible as well. Now, very importantly, as of 2026, there is a genetic sensitivity to capecitabine that all patients should be tested for before starting this combination. This is called DPD deficiency. DPD is an enzyme that breaks down the active chemotherapy component of capecitabine, and in 2 to 4% of the population that have a genetic deficiency of this enzyme, what we can see is much higher levels of the drug causing more severe side effects. So as of 2026, we really want to have all patients tested, if feasible, before starting capecitabine. Other chemotherapy options include the colon cancer regimen FOLFOX, which is the combination of 5-fluorouracil with oxaliplatin. There's really good data to use these, especially pancreas neuroendocrine tumors that have been treated with multiple other agents. There's a much older regimen combining streptozocin with or without 5-fluorouracil. It still has some utility in certain neuroendocrine tumor patients. And then the platinum chemotherapies, cisplatin or carboplatin combined with etoposide, are really typically reserved for much higher grade or aggressive disease such as neuroendocrine carcinomas. So when we think of somatostatin analogs and chemotherapy and how decisions are made, this brings us back to the idea that neuroendocrine tumors are just an incredibly diverse set of diseases. As such, treatment decisions are individualized and based upon symptoms, the behavior of the tumor, side effects, and quality of life expectations, as well as patient preferences and goals, which that last one is oftentimes of critical importance as we're navigating these different treatment options. Now, it's important to keep in mind that there are multiple effective treatment options that are often available over a long period of time, and new treatments are constantly being developed. Oftentimes, I have this discussion with patients of, well, why are we doing this treatment if we don't expect it to make the tumor go away or shrink, but rather just keep it stable? And it feels like we're just kicking the can down the road. That's exactly what we're actually aiming for in certain cases, because there are new treatments coming down the pipeline constantly. If we can minimize symptoms, minimize disease growth, and we treat this over a longer period of time, this really allows us to take advantage of all these advances that are going on in neuroendocrine tumor research. So some questions to ask your oncologists, really with most any treatments, but when it comes to somatostatin analogs and chemotherapy as well, is what is the goal of my treatment? How will we know if it's working? What side effects should I expect? And really, especially when it comes to the capecitabine nowadays, are there any genetic tests or otherwise that I need before the treatment? And here I'm really referring to the DPD testing. And then, as I mentioned in the last slide, are there clinical trial or other options that I should consider? Clinical trials are really just the critical way that we move this field forward and that we develop these new treatments. So I always strongly recommend pursuing these whenever that's a possibility. So some key take-home points that I wanted to make sure to emphasize. Again, neuroendocrine tumors, highly diverse cancers. Treatment decisions have to be individualized. Octreotide and lanreotide are foundational therapies that help control both tumor growth and hormone symptoms. Chemotherapy is generally used for more progressive or aggressive disease and can be very effective and well tolerated. Multiple treatment options are oftentimes available over time, and patients should understand the goal of each therapy within the greater context of their journey. All right, and with that, I'd like to say thank you to the Neuroendocrine Cancer Foundation for having me here today, as well as all of our viewers at home, the OHSU Neuroendocrine Tumor Program, as well as the OHSU GI Oncology Clinical and Research Team, and of course, our patients and their families who make all of this possible.
Hello, my name is Jennifer Chan. I'm a medical oncologist at Dana-Farber Cancer Institute, and I'm happy to be part of today's meeting, focusing on navigating various aspects of care with neuroendocrine cancer, including various therapies. My talk will focus on navigating targeted therapies and PRT. And as an overview of some of the topics that I'll cover, I'll focus on what targeted therapies and what PRT is and how these agents work. I'll also focus on the outcomes and side effects associated with these therapies and when we consider using these treatments as part of the treatment plan. Peptide receptor radionuclide therapy, or PRT, and molecularly targeted agents are forms of systemic therapy. You heard earlier today about somatostatin analogs and chemotherapy, which are also a form of systemic therapy. And these essentially are drugs that enter the bloodstream to treat cancer cells that are located throughout the body. In contrast to surgery and other local therapies like liver embolizations or ablation or histotripsy, systemic therapies are used to treat disease that can't be removed with surgery or can't be treated locally, and typically this is when the cancer has spread. Systemic therapies have an advantage in that they can reduce disease burden by shrinking cancer. They can also slow tumor growth, and they also can improve symptoms that are related to disease. And this can either happen because there is shrinkage of cancer that then leads to improvement in symptoms like pain that's caused by the cancer, or also with neuroendocrine tumors, the systemic therapies can reduce the amount of hormone that's being released. So some of those hormonal symptoms also can be improved with systemic therapy. There are various targets for treatment in neuroendocrine tumors, and these really are properties of the cancer cells or signaling pathways that drive growth of the cells. The important targets for treatment in NET include the somatostatin receptor, as shown on this slide. And you heard about this earlier today with somatostatin analogs, which also target the receptor. Peptide receptor radionuclide therapy also targets the somatostatin receptor, and I'll go into more detail about that in a few minutes. Some of the other important targets in neuroendocrine tumors include the mTOR pathway, and this is a signaling pathway that drives metabolism and growth, and the mTOR pathway can be inhibited with a targeted agent like everolimus. Angiogenesis is the process of new blood vessel formation, and that's an important process for delivering oxygen and other nutrients to cells that support growth and spread. And there are various ways that angiogenesis can be targeted, including the tyrosine kinase inhibitors, another form of molecularly targeted therapy. I'm going to start first by talking more about the somatostatin receptor. Again, this is the target for somatostatin analogs and also PRRT. And somatostatin receptors are a receptor that is found on the surface of just over 80% of well-differentiated GI and pancreatic neuroendocrine tumor cells. They're less frequently found, but can also be present on lung neuroendocrine tumors. And the way we know that somatostatin receptors are present on tumor cells is through imaging. This includes nuclear imaging with a dotatate PET CT scan where we can actually visualize where the tumors are. And this is an example of a dotatate PET CT scan where you can see various darker spots that are scattered throughout the body, and these represent areas of neuroendocrine tumor. These lesions are considered somatostatin receptor positive if the uptake on the dotatate PET CT scan is higher than the background liver. So you can see in this figure that the liver uptake is this lighter shade of gray, where the tumor is darker than that. The black spots that are kind of scattered throughout the body also represent areas of tumor. Peptide receptor radionuclide therapy enables delivery of tumoricidal doses of radioactivity to somatostatin receptor positive neuroendocrine tumor cells. And the way that it does this is that it pairs a ligand to the somatostatin receptor with a radionuclide. So I'll kind of walk you through how it works. The somatostatin receptor is present on the surface of the neuroendocrine tumor cells. And the peptide receptor radionuclide therapy includes a ligand that binds to that receptor. So that green portion of the figure is the ligand that binds to the somatostatin receptor. And along with the ligand, there also is a radionuclide that emits alpha or beta particles. And there's also a chelator that really is a cage that binds the radionuclide therapy to that ligand to make it more stable and make sure it's delivered to the target. Lutetium-177 dotatate is an FDA-approved treatment for somatostatin receptor-positive GI and pancreatic neuroendocrine tumors. And you can look at the name and see that there are various components to the PRRT agent. There's the radionuclide, which is lutetium-177. That is a beta-emitting radionuclide. The chelator, that's the DOTA part of the name, and the ligand is octreotate, so the tate. So this is the therapy that is used routinely now to treat somatostatin receptor-positive GI and pancreas neuroendocrine tumors. The way that it works is that the lutetium-177 dotatate binds to that target, that somatostatin receptor that's present on the neuroendocrine tumor cell surface. It's internalized, and once inside the cell, it releases radiation that causes tumor cell death. As mentioned, lutetium-177 dotatate is approved for treatment of somatostatin receptor-positive GI and pancreatic neuroendocrine tumors. It's typically administered once every 8 weeks for 4 treatments, and this can be given either with or without the usual monthly somatostatin analog therapy. It's approved to be given with monthly somatostatin analog therapy, although it doesn't necessarily have to be. What's important is that amino acids are given with treatment to protect the kidneys. And after treatment, there are radiation safety precautions that need to be taken, including minimizing exposure to other people during that, especially first week after treatment, and also, making sure that body waste, especially urine, is managed. Some of the benefits of lutetium-177 dotatate are that it can slow disease progression. We have seen from clinical trials and also clinical experience that lutetium-177 dotatate can slow the progression of somatostatin receptor-positive neuroendocrine tumors. In some cases, you can also get not just the slowing of growth, but you can also get some shrinkage. And this is particularly true if tumors are higher grade or if there's a pancreas primary. In addition to slowing progression and having tumor shrinkage, lutetium-177 dotatate also can improve hormone-related symptoms. This is particularly true for carcinoid syndrome, where symptoms of flushing and diarrhea can improve with lutetium-177 dotatate. And it also can be effective for other functional neuroendocrine tumor syndromes like insulinoma or VIPoma, where the treatment can help with those symptoms caused by hormone excess. We do also have to be aware that there are side effects of PRRT, and I've listed some of the common ones and the ones that may not be quite as common or even just have low risk, but we need to be mindful of. And these include fatigue. Some people may also have some GI side effects that might include nausea or diarrhea. And there is, again, that very low risk of probably around 2% or less of myelodysplasia or less than 1% risk of leukemia. So when do we recommend PRT? It's typically utilized for patients who have somatostatin receptor positive GI and pancreas neuroendocrine tumors after progression has occurred on a somatostatin analog. It also can be utilized earlier in some cases, particularly if there's a high grade 2, where a Ki-67 index of the tumor is more than 10%, or grade 3 tumor. And this is particularly true if there's high disease burden. I will add that not everyone with a high grade 2 or grade 3 neuroendocrine tumor necessarily needs to have lutetium-177 dotatate as the first line of therapy, but it can be beneficial when there are higher amounts of disease where it can be important to achieve early disease control. Retreatment with lutetium-177 dotatate can be considered. It would be off-label therapy, but it can be considered in cases where there has been a durable benefit to that first course of PRT. And there are various definitions that we use, but one kind of rule of thumb may be that there's at least 1 year of disease control where there hasn't been any growth after stopping that first course of lutetium-177 dotatate. Finally, I do want to add, and you'll hear more about this in some of the later talks, that clinical trials are being done to evaluate the efficacy of repeat PRT with lutetium-177 dotatate or an alpha-emitting PRT agent actinium-225 dotatate in patients with GI or pancreatic neuroendocrine tumors. So there will be important information that we learn from this trial about how repeat PRT compares to other systemic therapy options, and we'll learn more about the safety of repeat PRT, especially when it comes to hematologic or in some cases renal toxicity. I also want to add that there was a recently completed trial looking at a different PRT agent, in this case lutetium-177 etatrietide, also known as lutetium-177 dotatate. This was the COMPETE trial that enrolled patients with well-differentiated non-functional GI neuroendocrine tumors or patients with pancreatic neuroendocrine tumors that were either functional or non-functional. And in this particular trial, there was a randomization to either this newer PRT agent, lutetium-177 etatrietide, compared with everolimus. The results of this trial were announced last year, and we learned that lutetium-177 etatrietide has an improvement in progression-free survival compared with everolimus. So this agent is currently under review at the FDA, so I hope at some point soon we'll learn whether or not there's a new treatment option that we can consider. I'm going to switch gears now to talking about molecularly targeted agents for neuroendocrine tumors. And as mentioned before, there are two important features of neuroendocrine tumors that can be targeted with molecularly targeted agents. And this includes the mTOR pathway that can be targeted with mTOR inhibitors, and also tyrosine kinase inhibitors that can do a number of different things, but also impact angiogenesis. So everolimus is an example of an mTOR inhibitor that's approved for neuroendocrine tumors. This works by blocking that mTOR pathway that is responsible for regulating cell growth and metabolism. We have seen from clinical trials that everolimus can slow disease progression, and what I mean by that is growth or spread to new areas in pancreas neuroendocrine tumors and non-functional GI and lung neuroendocrine tumors. Everolimus is a treatment that's given orally, and this is administered as tablets that are taken daily by mouth. And treatment is continued until there is disease progression or until treatment has to be stopped for other reasons. There are side effects to watch for related to everolimus, and some of the common ones are included here, including fatigue, mouth sores. People can also develop a skin rash or high blood glucose level. There can be decreased appetite, GI side effects like diarrhea. Lung inflammation, what we call pneumonitis, sometimes also can occur with everolimus. Swelling of the extremities and taste changes can occur. So these are side effects to watch for, and there can be important modifications in the dose or holding of treatment that can improve these side effects. Cabozantinib is an example of a tyrosine kinase inhibitor. This works by blocking multiple receptors that are on the surface of the cancer cell, including the VEGF receptor. This is a receptor that's involved in angiogenesis. Some of the other receptors that cabozantinib blocks includes receptors called MET and AXL and RET, and these also are important for inhibiting growth and spread. The benefits of cabozantinib are that we've seen again from clinical trials that it can slow progression of pancreas neuroendocrine tumors as well as neuroendocrine tumors that arise outside the pancreas. This really includes sites in like the GI tract most commonly, but also lung, unknown primary tumor sites, thymus, and other rare primary sites. It primarily works by slowing disease progression, but in some cases, and this is particularly true for pancreas neuroendocrine tumors, there can be shrinkage that is seen on treatment. Cabozantinib, like everolimus, is a targeted therapy that's taken daily by mouth. And the side effects that are observed with cabozantinib include fatigue, diarrhea. Because it affects angiogenesis, this process of blood vessel formation, there can be cardiovascular side effects like high blood pressure. There also are effects of cabozantinib on the hands and the feet with a redness and a swelling, what we call palmar plantar erythrodysesthesia or hand-foot syndrome. Mouth sores, decreased appetite, weight loss, and taste changes also can occur with cabozantinib. And again, just like with everolimus, if these side effects occur, doses can be adjusted, doses can be paused, and once there's recovery, treatment can be restarted. Sunitinib is another tyrosine kinase inhibitor. It is similar to cabozantinib in that regard, but it's different in that it blocks different receptors. Both cabozantinib and sunitinib block the VEGF receptor, but sunitinib blocks other receptors, including the PDGFR receptor, receptors that are called c-KIT and RET. So the benefits of sunitinib are that it can slow disease progression in pancreatic neuroendocrine tumors. It, like cabozantinib, everolimus, involves treatment with pills that are taken daily. Some of the side effects of sunitinib are quite similar to what I mentioned with cabozantinib because they fall into that same class of tyrosine kinase inhibitors. I do want to mention that belzutifan is another targeted agent. This is what we call a HIF-2 alpha inhibitor, and this works by preventing HIF-2 from activating genes that lead to growth and recruitment of new blood vessels. Belzutifan is relevant for patients who have a germline or an inherited mutation in a gene called VHL. VHL, when there's a mutation in that, can lead to excess HIF-2 alpha, so you can block that with an agent like belzutifan. This is also effective and was approved last year for patients with pheochromocytoma and paraganglioma. Belzutifan also is a pill that's taken by mouth. Some of the side effects of belzutifan are quite unique, and they include anemia. There can be a drop in oxygen levels with belzutifan, and also shortness of breath, fatigue. Other side effects that have been observed with belzutifan include headaches, dizziness, some visual changes, and musculoskeletal discomfort. So when do we start thinking about using molecularly targeted agents? Usually everolimus and the TKIs are used after progression on other therapies like a somatostatin analog or often after PRRT. How we choose between these different agents really will depend on a number of factors, including primary tumor site, a patient's other medical conditions that may make one agent preferred over the other. For example, patients who have diabetes, we may be more prone to think about using a tyrosine kinase inhibitor because everolimus can lead to worsening of diabetes. On the other hand, people who may have hypertension or other cardiovascular conditions, we may favor using everolimus because of the impact of the tyrosine kinase inhibitors like cabozantinib or sunitinib on blood pressure and other cardiovascular effects. As I mentioned before, it's important to recognize that when targeted agents are used, that doses may need to be adjusted because of side effects. It's quite common that, for example, with cabozantinib, doses need to be adjusted over time because of side effects. And in some cases, patients may also start with a lower than normal starting dose. For example, starting with a dose of 40 milligrams or sometimes even 20 milligrams of cabozantinib if there's concern about ability to tolerate side effects. Treatment with molecularly targeted agents like cabozantinib, sunitinib, everolimus, and belzutifan is typically continued until there is evidence of disease progression that warrants stopping the therapy, or if treatment needs to be stopped for other reasons like side effects. I want to just make a point that there are a number of different considerations in the management of neuroendocrine cancer, so it really is not a one-size-fits-all approach, and we do need to think about tumor-related factors, and I've listed some of the important factors that are considered as treatment decisions are being made, and this includes primary tumor location, some of the pathologic features like differentiation grade, the extent of spread, whether tumor is somatostatin receptor positive or not. For example, if the tumor does not show up universally positive on a dotatate PET CT scan, PRT may not be the best treatment option. The other factor that's related to tumor that needs to be considered is functional status, and that is whether or not symptoms related to hormone secretion are present. Some of the patient-related factors I've already alluded to, and importantly include medical history and other medical conditions and performance status, how well patients are feeling and able to do their usual activities. Some of the other important treatment-related factors now include not just side effects, but how the treatment is administered, what's required with giving it, and that's like oral daily dosing is very different than giving something that's intramuscular once every month or subcutaneous once a month or intravenously. So we do need to consider mode of administration, schedule of administration, whether that treatment is available, and also cost. So this slide, I'm not going to walk through everything in detail, but I just wanted to kind of summarize some of the important considerations for tumor control in advanced neuroendocrine tumors across the various classes of systemic therapy, including somatostatin analogs. These, again, are really important for controlling disease progression and also improving hormone syndromes. The targeted agents are used in pancreas neuroendocrine tumors, and in the case of everolimus and cabozantinib, extrapancreatic neuroendocrine tumors, they mainly work by slowing progression. In some cases with cabozantinib, there can be some shrinkage. PRT is restricted to patients who have somatostatin receptor positive tumors. The approval is in GI and pancreas neuroendocrine tumors, but we sometimes can consider this as off-label therapy for patients with somatostatin receptor positive lung neuroendocrine tumors. They slow disease progression, and as I mentioned before, can be associated with some shrinkage, especially in pancreas neuroendocrine tumors or higher grade disease. And you heard in the talk before me about chemotherapy and how chemotherapy works. And really, especially in pancreas neuroendocrine tumors, regimens like capecitabine and temozolomide can be important for slowing progression and achieving some shrinkage. So I'll just leave with a few parting words about navigating targeted therapies and PRT for NET in the broader landscape of treatment. So again, TRT with lutetium-177 dotatate is often utilized for advanced GI or pancreas neuroendocrine tumors following progression on a somatostatin analog, but can be utilized as an initial therapy for patients with higher grade disease, particularly when there's a higher burden of disease that may warrant an earlier and more aggressive approach to treatment. The molecularly targeted therapies for progressing neuroendocrine tumors include everolimus, the tyrosine kinase inhibitors, cabozantinib, and sunitinib, and also belzutifan for patients who have VHL disease. Also important to recognize that treatment selection really does need to be individualized and made with multidisciplinary input. So I hope that information was helpful for you, and thanks for your attention, and I'm looking forward to the question and answer session. Thank you.
Hello, my name is Thor Halfdannerson. I'm a medical oncologist at the Mayo Clinic in Rochester, Minnesota. Today we will be discussing how to navigate clinical trials, and this will not be specific to neuroendocrine tumor trials, but to all clinical trials we see in oncology. So why do we do clinical trials? Well, we do it because the treatments that we give should be given not because they ought to work, but because they do work. And there's only one way to find out if they do, and that is by rigorously testing an intervention, such as a treatment, to see if it is safe or effective. The only way to do that properly is in the context of a clinical trial. So what are clinical trials expected to do? Well, they are expected to do many things, but really they are expected to test new good ideas, hoping to make a difference for patients, whether that's treatment or something else. I wanted to take you through some of the basics of clinical trials, including the low participation. So up to 40% of patients with cancer may be eligible for a clinical trial participation at some point in the course of their disease. But still, fewer than 10% end up participating in a clinical trial. But we also know that if patients are offered participation in a trial, over 50% will agree to participate. So there's definitely an interest, but the opportunities maybe not. And there's a lot of different reasons for low participation in clinical trials. So one could be that there just isn't a trial available anywhere close to you. Your provider, your oncologist, or whoever is taking care of you may be unaware of clinical trials, not used to suggest clinical trials, or just simply too busy to consider a trial. Sometimes the inclusion criteria are too strict, they don't really fit you. Sometimes there are concerns about receiving experimental therapy or placebo therapy, essentially ineffective drug. Sometimes there are concerns about the risks and side effects of a new therapy. So there's a lot of different things. But lastly, there is the concern for financial strain and time toxicity. So time toxicity is really the time spent coordinating, waiting for care, receiving care, all the time that goes into receiving care. So what is a clinical trial? Let's start by a definition. So the World Health Organization, WHO, has a definition for a clinical trial, and you can see that there. So a clinical trial is any research study that prospectively assigns human participants or groups of humans to one or more health-related interventions to evaluate the effects on health outcomes. And who does clinical trials? So institutions, cancer centers, clinics do trials. And every study is led by a principal investigator who typically is a medical doctor, but not always. There's usually a global PI or principal investigator for the trial. Let's say we have a trial that's being run across multiple different countries. There's one PI that's called the global PI, but each participating institution has its own institutional principal investigator or PI responsible for running the trial within that institution. The trials can be funded or sponsored by multiple different mechanisms, such as federal agencies, including the National Cancer Institute for cancer trials, often through what's called cooperative groups, which is really a group of multiple different cancer centers that join forces together to run clinical trials. Sometimes it's sponsored by pharmaceutical companies that they contact different cancer centers individually to ask if they'd be willing to participate in the trials. Academic medical centers can have trials within a single center, and there's a whole host of other organizations that can fund and run clinical trials. So what are the reasons for doing trials? So to add medical knowledge regarding treatment, diagnosis, prevention, and more. And also to evaluate an intervention. And the intervention could be medical therapy or a procedure or a screening procedure for treating a disease. And also to discover ways to prevent a disease or prevent recurrence of a previously treated disease. So it doesn't always have to be one particular therapy. And then also, and very, very importantly, trials are done to investigate ways to manage symptoms, to improve or maintain quality of life of patients with disease. In our instance, someone with a neuroendocrine tumor. So clinical trial participation is by far the best way to move the field of medicine forward. Without trials, there will simply be limited advances in therapy. So when is it appropriate to participate in a clinical trial? It's always worth considering participation in a trial. But it may not always be a trial you want to do. So the trial you consider should be applicable to your situation. It should ask a relevant question that might help you or others in a similar situation. It should have the potential benefits and risks clearly explained to you, and it should be feasible for you to participate in. So who can participate in a clinical trial? So each trial has what we call eligibility criteria for patient participation. So those criteria should be clearly stated in the treatment protocol. So what are we studying? What disease? In this situation, what type of a neuroendocrine tumor is being investigated? So that be clearly spelled out in the protocol. What prior treatments are allowed? Some trials allow multiple prior therapies, others allow no prior therapies, and some allow one or two prior therapies. So you have to make sure that the trial is really a good fit for you. And some trials evaluate the new experimental treatments where there are no other good trial options. And then, are there any conditions that preclude trial therapy? So a lot of trials have fairly strict requirements regarding organ functions, such as kidney and liver function. Some of them might even have too strict criteria. And then patients who are not doing well with what we call poor performance status, including patients with brain metastases, are often excluded from trials, which is also unfortunate because some of these patients are those who perhaps need better treatments the most. So many of the trials simply just have too stringent eligibility criteria. So we need to get more pragmatic trials as we're currently leaving many patients out of trials. So let me go through a few of the clinical trial types that we have. So we have prevention trials. So now we're looking at the prevention of disease in individuals at risk. And there can be let's say a trial that looks at a certain supplement or physical activity, those kinds of things, or doing a procedure to look for a cancer like colonoscopy to prevent colon cancer. Then we have screening trials. That actually fits better the colonoscopy example I just gave you. So finding disease early, treating more effectively. For neuroendocrine tumors, we don't really have a whole lot of these trials yet, but hopefully we will. Then there can be diagnostic trials. So we have a new diagnostic method. This could be a scanner, like a scan of some sort, let's say a new PET scan or a new biopsy or a new blood test, a genetic blood test, to identify better and more accurate diagnostic tests. And those are typically compared to sort of what we call the standard of diagnostic tests, just to see if the new test performs better. And then lastly, we have the treatment trial. So in this situation, we're looking at improving outcomes of patients with a condition such as a neuroendocrine tumor, looking to prolong life, delay tumor progression, or improve quality of life. We often talk about the 3 phases of clinical trials. There might be more than that, but let's just focus on those 3. So phase 1 trial, really that looks at if an intervention, such as a drug, is safe. So we test a new treatment in a small group of healthy volunteers that can be sometimes between 10 and 40 people. We look for safety, side effects, see how the body handles the treatment, and then often we treat 2 or 3 patients at a time, and we see how they do, and then we offer more patients. We're really not looking at the efficacy of the treatment. Then we have phase 2. So now we're typically looking at larger groups of patients. So looking for a signal of efficacy. So does this intervention, this drug, this new treatment, does it work? Does the dose that we identified in the phase 1 trial seem to be effective and safe? And then we gather more information on side effects and safety. And then we have the phase 3 trials, which typically are now looking at the new treatment that we've previously investigated in a phase 1 or even phase 2 trial and see how that compares to a standard treatment that's out there. So, for example, we have one treatment for someone with a neuroendocrine tumor that's been established, and now we have a new treatment, and we're comparing those two to see, is the new treatment better, same, worse, and is it safe? And typically that involves a larger number of people, so usually more than 100 in the trial, sometimes a lot more than that. And then if all of these trials sort of go through these different stages and we confirm there is efficacy, this is an effective drug or intervention, it's safe, then the pharmaceutical company or whoever is sponsoring the trial can seek an FDA approval. And ultimately, that's how we get the drugs approved. So I want to talk to you a little bit about the randomized clinical trials, because this is something that I get a lot of questions about. So not all trials are randomized. Typically, phase 3 and sometimes even phase 2 trials are randomized. So then we're comparing 2 different treatments. So we have patients who are eligible. We've gone through all the lists and we know that they are eligible for this trial. Then we randomize them 1 of 2 or sometimes even 3 or 4 groups. So one would be the experimental treatment, what we're testing, and that's called the experimental arm. And then we have what we call the reference or the standard treatment or the control treatment, and that's often called the reference or the control arm. And now we compare the 2 groups and we see how they do. And that gets us to the next point. What are we actually looking at? So this is something called clinical trial endpoints. So all trials have to have certain endpoints. Endpoints are what the trial is supposed to measure, and they can be all sorts of different things. They can be finding the appropriate dose, the safe dose, or they can look at how effective a drug or an intervention is. Most trials have a primary endpoint, so that's the big question we're trying to answer. And then there's a whole host of little questions, well, not so little actually, they're also important, and those are called the secondary endpoints. And then we sometimes have exploratory endpoints. We're running a trial and we have this new test. We're really not testing that test, but it's the perfect situation to test like a new marker of activity or toxicity, and those are called exploratory endpoints. So let's talk about the common endpoint for a trial called the median survival. The median survival is really trying to, in many instances look to see how long a patient lives on a clinical trial or how long a certain treatment works until it doesn't work anymore. And so it's a time from a diagnosis or start of therapy until half of the patients have experienced the event of interest, which is our main trial endpoint. That could be tumor growth or it could be death from any cause. So these numbers really only apply to individuals. And the very common endpoints are what's called overall survival, that's life expectancy, progression-free survival, which is the time until the tumor is growing. A common endpoint for trials done after surgery is what's called recurrence-free survival. So someone has an operation for a tumor, and then now we look to see how they do after the operation until the cancer comes back. And that would be called the recurrence-free survival. And this is something that the trial has to be clearly spelled out in the protocol before we start the treatment on the study. So let me try to explain the median survival. So this could apply to, like I said, life expectancy, time to cancer coming back after surgery, or time to tumor growth. So we start with a set number of patients. So you can see the patients in the upper left corner there. So this is the beginning of the treatment. And then after a certain amount of time, half of the patients have experienced the event of interest. Let's say in this case, it's tumor growth. Now, after a certain time, half of the patients have had the cancer grow. And then when that happens, we determine the time until half of the patients have had the tumor growth or the endpoint we're interested in. That is called the median survival. So as you can see, this doesn't apply to individuals. This applies to groups of people. So it's not always life expectancy. As I said, it can be until tumor growth or recurrence, and there's a whole host of other endpoints we can look at. So let's talk a little bit about something called crossover design, because this comes up quite a bit. So patients are interested in a clinical trial testing a new drug, and you may be randomized to a standard treatment, but half of the patients get the new treatment. And people will ask me, so what if I get randomized to the standard treatment? If it doesn't work, can I go on and get the active or the experimental treatment? So again, we look at the patients, see if they meet all criteria for enrollment. And if they do, then we would obviously talk to them about, are they comfortable with this? Are they comfortable with getting an experimental therapy, or are they comfortable with getting standard therapy? And then we randomize them. So this is done typically nowadays by a computer. So it's a computer that essentially flips a digital coin of some sort and decides on who gets what. So there's an intervention, which is, in this case, let's say the experimental treatment. And then we monitor the patient until there's tumor growth or progression. And then that patient comes off study. So this is for the experimental arm. Well, what about if you get randomized to placebo or to standard therapy? It doesn't have to be placebo. It could also be sort of an established therapy. And you're on the placebo or on the standard therapy, and they're monitoring you really carefully with scans, as we do on both arms every so often. But then there is tumor growth. The crossover design allows you to switch over or cross over to the experimental arm. And now the clock starts again. So now you've started the experimental drug after having completed your time on the reference arm or the control arm. So let's move on to clinical trials in practice, so how this all works for us in the clinic and for you in the clinic. So first, we got to find out about clinical trials. So where do you find out about a trial? So you ask your oncologist. If needed, get a referral to a cancer center that has a trial, and you can look for trials using search tools like the Ancora tool there, or you can just navigate to ncf.net and look for clinical trials there, which is a very useful clinical trials finder. And then you have to talk to your oncologist or your provider about the trial versus doing available standard therapy. And I'm not saying a trial is for everyone. Some people are just uncomfortable with it, or they don't have the opportunity of doing it. The trial has to make sense for you and offer you a treatment that has a chance of working. And then you have to ask yourself and your provider, if I participate in this, do I burn bridges for future therapy? Usually that's not the case, but just ask, because some trials will not allow you to get certain treatments in the future. Typically not a problem. And then what is involved if I decide on participating? Because this could be a substantial time commitment. Some trials offer financial assistance with travel and such, and some trials are now starting to do some of these things remotely. So how do we enroll patient on a clinical trial? So someone is in my clinic, let's say, has a neuroendocrine tumor, it's growing, we've been on standard therapy, and it's time to change. So we've identified a trial option. Sometimes we have systems in our electronic medical record, so the patient has been flagged as a potential trial candidate. Or sometimes the patients or the families have identified the trial and they come to me and say, hey, tell me about this trial you have. And then we do the eligibility check. And if you don't meet the criteria, then obviously you're not eligible. Then we talk to our patients and to the family and friends, and we discuss the trial to see if it's feasible. And sometimes after hearing about all the details, they say, no, not interested. And then if they are interested and meet the criteria, now they meet with the trials coordinator and sometimes a research nurse and talk about all the details. And sometimes they find out after hearing all the details that they're not interested. Well, assuming they are all interested in this, we do a final eligibility check. That may sometimes require additional testing to be run. And occasionally we find out that someone we thought was eligible for a trial is no longer eligible because we did that extra test and now they are no longer eligible. If that happens, there's no enrollment, then we'll just look at other options. If there is eligibility, so they meet all the criteria after going through all these steps, then we enroll the patient on the trial. So what happens once you're on the trial? So every trial is obviously different. They follow a very detailed protocol with like trial visit schedules, all of those things. And you can always come off the study if this is not comfortable for you or you decide that you don't want to be on the trial anymore. You can stop the trial. And then you meet with different team members on different occasions. So clinical research coordinators, clinical research nurses, clinical providers, which are doctors or advanced practice providers, sometimes learners like fellows and others who are learning how to run clinical trials. So just to wrap up, it's always worth considering participating in a clinical trial, but it has to make sense to you and it has to be something you're comfortable with. And there is no better way to advance the science and improve patient outcomes than participating in a trial. Thank you very much.
Hello, I'm Pam Coons. I'm a medical oncologist at Yale School of Medicine and Yale Cancer Center, and it's a pleasure to speak to you today on navigating treatment sequencing. These are my disclosures. So today I'm going to talk about treatment sequencing, how we make decisions as a team. We'll talk a little bit about the differences between neuroendocrine tumors and neuroendocrine carcinomas in terms of treatment sequencing, and then discuss what this means for you. So I like to start with this timeline just to really share how far we have come in terms of treatment advances for patients with neuroendocrine neoplasms since the 1980s. We've just had an explosion of research demonstrating kind of above the timeline advances in imaging and below the timeline advances in treatments. This has made treatment decisions in terms of how we think about sequencing treatments very complicated. And there's so many treatments and it is objectively very confusing. And so we want to try to help provide some clarity around that for you. So what is treatment sequencing? We really think of it as the right treatment at the right time, with the understanding that plans can change over time and that there are multiple treatments that you may need over time. And so for patients of mine that are listening, they know that I use the toolbox analogy. So I'll describe that for all of you. So let's say we have an empty toolbox. So we start with number 1. We then have several tools that we can use at number 2. And we want to try to add those tools to the toolbox. We tailor that for patients. So one patient may start with the pliers and then get the screwdriver and then get the hammer. And then another patient may get those tools or treatments in a completely different order. So what I'd like to talk about next is how we think about making these treatment decisions. What guides us? So I use these 8 separate variables to think about doing that. So functional status, meaning whether or not your cancer secretes a hormone. Where did the cancer start? That's the primary site. Stage, volume of disease, degree of differentiation and grade are both features from the pathology. Somatostatin receptor status, and then your goals are a very important part of this treatment decision. Optimal care really requires expertise and multidisciplinary coordination. So in terms of neuroendocrine tumors, the goals are to control growth, reduce symptoms, maintain quality of life, and ideally prolong survival. And for neuroendocrine tumors, starting treatments in the oncology lingo, we call that first-line treatment. We can think about using somatostatin analogs like lanreotide or octreotide. Dr. Pegna will be talking about that, or has already. And surgery, Dr. Halle already discussed that. And then watchful waiting. And watchful waiting would mean if a patient is asymptomatic, maybe newly diagnosed, we may think about watching with serial imaging before even starting treatment. And there are select patients for whom that's appropriate. If the tumor grows, and in oncology lingo, we call that the second line or beyond treatments, we think about radioligand therapies, targeted therapies, chemotherapy, and liver-directed therapy. And Dr. Chan spoke about radioligand and targeted therapies, and Dr. Sulin talked about liver-directed therapies. So systemic treatments for patients with advanced disease fall into four main categories. You've heard several talks on these already, but just to kind of bucket them for you. So somatostatin analogs, we said, could be used often in the first-line setting. Then radioligand therapies is another bucket. Targeted therapies include everolimus, sunitinib, and cabozantinib. And then cytotoxic chemotherapies include both IV and oral chemotherapies like streptozocin, Cape-Tem, Cape-Ox, and Fulfox. So the next step, we have all of these different treatments. So in those 8 factors that help us make those treatment decisions, the goals of treatment include stabilization and response, i.e. shrinkage. And then we think about the side effects. Are the side effects pretty minimal, or does a treatment have more side effects? And so as we think about those 4 buckets of systemic treatments, and as I'm talking with patients and thinking about how to tailor those treatments, we also will discuss, well, somatostatin analogs in general will yield stability, and they're very well tolerated. So it is for patients that maybe don't need shrinkage of their tumor, but stability would still be considered a win. If a patient needs shrinkage, we then think about going to radioligand therapy or cytotoxic chemotherapy, but those are going to have more side effects. So you can see it's this really tricky balancing act. I want to just talk to you about how oncologists, whether it's a NET expert or your community oncologist, makes these decisions. So the NCCN Neuroendocrine Tumor Guidelines, that's the National Comprehensive Cancer Network, has guidelines for physicians. There are neuroendocrine tumor patient guidelines that are really wonderful. So there are algorithms in terms of how to use these systemic treatments. We are starting to get more data around the lines of treatment. But at present in 2026, we have all these tools for that toolbox. And really the way that we primarily determine sequence is based on those 8 factors of primary site and patient goals and grade, et cetera. What's really exciting is that several recent clinical trials have either evaluated sequence or some new ones are starting to do that. So in the early days of clinical trials for NETs, we generally compared a treatment to a placebo, but most of our recent trials are comparing active drug to active drug, and that is helping us to teach us if one treatment is better than another. So the top 4 trials, NETTER-1, NETTER-2, COMPETE, and OCLA-RANDOM, all compared an active treatment versus radioligand therapy. In all 4 of those trials that are now complete, the radioligand therapy did better. These were in various lines of treatment. I think importantly in COMPETE and OCLA-RANDOM, we know that ludotatide or luetitriotide did better than everolimus and sunitinib. So the way I use that information is I typically use everolimus and sunitinib a little bit later in a patient's treatment course. Sadly, the CompareNet trial actually closed early due to low accrual. This was a national clinical trial network trial, which is conducted through the federal government. And sadly, we couldn't get enough patients. And so this is a very practical trial. And I get asked for patients with pancreatic NETs, should we use Cape-Tem or ludotatate? And this would have been a way to answer that. And sadly, we may not formally have a trial that gets at that answer. This slide talks about NEC, or neuroendocrine carcinoma, and how it's different. So for neuroendocrine carcinomas, how is that different? Well, they tend to be faster growing. We often need to start treatment more urgently. And the treatment is a lot like small cell lung cancer. And actually, many of the principles are based on how we treat small cell lung cancer. And we often extrapolate. And so we're starting to get more trials that are based on some trials from small cell lung cancer. So the NEC systemic treatments fall into two main buckets. The first line or starting treatment is usually cytotoxic chemotherapy with platinum etoposide. There are some other chemotherapy combinations. The acronyms are FOLFIRINOX and FOLFOX. And then immunotherapy has been studied in some small trials, including immunotherapies like pembrolizumab, ipilimumab, and nivolumab combined. We have some ongoing clinical trials in these extrapulmonary neuroendocrine carcinomas looking at immunotherapies, so we'll have to stay tuned on that. So this is an excerpt or an adapted version of the NCCN guidelines again for GEP-NEC systemic treatments in 2026. So I've listed several other types of chemotherapies, but the carboplatin etoposide or cisplatin etoposide is really considered a first line or starting treatment. But then we have several others that we can fall back on in the second line and beyond, including immunotherapy. Occasionally we will use local regional therapy options such as radiation. But again, that's very patient specific. I didn't mention when we talked about NETs, but clinical trials are always part of this conversation. And if we think back to that toolbox analogy, when I am talking with patients about a new treatment or a change of treatments, we'll always talk about standard of care options and clinical trial options. So what does this mean for you? I think that there's no single right order. And another way to think about it is that there are several options for you. Plans may need to adapt over time. We really encourage you to ask questions about why we're making the decisions we're making. And again, you have options. So let's put our knowledge to practice. So I'll remind everybody, these are the 8 key variables that help us make treatment decisions in terms of sequencing: functional status, primary site, stage, volume of disease, differentiation and grade, somatostatin receptor status, and your goals. So we're going to do 2 cases together. So this is a 60-year-old woman. She has a newly diagnosed metastatic, non-functional, well-differentiated grade 1 NET of the small bowel. The Ki-67 is very low, it's 2%. And she has low volume liver metastases, generally meaning that they're small. This was in fact found incidentally at the time of a hysterectomy. And so she was completely asymptomatic. Her small bowel primary tumor was surgically removed. And then we're thinking about, well, what's the best first line or starting treatment for her? So the top is a picture of her abdomen. It's an MRI. It is a cross-sectional image. So think of it like a bread slice through your body. And this just captures a portion of the liver. The liver is on sort of screen left, but it's sort of physically and anatomically on your right. You can see some small darker spots in the liver. One of them is measured. You can see that there. It's 16 millimeters. Another way of looking at this is with the gallium-68 dotatate PET CT. And this shows some of those dark spots in the liver. Those represent the neuroendocrine spots. So again, best first-line treatment options include observation, a somatostatin analog, ludotatate, capecitabine temozolomide, or liver-directed treatment. And so as you're thinking about that, I'll tell you the correct answer. And there's actually probably 2 correct answers here. So one would be observation, and a second would be a somatostatin analog. That decision, I think of as shared decision making with the patient. It is very difficult to tell a patient that you have a newly diagnosed cancer and we're not going to treat you with anything. But if I then go deeper into the rationale, the clinical trial actually proved and showed that octreotide and lanreotide worked. The patients who got placebo had several months, in fact, up to a year and a half on the lanreotide trial before they had any progression. So for select patients, watchful waiting with serial imaging may make some sense. But if a patient is very worried about not starting on something, that's exactly when we have that conversation. And that would be consistent with a patient's goals, perhaps to start a somatostatin analog. Okay, one more case. So this is a 60-year-old woman with a 2-month history of abdominal pain, GI upset, low appetite, and 10-pound weight loss. So note immediately that she is symptomatic compared to our last patient. The MRI showed a hypervascular pancreas mass and large liver lesions. A liver biopsy showed a well-differentiated grade 1, Ki-67 2% net. These are both MRIs. So in the upper panel, you can see a large liver lesion that's up to 58 millimeters or close to 6 centimeters, sort of the size of an orange. On the bottom panel, towards the right, there's a 23 millimeter pancreas mass that's over along the right side. So same question, what's the best first treatment for her? Somatostatin analog, lutetium dotatate, capecitabine temozolomide, cabozantinib, or liver-directed treatment. So as you're thinking about what we learned today, we really need something that has the potential of shrinking the cancer because of how symptomatic she is. The two main options include lutetium dotatate and capecitabine temozolomide. So sadly, we won't have that trial that was comparing those to answer that question. Again, I will talk with patients about what side effects can be expected with both treatments. Patients will often get both of these in their lifetime. So really, it's just a matter of tailoring and thinking about both logistics of treatments and side effects that help us make that decision. But both are correct answers. So just to wrap up, treatment is a journey and plans evolve over time. You have multiple right options. Clinical trials are an important part of that and really a wonderful way to continue adding tools to the toolbox. So as you are exploring new treatment options, whether it's a first treatment or whether it's a second or third treatment, please be sure you're asking your treating team if there are clinical trials for you. The right treatment depends on your tumor and your goals. You are a critical part of this decision making. We really encourage people to ask questions and be part of that shared decision making. And the goal is to both control the cancer and help you maintain excellent quality of life while we do it. So thanks for the opportunity to talk to you today about sequencing. It's a tricky area. I'm happy to try to answer questions later. Thank you.
Hi there, this is Jason Starr coming to you from Jacksonville, Florida. I'm a medical oncologist over at Mayo Clinic, specializing in neuroendocrine cancers with a passion for helping patients in need with this disease. Anytime we start a treatment, I'm very judicious and I come up with a scale here to exemplify that. In terms of when to start a therapy, is the timing right? There's a lot of nuance with selecting time of therapy, but once the shared decision making between the patient and the oncologist is, you come to the point where you say, okay, we need to start a new therapy. You have to balance the efficacy and the side effects. And side effects go in with quality of life, right? If you're on a therapy, you want to be living your best life and you want that therapy to work. I would say when the scale gets tipped in terms of the balance of the side effects becoming so great, the efficacy becomes maybe even less relevant, right? Because if day to day it's a struggle, but the therapy's working, at some point you may ask yourself, is this worth it to me, right? And that's a very individualistic decision. So one of the rules of thumb that I have is always err on holding the medication. in that you're going into the weekend, it's a Friday, you're waiting for a call back from the medical team, and you're experiencing significant side effects, diarrhea, fatigue, or skin rash, anything obviously that needs urgent evaluation, you want to consider going to the emergency department or, an acute care clinic if the medical facility has that. But holding the medication is always the best strategy in that, the faster the drug kind of gets out of the system, the faster the side effects resolve. And it's not going to be detrimental to your overall treatment to hold the medication for a short period of time. And then maintaining that active dialogue with the medical team. Hopefully the medical team has a system in place where you're experiencing side effects, they're doing a check-in a few days later, they're bringing you in, they're checking the lab that may be in question. So it's just a matter of having that two-way dialogue going on with your medical team so that they know how you're doing and you can express yourself in terms of any concerns that you have. So many offices we have at Mayo Clinic have an acute care clinic where the providers may not have opening on their schedule or calendar for that day, but you can come in and be seen, usually an advanced practice provider, an APP, for evaluation, IV fluids, determination of how the severity of whatever side effect that you're experiencing. And one thing that I really stress to my patients is one dose does not fit all. So along the way, you may require a dose reduction, and that's dialogue that you can have with your provider. So we're going to review potential side effects of somatostatin analogs, which are probably the most commonly used medications in neuroendocrine tumors. We're going to talk about lutetium-177 dotatate or Lutathera. We refer that class of medication as PRRT, peptide receptor radionuclide therapy. And to complicate things, some people now refer to it as RLT, radionuclide labeled therapy, both the same thing. Everolimus or Afinitor, capecitabine or temozolomide, which we refer to as CAPTEM, and then tyrosine kinase inhibitors, sunitinib, which is the old school one, maybe 2011 got FDA approved, and then cabozantinib or Cabometyx is a medication that was approved last year, which is also a tyrosine kinase inhibitor. So somatostatin analogs. And you'll see there's a lot of potential side effects. And that's why, although it's a synthetic hormone that your body makes naturally, there's side effects, right? So even though it may be like, oh, we're going to start a hormone therapy, it's an injection once a month, it doesn't come without potential side effects. Some patients have diarrhea for a day or so after injection. And that could be ironic in the fact that sometimes we are using the medication to treat diarrhea, whether it's related to carcinoid syndrome, but sometimes that diarrhea can briefly worsen. A lot of times for patients with carcinoid syndrome, they actually notice pretty rapid improvement. Usually the diarrhea that I see is in patients without carcinoid syndrome. Nausea and vomiting. This medication kind of slows everything down, right? It's an inhibitory hormone. It slows the digestive system down. So sometimes it will delay stomach motility or stomach movement. Similar to how the GLP-1 agonists, those new drugs that we use for weight loss work. So that can lead to nausea and or vomiting. And then exocrine pancreas insufficiency, EPI. This is really common. Actually, Dr. Lowell Anthony, who's one of the godfathers of neuroendocrine tumors, told me once upon a time that patients, by definition, develop exocrine pancreatic insufficiency when they're on these medications. That's how you know that you're on a therapeutic dose. And again, the drug makes things lazy. It makes the pancreas lazy. It doesn't damage the pancreas, but it makes it lazy. And why do you need your pancreas? Well, there's a hormone side to it, right? Regulate your blood sugars, for example, insulin, another hormone called glucagon that helps regulate your blood sugars. But then there's the other component of the pancreas that helps with the digestion, and more specifically, fat digestion. So if you eat a fatty meal, you need your pancreas. It makes an enzyme called lipase to help you digest your food. When you're on these medications, you will get a lazy pancreas. A good majority of my patients are on pancreatic enzyme replacement. And there's over-the-counter pancreatic enzymes, and then there's prescription strength ones. So you should talk to your doctor if after you eat a meal, you get bloating, gas, just don't feel right, especially after a fatty meal, you have exocrine pancreas insufficiency. I don't do any fancy testing to make this diagnosis. For me, it's a clinical diagnosis while on these medications. Blood sugar fluctuations, as we said, the other component of the pancreas is the endocrine side. I see some high blood sugars more common than low blood sugars, but I do have some patients who develop low blood sugars to the point where, they have to be careful and carry glucose tablets around with them. Gallbladder problems, again, it's a lazy hormone, so it slows the contraction of the gallbladder. This predisposes patients to gallstones and gallbladder issues. So you develop some pain in what we call the right upper quadrant, radiates to the back, worse after eating, it might be the gallbladder. Injection site pain. A lot of patients will describe little like knots or nodules at the sites where the injections are done. Those shouldn't really happen if the injections are being done right. So they should be thawing out the medication for the appropriate amount of time, not bunching up the skin when they're doing the injection. So you just want an experienced nurse doing the injections. But one thing to decrease the chances for injection site pain is to put a lidocaine patch on the area. So I prescribe those very often. You put it on before you go in, right where you're going to get the injection. The nurse will take off the patch and then go ahead and do the injection, and the area is numb. So it's a nice trick, and some of my patients really appreciate that. So less common side effects, I've seen some blood pressure changes, particularly increase. I've seen some patients develop joint discomfort. I've seen some low heart rates, so what you call bradycardia, which is a decreased heart rate. I've seen headaches. I've seen fatigue. I had one patient who had really debilitating depression after getting the injections. So you'll see at the end of the talk where one of my rules of thumb is that if you get a medication and you develop a side effect, it's the medication until proven otherwise, right? You can try to explain it away, but if you're putting something into your body and you develop a symptom, it's that something you put into your body. Lutathera, so that's that class of medications called PRRT or RLT. Now, Lutathera is the kid on the block that's been there for the longest. It got approved in January of 2018. There are some drugs very similar to Lutathera that are going to be coming available in the very near future. So that can be a discussion that you have with your oncologist. But these side effects are within this class, I would say, of therapies. So the Lutathera, as it is right now, is given once every 2 months as an IV infusion for 4 doses. Some patients do develop some nausea and or vomiting on the day of the infusion. This was a big problem before we were compounding the amino acids, so we were giving a less specific amino acid solution. This has been obviated and eliminated in terms of now that we use a compounded amino acid solution. We don't see that at all with that amino acid solution. So nausea is typically not an issue. We do give an anti-nausea medication just in case, as the actual Lutathera itself can cause nausea in a percentage of patients. Diarrhea, some patients get that for a day or so after the treatment, usually very mild. Fatigue is the prevailing side effect that most patients experience. It can be present throughout the treatment. It can happen for a few days after the treatment, and it can actually persist for a few months beyond the treatment, because we know that the therapy, once it kind of goes in there and does its thing, can continue to work. Although the drug is out of the system, the effect on the cells can still be going on. So patients can continue to have some side effects. So don't rule that out. Hair thinning is typical, but not loss. I haven't really seen hair loss, like complete hair loss, but thinning for sure. It can sometimes temporarily worsen carcinoid syndrome, particularly if a patient is having carcinoid syndrome and the symptoms are quite severe. That first dose can definitely trigger worsening of that carcinoid syndrome. So we utilize short-acting octreotide, which is a subcutaneous injection as a rescue medication. But remember, the day of your Lutathera, you also will get your long-acting somatostatin analog, whether it be lanreotide or octreotide LAR. Less common side effects that I've seen, joint discomfort. So I have patients use NSAIDs like ibuprofen, but sparingly. Kidney problems, typically in patients who have kidney issues, it can exacerbate pre-existing kidney issues. Infusion reaction. I did have one patient who developed anaphylaxis, which is like a severe allergic reaction with Lutathera. Very rare. I've treated over 100 patients with this therapy and seen it one time. Bone marrow suppression is the most common lab abnormality. So if you get your labs, you will notice maybe a low hemoglobin, which is consistent with anemia, which is your red blood cells. You may notice low white blood cells, and also most commonly low platelets. Platelets help clot your blood and clump up together to help you prevent bleeding. Usually the extent of the low platelets is very mild and not severe to precipitate bleeding. And there is a small but very real risk of leukemia. And the studies quote 2 to 3%. We think it might actually be a little bit higher than that, maybe not a lot higher than that, but that's what we've seen in the studies so far. That is absolutely something that needs to be discussed with your provider. So let's go to everolimus or Afinitor, kind of a tried and true therapy, very effective for some patients. The FDA approved dose is 10 milligrams. My philosophy is start low and going up to the recommended dose. If we start at the recommended dose and you get severe side effects, you kind of get snake bitten in that I don't know if I want to go back on that. I felt so badly. So I always say, start on the lower side and bump it up accordingly over the course of a month or two. Always recommend starting a dexamethasone mouth rinse, which is a steroid mouth rinse. Fatigue unavoidable with this drug. Everybody that I think I've started on it has had some level of fatigue. Other things that it can cause: diarrhea, skin rash, leg swelling. I've had to stop the therapy in some cases for patients who have had such severe leg swelling. Cough or shortness of breath. This one's really important. I've seen quite a few patients develop really quite severe inflammation of the lungs. Now, if you intervene quickly, you can prevent it from getting serious. But as soon as you develop some shortness of breath or cough, even if it's mild, just let your provider know. They should be asking you about this every time. The other thing I didn't put on here that I should have is it can suppress your immune system. It affects what we call the T cells. The T cells are really important with your, fighting infections in your body. So I have seen some patients develop lung infections related to this drug because their immune system was suppressed. And then the other thing is it can lead to elevated blood sugars and or lipids, particularly triglycerides. So your physician should be keeping an eye on your blood sugar and your cholesterol panel. So let's go to CAPTEM, which is capecitabine, one drug, and temozolomide or Temodar is the other drug. The drug schedule can be confusing. I recommend getting a calendar and mapping it out, because one of the drugs you take for 14 days, another drug you take for 5 days, but at the end of what we call the cycle, so days 10 through 14, it's given every 28 days. Getting a calendar and mapping it out is really important. Really also important is discussing with your provider the role of DPD testing. So what this is an enzyme in your liver that metabolizes the drug called capecitabine or Xeloda. Some patients are slow metabolizers, and if you metabolize the drug slowly, then the drug will become toxic in your body and would require a dose reduction. Now, my philosophy is I'd rather know that up front than know that in a reactive. So I like to be, proactive instead of reactive. So a proactive approach is to do this test, know the results, and get a dose appropriate for your body. So I would strongly advocate for this, and the FDA has put labels on the drug to also recommend this. Side effects for the capecitabine: fatigue, diarrhea. There's a rash that can develop on the palms of the hands and the soles of the feet. A drug which is an anti-inflammatory called diclofenac. It's also brand name Voltaren. It's actually over the counter now. You can use this twice a day on those areas, and it can help prevent that rash. So keep that in your back pocket if you're going to be on this therapy or you're already on the therapy. Mouth sores, joint discomfort I have seen. Temozolomide, nausea. This is the big one that I need to really emphasize. Please take your anti-nausea medication at least 30 minutes prior to taking your temozolomide. Otherwise, almost certainly you will develop nausea and probably vomiting. My patients will tell me, I forgot it once and I'll never forget it again, because it's miserable to feel nauseous and vomit while taking these therapies, at any time. Bone marrow suppression, so that's a really important one. So I have patients check their labs every 2 weeks for the first 2 months, just to make sure that the blood counts are appropriate, and then we kind of go to a monthly schedule after that. But you really have to watch your blood counts. I've seen some really severe low blood counts, and we're not able to predict which patients will develop that. So lastly, we're going to talk about tyrosine kinase inhibitors. So those two drugs are cabozantinib and sunitinib. We talked about at the top of this talk that one is the new school one, one's the old school one. Both are acceptable for prescribing and for treatment. The cabozantinib, the majority of patients on that trial, 60% or so, had to have their dose lowered from 60 milligrams to 40 milligrams. So my philosophy: start low, go slow. I start at 40 milligrams and see how patients tolerate that for, at least 2 to 4 weeks before ramping it up to 60 milligrams. I will say it can be misleading. Being on a pill is convenient for sure, but the side effects can be more than IV treat. So I think that collectively, between the physician and you and the shared decision making, it should be understood that these are real treatments, even though they come in pill form, and they need to be treated as such. Fatigue can be quite severe. I said kind of unavoidable on that end. Nausea, we can see in a certain amount of patients, so we just watch for that. Sometimes, again, you can take an anti-nausea medication before your therapy, and that's a fine strategy. Ondansetron is probably the most commonly used. Just be careful with constipation with that drug, but there's no issue with taking that before your therapy. Diarrhea, usually very easily managed with antidiarrheals such as Imodium or Lomotil is prescription strength. So usually if the Imodium isn't doing the trick, we'll prescribe Lomotil. Elevated blood pressure, very common and easily managed by your primary care physician or your oncology team. The impaired wound healing is important to point out because if you're going to be undergoing a surgery or a procedure even, you need to talk to your oncology team about holding that drug before that planned surgery or procedure, because even after, while the wound healing is occurring, you don't want to start the medication too soon. I have seen some bad outcomes in terms of wound healing issues after a surgery. There is a risk of bleeding and or clotting. This drug does affect blood vessel formation. So that's why you see some of these side effects in terms of blood pressure issues or bleeding and or clotting. The risk of bleeding and or clotting is low, but it is something that needs to be discussed. And if you have signs or symptoms, say you had swelling in your leg, it was painful, we would need to evaluate, make sure you don't have a blood clot in your leg, for example. You can develop a rash on your palms of your hands and soles of your feet, similar that we talked about the capecitabine. And similarly, with the diclofenac gel, we can use that to help prevent this. So that's a nice trick that is really a proactive, as we talked about, being proactive as opposed to reactive. Liver inflammation, quite common, and we usually just pick this up on blood tests. Usually you won't feel anything as it relates to this. So your blood tests will be monitored regularly, just like you would be on any other medication. And something that may be under-recognized is thyroid issues. This class of medications can affect the thyroid gland and make it kind of sluggish or lazy. So that needs to be monitored probably every 3 months or so by either your primary care physician or your oncology care team. So the take-home points are these. Early recognition of side effects leads to quicker resolution of symptoms. When in doubt, call your team, let them know what you're experiencing, and then again, don't hesitate to hold the drug. Aggressive management of the side effects will allow you to stay on the therapy longer. So having that dialogue with your team, and again, even though it's a pill, you may need to be seen once a week or once every other week to help tailor and manage these symptoms to get it right. Remember, one size does not fit all in terms of the dose. So dose adjustments are very common. Please don't take that as, oh, the drug isn't going to work now. We have to find the right dose that works with your body. And then please also let the team know about any supplements you may be taking so we could determine if any of those could be contributing to the symptoms. There's a lot of potential what we call drug-drug interactions. So we just have to know what you're taking. We're not going to judge. A lot of patients ask me about ivermectin or febendazole or mebendazole. I'm not going to judge, but we just need to know what you're taking. And then my rule of thumb. It is always the medication accounting for new symptoms that may appear while on the drug until proven otherwise. You take the drug, you get symptoms, it's the drug until we prove it otherwise. Thank you very much, and I hope you all enjoyed and had some things to talk to your physicians, help create a dialogue, and it was a pleasure being here, albeit virtually.
Hello, everyone. My name is Jairada Rivera. I am a medical oncologist at the National Cancer Institute, and it's my pleasure to be with you today and discuss when do we make treatment decisions in patients with neuroendocrine cancer.
Hi, my name is Chandrika Chandrasekharan. I'm a medical oncologist. I'm currently at MD Anderson Cancer Center in the Neuroendocrine Tumor Group. Thank you for inviting me to this panel.
And I'm Calesia Clark. I'm a surgical oncologist at the Medical College of Wisconsin. Again, really excited to be here today talking about my favorite topic.
Hi, everyone. I'm Eric Mitra, a nuclear medicine physician at Oregon Health and Science University, and great to be a part of this group. Thank you.
Thank you, everyone. One of the aspects in the management of patients with neuroendocrine tumors is to understand the decisions about the various therapies available for patients living with neuroendocrine tumors. And I would like to start a question to Dr. Chandrika. And the question that I would like to ask you is, when do you make the treatment decisions of a patient who is newly diagnosed with neuroendocrine tumor?
Yeah, I think I'm glad that our panel is very balanced with the different specialties here. I would like to say, if as much as possible, I would like to have the patient meet with the different specialties involved in this cancer's management through the course of their journey. Oftentimes, by default, patients end up first seeing the medical oncologist. In some institutions or some places, they may end up seeing the surgical oncologist. Dr. Mitra, who's a nuclear medicine, they probably are not maybe the first point of contact for a patient with this cancer. But with different clinical treatments coming up with PRRT upfront, certainly nuclear medicine or interventional radiology, the other specialties can also be part of the discussions in the very beginning. So I think the first thing for a patient when we see them is how symptomatic or how is this cancer affecting them? I think that's always the first question we all ask ourselves, because a lot of us know that some patients have no symptoms, just incidentally diagnosed, they had a scan for something else. I think the path we take definitely starts from symptoms and how the patient is affected by the cancer. I'm not talking about the mental agony of being diagnosed with the cancer, but just the actual physical aspects. And then a lot of us will make our decisions based on if we know the grade or the biology of the cancer. I think that's a good starting point for me always. And then figuring out from there, depending on the scales, the treatment options they may have, whether they need to meet a surgeon first, they need to meet, or are they very symptomatic? We need to think about maybe some patients PRRT first or embolization first. So symptoms, grade, and a presentation and the patient's preferences again.
And now that you mentioned PRT, maybe I can ask a question to Dr. Mitra about if you could maybe describe a little bit more in detail what makes someone an ideal candidate for PRT. Maybe you can discuss difference of PRT now that we have alpha and beta for our patients to know, and what PRT stands for. That would be great.
Sure. Yeah. So PRRT stands for peptide receptor radionuclide therapy. Currently, there's only one FDA-approved version of it, which uses this isotope called lutetium-177, which is a beta emitter. It's been around since 2018, and we have a lot of evidence in terms of how to use it. Typically, it's used as a second line or later treatment after some of the other treatments that my colleagues here will have done. But some of the new evidence that came from this study called NETTER-2 shows that you might actually be able to use it more as a first-line treatment, as Chandrika just mentioned. So that's something that we evaluate together in a multidisciplinary tumor board. Everything that we do often is based on the imaging. So once you have a PET scan done showing high uptake or low uptake, depending on what it shows, then we'll kind of discuss everything in the tumor board and then make a decision whether we should do the treatment earlier or perhaps do a different treatment up front. And then as far as the alpha that was mentioned, this is kind of the next generation PRRT that everyone is very excited about. There's a lot of ongoing research with that. Several different clinical trials are in sort of phase 2 and phase 3 right now. So we don't have any FDA approvals on those, as it probably get in the coming years. But once we do, most likely we'll be able to have both the standard lutetium PRRT as well as some of these alpha therapies available in the future.
Great. Thank you so much, Dr. Mitra. And that will be a following question as well for Dr. Clark, newly diagnosed patient with neuroendocrine tumors, that they have different presentations. Some of these patients may have more what we call localized disease. Some of those patients, they have more of advanced metastatic disease. And the question will be, when would you recommend surgery? When would you call our surgeons and make the treatment recommendations on a patient with metastatic neuroendocrine tumor?
I typically see two presentations for patients with neuroendocrine tumors that are newly diagnosed. One common scenario, unfortunately, is an intraoperative consult for somebody who has now a new diagnosis of a neuroendocrine tumor, but is presenting with a problem, an obstruction, a perforation, any kind of complication from the tumor. And obviously, in those settings, we often are offering a surgical procedure to palliate what the immediate problem that the tumor is causing. And that may not even be a curative or even truly cytoreductive surgery. We're just trying to manage a particular problem. that's becoming, I think, unfortunately in my practice, a much more common scenario for which I'm meeting patients for the first time. But I think a more typical setting is in a somewhat elective fashion. Typically, patients have been having mild or maybe nonspecific symptoms for sometimes years that were sort of unrecognized and undiagnosed, and now they've come to the new diagnosis of neuroendocrine tumor, and they're seeing me or my partner in a clinical setting. So we're fortunate enough, and I think as are probably all of the experts on today, to be at institutions where we have neuroendocrine clinical centers of excellence, and we're often seeing patients either on the same day or in conjunction with at least one of our partners. So I typically will see patients with my medical oncologist on the same day at the time of their initial diagnosis, and so they get to meet both of us. I'll talk with them in general about what the surgical options are for their particular disease. And then I'll mention to them that the good news is we actually have had an explosion of innovation in the space of neuroendocrine tumors, especially over the last 5 to 10 years. And so now we can actually have educated discussions about how to layer in each therapy to try to maximize survival for our patients. And so I'll often say, while technically your tumor is surgically resectable, we are going to have a multidisciplinary conversation where all of our experts can weigh in on what tools they have to offer. And we'll figure out what's the best sequence of therapy so that we can try to ensure that you are alive as long as possible and symptom free as much as possible from your tumor disease. So we almost never make the final recommendation for treatments at the initial visits. I almost always tell patients that we're going to discuss you in a multidisciplinary tumor board. We meet weekly. And so we usually set up a phone call or virtual visit right after that multidisciplinary tumor discussion to finalize what the treatment plan is going to be.
Thank you so much for that answer. And a follow-up question, one aspect, and that also has been discussed throughout the different talks today, is to also understand not only the difference in neuroendocrine tumors when a tumor is more indolent versus maybe more aggressive behavior or more rapidly growing tumors, but also in that sense, when we discuss about K67, does that help you as well to make treatment decisions and treatment recommendations?
Yeah, I think it has to be put in the context of a few things. So I would say often the first piece of information we have is the biopsy, which again, for patients who are newly diagnosed, just to clarify some of these terms, under the biopsy, we classify these neuroendocrine tumors basically into categories, grade 1, 2, and 3. The grade 1 is kind of the slowest, most laziest kind of tumors, then grade 2 is a little bit faster, and grade 3 is faster. So in that order, and then we also have some the same selecting very aggressively as a poorly differentiated neuroendocrine, what we call a carcinoma, very aggressive. So the biopsy is often our first picture into this cancer, the disease, and that's what we base what we expect it to be. Sometimes though we may have prior scans or images, so we have to also look into that. I always try to ask patients, have you ever had any scans for anything in the past that covered that organ? And that can give us a clue as well. Say we got a scan from 3-4 years ago and we found a lymph node that's in the abdomen now was also there, but that gives us an idea about the slow pace or biology based on if we have prior imaging. And then of course the clinical symptoms, right? So some patients clearly will tell us, gosh, I've had diarrhea going on for 3 years, this severe. And probably then they may have had a metastatic or a spread cancer with small bowel neuroendocrine already. So it's not just the Q67, and we have to realize that, we can't put our, like all the decisions just based on one thing, but certainly Q67 or the grade of the tumor is one of the first factors we have that helps us plan a move. Because clearly, if I see a patient who's got a biopsy that suggests what we call a grade 3 neuroendocrine tumor, or kind of the faster growing type, then I'm going to be a little bit on the guard and tell the patients, I'm going to watch you closer. I'm going to be more, maybe there's, we expect this may grow a little faster, but we don't know. So we have to watch you closer. Probably if I see a patient with a grade 1, no symptoms, I'm really going to tell them, or I also have a scan from 4 years ago that I see something that was there before, then it's very reassuring already. And we have, that's reaching the patient to us and say, listen, we can watch it. We may still see you 3 months, but probably we're going to be fine even if we see you in 6 months. And so K67 is one component, not the only component. Well, like 20% is a cutoff. It doesn't mean 21 is really bad and 19 is really good, right? So it's just it's just kind of an index. It's a continuum, as we say, meaning like we are estimating how many cells are dividing, and it's not a perfect number by any means. It's just helpful in some ways because it's validated that it has been shown to tell us more about the behavior of the tumors while we use it.
And discussing a little bit about the behavior of the tumors, that would be a question for Dr. Mitra. Which patients or when would you consider doing a gallium-68 dotted scan versus an FDG PET scan? Because as Dr. Chandrika said, some of these tumors may be very well differentiated, which we know they're more avid on dotted scans. Some of them are more grade 3, that some of them may not express, all of those tumors may express somatostatin receptor, for which it seems that maybe FDG PET scan may be a better option sometimes, but maybe a question for that. When would you decide what would be the best diagnostic therapy? Would you do both, or what would be your recommendations in this situation?
There's different imaging modalities that we can use to kind of help better understand and capture this behavior throughout the whole body. And one of the nice things about these types of PET scans is that, we're looking at the entire body at once, as opposed to a biopsy, which is just looking at, one small area within the body, or even just a few cells that are sampled. So as was just mentioned, there's a couple of two main types of PET scans that we use. One is a dodecate PET scan, which is looking at somatostatin receptors, and the other one is an FDG scan, which is looking at glucose uptake or energy utilization by the cell. So typically, again, to use that spectrum example, the lower the Ki-67, the less proliferation there is, tends to be more well-differentiated tumors that do express somatostatin receptors. And so we typically are able to visualize them best with a dodecate PET scan. But as the grade becomes higher, they can lose the somatostatin receptors and become more utilization of the glucose. And so then we can use the FDG uptake to better characterize them. And this does have impact on the treatment decision, because as things are more well differentiated and express somatostatin receptor as well, then we would use things more like PRRT that we discussed before. And as things become more high grade and lose that somatostatin receptor expression, then PRRT is less effective, and we might use other systemic agents or chemotherapies in that case instead. There is sort of this in between group of people who may benefit well from both types of imaging, because parts of their tumors may express somatostatins, other parts may not. That's kind of an evolving area where we're trying to decide, based on the grade or based on characteristics that we see on conventional imaging, such as CT scans and MRI scans, that perhaps we should do, FDG scans as well in those patients.
Great. Thank you for that answer. And another question for Dr. Chandrasekaran is that when would you decide I will give chemotherapy versus somatostatin agonist? What will be the clinical characteristics of the patients that make you choose one treatment versus the other?
So the way I try to explain to patients is, what grows fast may respond fast, but that's necessarily not a good thing, right? So, that's just in general, when we talk about these high-grade neuroendocrine carcinoma, or the kind that are very poorly differentiated, we primarily treat with chemotherapy-based as a first-line treatment. Now, within the better behaved or the well-differentiated group, where do we use chemotherapy, especially upfront? Clearly, again, we look at the symptom of the patient, the burden of the tumor, if there's a significant volume of cancer that's already affecting the patient. And we all know that neuroendocrine tumors, specifically of pancreatic origin, are the ones that are more exquisitely sensitive to the chemotherapy type of drugs. And so they may not be the same with small bowel neuroendocrine or other origin tumors. We just don't have a lot of data, but if we get a sense this tumor is growing fast, patient is symptomatic, or there's very high volume, and especially if they're pancreatic origin, that's the person to think about chemotherapy first. Now, Dr. Mitra may also say this is exactly the time we could also, if they have octreotide receptors, on the PET scan, could also be considering PRRT, and we have data from the NETTER 2. Not to steal his thunder, but that's a good patient also. But, we also have patients who have, for example, in those patients, let's say I'm getting a dual PET, and meaning like I'm getting a gallium PET and an FDG PET. If I'm fortunate enough to have all these data points to make decisions, and I know this patient has tumors that are not uniformly or very strongly octreotide receptor positive, then that would also make me lean towards chemo rather than PRT in that kind of situation. And that's a great question. I'm going to ask a question for Dr. Clark, if that's okay, Dr. Del Rivero, too. In these grade 3 tumors, the question of surgery comes up, too. I'm curious to see how the decision tree is. We always talk about chemo versus PRRT in these patients, but I would also say, hey, what about surgery in these patients?
Yeah, so I would say in general, I do favor a neoadjuvant approach for any tumor that has either a couple of things. If it demonstrates either aggressive biology by location, aggressive biology by Ki67, or aggressive biology by extent of resection that's needed. So what does that mean? For somebody that has perhaps even like a high grade 2, which would be somebody whose Ki67 is in the double digits, that has a very large burden of disease, where I know that the magnitude of the operation, even though technically feasible, is going to be significant. If I'm worried that there's going to be short-term failure in those patients, I do like to give a test of biology, preferentially with chemotherapy, especially if it's a pancreatic neuroendocrine tumor. I just find that operating after PRRT is a little bit more problematic than, operating after systemic therapy in terms of the intraoperative challenges with bleeding and scar tissue, et cetera. So that's my preference. And certainly for grade 3 tumors, my approach is almost never upfront surgery. I think those patients deserve systemic therapy as quickly as possible. We know that their risk of failure long term is dependent on the development of metastatic disease. And so even in localized tumors, I hesitate to do upfront surgery without consideration of systemic treatments first. A few exceptions, obviously, immediately symptomatic, if I'm trying to palliate a particular problem, like an obstruction or perforation, obviously, then we'll manage that. But I think that you explain it to the patients that the risk of failure and their overall survival is really going to be based on the mitigating the risk of developing metastatic disease distantly. And so most of them are in favor, at least for a short-term course of systemic treatment up front.
And Dr. Clark, I was just wondering for, our audience here, especially for those patients that are newly diagnosed or attending this conference for the first time, how can you define failure?
Well, I think there's a very broad definition. I think there are oncologic definitions of failure of treatment, and I think there are patient-defined failures of treatment. And I think especially for neuroendocrine tumors, where fortunately the majority of our patients present with well-differentiated low-grade disease, their lifespan, even with this diagnosis, can be quite long. And so we do have to measure what the impact of the treatment is to the patient's quality of life against the impact of the treatment on overall survival. So I think a failure from an oncologic standpoint, for me as a surgeon, the thing that I worry the most about is doing a very big complex operation and then having that patient recur, like on the first post-op scan. That basically makes me think that I made the wrong recommendation. I made the wrong decision to proceed to the operating room with a person that had, very aggressive disease and would have benefited from some upfront systemic therapy first. I think another failure is quality of life outcome that wasn't disclosed and extensively discussed with the patient from a surgical standpoint before surgery, so that they're unhappy with the outcomes after surgery. And we can't ever predict everything, but we can predict the most common things. And that they weren't able to sort of talk about how their post-operative state was going to, impact their day-to-day activities and the quality of life. So I think, failure is widely variable, as is success. I mean, I try to make sure that my definition of the end goal is consistent with what the patient's definition of the end goal is. And then we try to match the therapeutic options to that goal as best as possible.
Thank you so much for clarifying that, Dr. Clark, because sometimes for patients, when they see that terminology, that may be, it can be sometimes scary. So I think it's important of kind of like this, kind of like explaining exactly, what that means in the context, as you very nicely described from the oncological perspective. I think it's important to make that clarification.
I appreciate that too. And I just want to make one comment because it really did bring something to mind that you said. Absolutely right. A lot of times too, we're not really clear about what we are looking for. So for some patients, for example, I'm not even necessarily looking for tumor shrinkage. Before I get to the operating room, I would just be very satisfied with no new lesions popping up. And so, they'll have one lesion that's a 2 millimeters larger on a repeat CT scan after a systemic treatment, and they're really worried about that and thinking of that as failure. And I'm like, there are no new lesions. I didn't need the shrinkage, especially not in that location. And this 2 millimeters of growth is really inconsequential. And we're going to proceed, as well. And then also, they may think like lanreotide or something else is failing because they don't see shrinkage. And we know that that's not the case. Again, we're really just trying to make sure that we have all the lesions identified as much as possible so that we know what we need to take out at the time of surgery. So I think you're right. The definition of failure means something different to the patients as it does to us. And so I think the due diligence is on us to try to explain what exactly are we testing, what are we looking for, what do we expect to happen, and what's consequential and what's not.
And just to add to that, I think that's true across the spectrum of all treatments, not just surgery. I think, PRT especially, I feel like patients, when especially now it's already a decade old, so some patients know a little bit more about it. But when it came about, it was like this magical, Eric, it is magical, sorry. But in terms of, the expectation that people have from it, like, oh gosh, this is just going to melt away my tumors or something. I mean, if you really show them or share the data that's there, our goal is, even with PRT or even some of the other drugs, is not that these tumors, all of them always do shrink. Again, it's just a different tumor, right? So we have to explain. I tell them the success of the PRT is not measured sometimes during PRT. If you tolerate the treatment without complications, that's a success, right? That's number one. But not having side effects immediately, that's a success to me. The success from a treatment perspective and the efficacy is, especially for something like PRT or even other drugs, is about stability longer term, like how long, least quality of life impact you can be with least bothersome symptoms from this tumor you can be. And I think it seems like, especially with the PRT, it seems like this misconception maybe that, again, we do see some amazing responses in those high-grade tumors, but that's not the goal. I think people, our goal, it's happy to see it. I'm sure people love to see those scans look better, but, we want a goal that's far-reaching beyond that.
Yeah, I agree. I agree with everything you're saying here. And sometimes we see a patient and then they may come to you for a second opinion, right? We always say, well, if you see 2 different experts, you may have 5 different opinions. And kind of like the question is like, when do you think is the right treatment option?
This is also a hard one because there is no right treatment decision, right? All are correct treatment decisions is the first thing we start out with. And that's why I think this is sometimes very confusing for patients, sometimes confusing for the people taking care of this cancer, right? Because we all have these tumor boards where ideally, if you have a medical oncologist, surgeon, and interventional radiology and nuclear medicine folks, all 4 of us saying, yeah, we can do this. We can offer what we can offer, right? I can offer drugs. Dr. Mitra can offer PRT. Dr. Clark can be able to offer surgery, especially for some patients who are super healthy and are a candidate for everything. I mean, the good news is it's all up for offer. That's what I tell people. Hey, again, try to talk to patients in a way that if you go down this path and if it goes well, it looks like this. If it doesn't go well, it looks like this. And so kind of walk down each of these paths and then try to come up with a framework of decision that is helpful for the patient in the context of their lives. Again, a discussion, let's say, for a young patient with radioactivity may be different from a patient who's a little bit older, or a young person, we may have a bias for surgery because they're going to hopefully spring back and do this thing. So I think that part is where maybe the nuances of discussion may vary from one center to another or one patient to another. But the answer we have to emphasize for the patient is all are correct answers. And that's true because we still don't know the right answers to sequence.
Dr. Mitra?
Great discussion, and I really agree with a lot of what has been said so far. From my point of view, I would just stress a couple of things that, again, I feel like have already been said. But one is that it's really important, as was just mentioned, to understand that, even we don't really understand what is the proper sequence of these things. So there is really no wrong answer to that end. It's important, as was mentioned, to just really kind of understand what each of these therapies entail. And then, as Dr. Clark said, to really understand, what it is that your goals are out of this, treatment. Because perhaps, surgery is something that is potentially very good for you. But if you don't want to go through that and, have the recovery from that, as an example, PRT is very, very well tolerated. It's given once every 2 months. It's very easy to do. It has to be kind of a combination of all those things. And again, I mentioned before that, we discuss all of these things in the multidisciplinary tumor board. And I do think that's important, especially since we don't have clear understanding of the sequencing of some of these therapies. If we can get sort of a consensus of, multiple experts, so to speak, agreeing on this thing, then I think that's also helpful.
I would say I think the right patient, the right treatment's probably determined by the patient. I think that, having comfort in the treatment plan is really critical. I think that if you feel like either you don't understand the reasons behind the recommendations, or the recommendation hasn't really addressed your major concerns, that may not be the right treatment plan for you. And I really encourage folks to get a second opinion in those settings if they're not entirely comfortable with the treatment plan, because they will get different opinions at different centers. And that could be, from my standpoint, especially, like I will see a lot of patients with what I consider low risk, small, non-functional, incidental pancreatic neuroendocrine tumors. We at our center really favor observation for the vast majority of these patients, with some exceptions. But there's some patients that just don't feel comfortable watching a small tumor that's a centimeter in size, and even with the data presented, they may want to pursue surgical intervention somewhere else, and there's nothing wrong with that. I actually encourage that sort of debate and discussion. And again, the patient has to be comfortable with the plan, just as much as I think the treating team have to be comfortable with the plan. I think it's really a matter of trying to get the outcomes really aligned with patient wishes as much as possible.
Thank you. And I would like to ask a question to the three of you. What advice would you give to a patient who is newly diagnosed with neuroendocrine tumors in terms of treatment decisions or treatment recommendations?
I think knowledge is power. I mean, so is in every cancer, but this is a long journey, hopefully a very long journey for most of a patient. So there is nothing wrong in equipping yourself with the knowledge first. I mean, there are also patients who may opt not to, and that's fine too. I just want to make sure there's no right way, I'm sure, from a patient perspective. But some will say, just don't tell me about this, doc, just tell me what to do. That's fine too. But if you're the kind that likes to know and be involved, that's absolutely necessary in this cancer. Because the more you know, you are still going to be the centerpiece of all these decisions. You're the one going through the treatments if you need them. You're the one with the toxicity. So you have to express yourself and ask all these questions. So equip yourself with knowledge, speak up. It's okay to seek an opinion, like Dr. Clark mentioned, seek an opinion. If you're, it's okay to do that. Again, there's nothing wrong. And make sure you're comfortable with your team.
Yeah, Dr. Clark?
I actually refer patients a lot to the Neuroendocrine Cancer Foundation and to any patient-centered groups. We have a very active patient net group in Wisconsin. And so I recommend that they get to be a part of the net patient community, because a lot of what I say sounds like a reasonable thing, but there's nothing, I think, more powerful for a patient who's sitting in a chair, who's very scared and devastated by this new cancer diagnosis, like talking to somebody who's sort of been through what they're going through. And so talking to other patients who sort of navigated or are still navigating their neuroendocrine tumor journey is probably like one of the most beneficial things that I think a net patient can do. I also tell them to forget about everything they've heard about cancer, because almost none of it applies to their particular tumor, and everybody's going to tell them what they think. And it's not going to be relevant, because this is just a totally different beast than the typical cancers that they're going to encounter amongst family and friends. So I agree with Chandrika. I think knowledge is power, and a lot of that knowledge can actually be gleaned from folks who've been through this diagnosis or still navigating that diagnosis. And I think it can help them understand their disease and disease course and potential for long-term outcomes better than anything that we can explain. I think it can familiarize themselves with other experts in neuroendocrine treatment across the country that they may not be privy to just in their regional circles. And then I think it's particularly helpful for caregivers to really get a better understanding about what next steps or what the next years will look like for their loved ones. So I really encourage patient-centered support groups as much as possible.
Thank you for that. And Dr. Mitra?
Not much to add to those. I completely agree with everything that was said so far. Those are great things to do. The only thing I could think to add would be that a lot of times, since this is a relatively rare, uncommon disease, that in physicians in the community often don't have a lot of experience with it, and this is again a very nuanced type of management, as was just mentioned. So if it's possible to go to a center of excellence, or at least a center that sees more neuroendocrine patients at some point, it would be probably advantageous for you to just be connected to them. You can still kind of be connected to your local oncologist and local physicians for sort of your day-to-day care, but I think it's good to also see some specialists if possible.
That's the very, very important information. Knowledge is power, and going to support groups and get you informed about the symptoms and like what is the workup, and that way, patients can make the treatment decisions. And like you say earlier, Dr. Chandrika, I think the always, and Dr. Carlos say, is what the patient decides, as long as we understand all the risks and benefits and what makes sense in terms of the clinical presentation of the patients. I think is also important. And earlier, all of you mentioned about like the importance of multidisciplinary teams, multidisciplinary care, and in patients with neuroendocrine tumors. And we know that a lot of us, or most of us here, we are in institutions that we have the multidisciplinary team needed to treat those patients, but we also have patients that may not necessarily have that. So in those situations, what would be your recommendation in a patient that may not have access to the academic centers, that they have all the different specialties? So what would you recommend?
So I think all of us do practice in an academic center. So, right, I think we do have that luxury of having the team, the colleague that you can call from radiology, nuclear medicine, surgeon anytime. So I have great respect for the people taking care of the patients in the community. And the access comes twofold, right? The access is a patient not being able to get to a specialty center, but there are various factors. But in terms of accessibility, I would say, for example, a doctor who's treating this cancer in the community has a patient who's not able to get to the center. They still have access to other resources to reach out if they only see one or two patients in a year with this cancer. In other words, there are ways to mitigate it. It's a very tall order. Having video visits and virtual visits, like a lot of us have started to do that. Thankfully, having those liberal state licensing things and have enabled some patients with access issues still be in touch if possible. So I think we have to get creative, both as a physician treating team as well as the patient group and advocacy, to address this, to offer what we have to offer for more people.
Thank you so much for that question. And we are coming at the end of our session. But if you mind asking, then maybe we can start with Dr. Clark. What is the single development that you're more excited right now about neuroendocrine tumors?
Wow, I mean, that's a tough question. I just think that really it's the trend. It's an explosion of new therapeutics that are specifically focused on this disease. I think, we've been an orphan cancer for so long. We are just now starting to reap the benefits of decades of investment and innovation, research, and inquiry in neuroendocrine tumors. And so we're starting to see a lot of new, more personalized options for tumor treatments and more precise treatment options that offer perhaps the benefit of enhanced tolerability and even maybe wider access outside of some of these, centers of excellence. So I think that has been the thing that's most exciting. And I tell people now, sometimes in many cases, not in all cases, but certainly even with somebody that has high volume grade 1 disease, that, we're going to try to play whack-a-mole with your disease for as long as we can. We have a lot more tools in our box, and we're going to try to use the right one at the right time to manage your disease, minimize the side effects of the treatment, and then try to keep you alive as long as possible. And we can actually say that now with a reasonable amount of confidence, whereas I don't think we were able to say that 20 years ago.
Dr. Mitra?
I mean, that was a perfect answer from Dr. Clark, so I really can't add much. The only thing I would say is this is going to continue. Over the last 10, 20 years, we have had so many developments, but even more so coming in, the next 10 to 20 years. So it's a lot of exciting things to look forward to.
I'm actually excited about the investment and the interest in this cancer to begin with. I think that's kind of where it starts. I think there's a concerted effort, hopefully from multiple levels, to, again, rare orphan, yes, but I think all this progress has been possible because there is still the commitment to make progress, right? So that's, I think, key, and that momentum, I think, will continue. And so that's important. And then two, probably is, the excitement is also about some new models we can study these tumors. As technology in other places are increasing, we're going to have to immediately start applying it in neuroendocrine tumors so we can do better.
Well, thank you so much. Thank you, everyone, for being here today. And this concludes our session. And get back to you.
I'm Katie. I'm a pancreatic primary neuroendocrine. It's a grade 3, stage 4. I've since had surgery to remove that and have been in a variety of different treatments, including CAPTEM, some systemic chemotherapy, I've had liver ablation and am currently in a clinical trial. I've been in this clinical trial since January of this year. It's December now, so I'm entering my 12th month. I wasn't actually looking for a trial. So, contrary to how I think some people think about it, I was not having exhausted all other options, but I was looking at a decision treatment window. So, I had had treatments last year that had gone well, but I'd had recurrence of disease. And I think, like any other treatment junction, I was taking a survey of the options available to me, which included a lot of different things. My specific case is that I have a higher grade, but low disease burden. And that alone sort of narrows the field. For example, liver-directed therapy, not yet something I'm eligible for. So when I was looking at the options, some of the other kind of more standard of care systemic treatments do have a higher toxicity. They come with a higher, side effect and or long-term risk. And for me, one of the things that has been really important as I manage this disease is trying to be as aggressive as I can in treating it while also keeping options on the table for down the road and including just generally lower risk where I can. So prior to joining this clinical trial, I did not know anything about clinical trials. So my experience up until then was that I heard about it in the movies. It sounded like something that you do when you have no other options or you're really on the cutting edge of science. And it turns out I am on the cutting edge of science, and that has informed a lot of things about my experience. I think one of the things I've learned is that while things have been studied, and that means it's not the same as a complete unknown, there is a reason it is in a trial, both the uncertainty of its efficacy against the disease, as well as potentially the side effects, the treatment schedules, et cetera. So kind of wrapping my arms around the level of unknowns and being willing to step into that is something that but once you experience, it does change a little bit. Having said that, I've been fortunate that it has actually worked out, both from an outcomes perspective. So far, we are doing well. I'm excited about the progress it's had on keeping my tumor stable. And where there have been unknowns, I have been able to manage them. One of the benefits of being in a trial is that you have an incredible care team around you. So for folks who are trying to think about whether a clinical trial is right for them, there's a lot of different things to consider. Off the top of my head, a few would be first, just lifestyle. I think that gets kind of like a broken record in cancer care, but you're not off the hook for thinking about it here too. I knew I was going into a year plus of having every 3 weeks to be in office, regular appointments, and more frequent scans, which can be anxiety inducing. I'm scanned every 2 months for this trial. I was willing to take that on to have access to this treatment. I'm fortunate to live close to my care facility. I don't have caregiving responsibilities for children, but everybody's situation is going to be different. The second is a little bit more esoteric, but it is that level of unknown. So questions to ask would be, what do we think the success rate's going to be? What do we think the risks are going to be? I am going to say you'll want to ask questions either way. And I think that includes, what are the options going to be if and as I have unexpected side effects? What are you doctors most worried about? And then the other thing that I really recommend asking is, if this doesn't work for some reason, what is my next option? I went into my trial already planning my second and third options. I've been fortunate to not have to go to them yet, but it was really important to me in that first 6 months to not have to simultaneously learn how to navigate these systems and drugs and research something else. And so you don't want to plan for failure, but you do want to be realistic. So words of advice or words of encouragement for someone newly diagnosed with neuroendocrine cancer. Encouragement. I heard this when I was first diagnosed, and it was from somebody much older. And he said, your job is to just stay alive until they invent more things to help you keep staying alive. And I thought, that's really bleak. But okay, I'll sign up for that. And now that I'm a few years in, just in a few years, he was completely right. I have been very fortunate that I have not been close to exhausting my available options in those few years. And even so, there are new things that have become available that are less toxic, that are more effective. And it really is a wonder seeing the advances that science is doing, not just in cancer in general, but I think neuroendocrine cancer gets some of these therapies a little later. And the second piece of advice, which I don't know how to say it without sounding preachy, but I'm going to just say anyways, is When I was first diagnosed, I heard a lot that we're balancing quality of life with care. And at the time, I felt like that is a defeatist attitude. I want to be aggressive. I don't care what my side effects are from treatment. I'm going to cure this damn thing. That was maybe not the right mentality, not because I'm not being as aggressive as I can, but quality of life is a much more expansive than just physical side effects. And that is the part I didn't really understand as it was originally presented to me. Accepting that I have a managed disease and that this is a part of my life, and just really searching over time and continuing to iterate on what your version of just living your life and taking care of yourself, which includes your treatments, is so important. It's a critical piece. Otherwise, I think you live in this constant mental state of crisis or of defensive mode or of limiting what you can do until you're just past the next treatment. I've certainly internalized that and embraced that more in the past year. And the sooner people can lean into that mentality in this disease, the better.
Welcome back, everyone. We are very fortunate to have this incredible panel of neuroendocrine cancer experts join us for a live question and answer session. It's an honor to introduce today's panelists. In order of alphabetical order, Dr. Jennifer Chan, medical oncologist from Dana-Farber Cancer Institute in Boston, Massachusetts. Dr. Chandrika Chandrasekaran, medical oncologist from MD Anderson in Houston, Texas. Dr. Delphine Chen, nuclear medicine physician from Fred Hutch Cancer Center in Seattle, Washington. Dr. Haidira Del Rivero, medical oncologist and endocrinologist from the National Cancer Institute, National Institute of Health in Bethesda, Maryland. Dr. Udavi Grewal, medical oncologist from Emory Winship Cancer Institute. Dr. Thor Hefdenerson from Mayo Clinic in Rochester, Minnesota. Dr. Pamela Kuntz from Yale Cancer Center and Smilow Cancer Hospital. Dr. Michael Solon, interventional radiologist from Penn Medicine in Philadelphia, Pennsylvania. And Dr. Jason Starr, medical oncologist from Mayo Clinic in Jacksonville, Florida. And of course, Josh Mailman, president of NorCal Carcinet and patient advocate extraordinaire, who will be serving as co-moderator for today's Q&A session. We have approximately 90 minutes for the entire Q&A session, divided into two parts. I will moderate the first part of the Q&A session with Drs. Chandrasekaran, Chen, Del Rivero, Kuntz, and Starr. And Josh will moderate the second parts with Drs. Chan, Grewal, Hefdenerson, and Solon. I invite the first group to stay on with me while Josh and the second group can now turn off their cameras. And a reminder to the audience, this Q&A is for educational purposes only and should not be taken as medical advice. We encourage you to speak to your own medical provider about your specific situation. And we will now try to get to as many broad-based questions as possible. We'll go to the first question now. Dr. Kuntz, we'll start with you. Are NETs considered cancer?
Hi, Lisa, and hi, everybody. Thanks so much. That's a great question. And actually, this came up in clinic this week for me. So I think it's probably relevant for lots of our listeners. So the short answer is yes, NETs are considered cancer. I think the confusion has arisen given the complicated terminology over many decades. Some of you may have heard of the term carcinoid, which means cancer-like. This was a term that was coined in the early 1900s when, in fact, these cancers were not thought to be able to spread or metastasize. And so there was a lot of confusion around that. We now know, in fact, that NETs can grow, can spread to other places. We just don't know which ones might do that. And so we think of these all as cancers. Patients are treated with cancer-directed therapies. Some may have a higher likelihood of spreading or growing than others, but I think the right way to think about these, if these are in fact cancers, and we have to treat them as such.
Thank you so much. Dr. Del Rivero, Dr. Kuntz just mentioned carcinoid and how that was an old term. What is the understanding about the hormonal or emotional symptoms of carcinoid syndrome? Do you have any suggestions around this?
Yeah, great. Thank you, Lisa and everyone. And for being here today. And thank you for that question. I do think it's an important question to understand the emotional aspect as well around any cancer diagnosis. I think in the setting of neuroendocrine tumors, I think it's important to understand symptoms related to hormone excess, but also how having the diagnosis and the symptoms related to hormone excess may impact the emotional aspects of, of anyone, not only for patients, but the same for caregivers too. In terms of the hormone related to, or the symptoms related to hormone excess, I think, for example, in the setting of carcinoid syndrome, so how it happened is that tryptophan is an essential amino acid. It is in everything that we eat and a lot of the food that we eat. And that tryptophan is then, in the center of having a neuroendocrine tumors, that tryptophan convert into serotonin and then subsequently into the urine via 5-HIAA. So the tryptophan is used a lot in these situations. And some patients, they get depleted in other parts. And being an essential amino acid is important in certain aspects of functionalities of the body, like for example, sleep. Tryptophan is important for melatonin. So that's an aspect that sometimes patients may also discuss, that having the lack of sleep is one of those aspects. For example, tryptophan, there has been also studies that tryptophan also, the low tryptophan correlates with higher levels of cortisol. So cortisol is an important hormone, is considered a stress hormone, and that's our fight and flight response. So having this excess of cortisol can be associated with other aspects or emotional aspects of having this diagnosis. I think there is different aspects between the emotional and as well as having the diagnosis of the tumor, of the neuroendocrine tumor, as well how the excess of hormones has the implications and the symptoms and how these symptoms can then hence some aspects of the emotional well-being. I think in these situations, two important parts is to, we always have discussed this, having consult with someone who has an expertise in neuroendocrine tumors, or collaborate with somebody who has a neuroendocrine tumors that can address the aspects as well of not only the neuroendocrine tumor, but as well of the hormone excess related to neuroendocrine tumors and how to address that. But the other aspect as well is that having a good support system too, to help understand, all the different aspects of how this can impact well-being. And with that, I was, having support groups, and as well, educate patients themselves. Also, consult with palliative. I think palliative is one aspect that we always feel that is the end of life, but that's not necessarily the case, right? Palliative is help patients to live their best life, having and living with this diagnosis. And I think all of that is important so that way we can manage appropriately not only the symptoms related to hormone excess that can cause some emotional aspects and enhance some emotional aspects of the well-being, but at the same time having a good support system that can help you overcome all those aspects. I don't know if anybody has any opinion.
Yeah. Dr. Del Rivero, I really appreciate how thorough and how holistic that answer was. That was very informative. I'm going to follow up with Dr. Starr. There was a question specifically about tryptophan diet. How do I know if I should follow a low tryptophan diet? I've received contradictory information about this and my nutritional needs.
Yeah, so this kind of dovetails with Dr. Del Rivera's kind of explanation with that last question. So tryptophan is a precursor for serotonin. So in a patient who has a neuroendocrine tumor that's what we call hormonally active, the body will divert more tryptophan to serotonin, right? So you could experience more carcinoid syndrome type symptoms, i.e. diarrhea. Flushing is a bit more complicated. So it's not necessarily tryptophan, but we call these substances amines. Serotonin is an amine, A-M-I-N-E. Histamine is an amine, right? So there's a lot of different substances in the body that have these precursors that when you eat foods that have the precursors, it could make a surge in hormones go up. So this is what I tell patients. If you eat a food and it seems to trigger certain symptoms, or you drink alcohol, it seems to trigger your symptoms, don't eat that or don't drink that, right? But I don't think you need to avoid foods if you don't have the symptoms. And I think that's where a little bit of the kind of misinformation comes in. It's like, oh, I have neuroendocrine tumor, I shouldn't eat these foods. Those foods are not going to hurt you. But if the foods trigger symptoms due to the mechanism that I had mentioned, then you should have some avoidance there. And you know, I always am cautious there because food is part of life, part of the enjoyment of life. So I hate to eliminate foods that people enjoy, because I think that's, you know, quality of life kind of, uh, you know, something that contributes to quality of life. So that's how I kind of counsel patients on that.
Thank you so much. Quality of life matters for sure. I'd like to ask Dr. Chen about some scan questions that came up. What's the best non-MRI scan to evaluate bone pain? And then secondly, if there are bone lesions detected, what imaging technique like nuclear medicine, gamma, MR, or CT is best to reveal the detail of the bone lesions that are detected previously on scans like MRI or PET scans?
Yeah, thanks for the question. Actually, one of the general nuclear medicine studies that we use a lot for other cancers is a bone scan. So bone scans are really good at showing bone metastases when that bone metastasis is causing the bone cells around it to react to it and deposit calcium. We call those sclerotic lesions. So I don't know if you recall in my talk, one of the CT pictures shows those bone lesions really well as white spots. That means the bone is depositing calcium because the bone is trying to react and it's reacting to what the tumor is doing to the bone matrix. So when it has that kind of reaction, you can see them on a bone scan, and we can use them really well to follow bone tumor metastases in other cancer types. We can also use it for looking at sites of bone pain, for example, in patients with compression fractures, if they're trying to look at whether there's movement in the compression fracture before they intervene to try to reduce that bone pain. So bone scans are a nice alternative modality. If you cannot get an MRI and you're trying to find the source of bone pain, it will at least show those where you have that sclerotic reaction or that calcium depositing feature of the bone metastasis. If it doesn't, if it has what's called a lytic appearance, which is the tumor is actually eating away at the bone matrix and it's not able to deposit calcium around it, then even a CT will show that lytic metastasis pretty well, and that's probably the best way to characterize it. And then depending on where it is, like if it's in your long bones, basically your arms and legs, plain radiographs actually might be the best way to look at whether you're at an increased risk for fracture per se. And then with regard to, and this leads me into your other question of what other modalities are available to characterize bone metastases. It really depends on why you're trying to characterize a bone metastasis. For general staging, as I mentioned, between tape PET, CT, and MRI, depending on which shows it the best, you might want to use that for following it. But if you're worried about, again, specific bone pain sites, that's where we start looking at, CT and MRI show those lytic metastases really well. If you can't get the MRI and you have the sclerotic metastases, the bone scans can be really helpful. And then, like I said, the radiographs are very helpful for it. There's a very defined scoring system on the risk of fracture if you happen to have metastases in your arm or leg bones. So I hope that answers the question.
Thank you so much for explaining that. Dr. Chandrasekaran, there's a lot of concern about what causes neuroendocrine tumors or cancer. Can long-term use of proton pump inhibitors, Nexium, lansoprazole, Prevacid, cause neuroendocrine tumors or cancer?
So I think this is definitely relevant in terms of patients who have been diagnosed with what we refer to as gastric neuroendocrine tumors. But this is a very small subset of different other neuroendocrine sites. Majority are small intestine origin or pancreas origin or lung. So gastric neuroendocrine tumors have definitely increased probably in number, whether we are diagnosing them again because of the scopes we are doing more often and incidentally finding things. We used to think of them traditionally classified into type 1, 2, and 3.
which is broadly one of the kind is when there is a tumor in the pancreas or the duodenum causing excessive gastrin, which in turn leads to these tumors inside the stomach area. Another kind where it's often associated with autoimmune pernicious anemia. So this is something where your stomach acid is not being made and those cells are kind of on an overdrive. So, and then the third kind, we used to call them sporadic, meaning we can't put them into type 1 or type 2, basically. But then recently, I think there's definitely been a recognition that there is these neuroendocrine tumors that we find in the stomach when we do the scopes without necessarily a very aggressive behavior that has been previously associated with the type 3. Oftentimes, these are multiple, like not a single area, but multiple neuroendocrine tumors, and majority of them are very slow growing, or what we refer to as a low grade or grade 1. I think this is an interesting entity. I think we're really overdue for reclassifying and renaming gastric neuroendocrine tumors. And that particular subset, the type that is, maybe multiple low grade and often associated with long history of protonics or PPI use, is the only subset right now. Now, outside of that, to my knowledge, there's no connection of other neuroendocrine tumors with PPIs of any of the kind that's mentioned.
Thank you so much. Dr. Coons, you talked about sequencing, about treatments, and that was really helpful. This is a common question. Are somatostatin analogs always necessary, also in the case of non-functional neuroendocrine tumors?
Great question. So we often will start with a somatostatin analog for tumor control in both patients who have hormone secretion and patients who do not. So for the patients who have hormone secretion, that's about 30 to 40% of patients. It's often a great first choice because it controls both the hormones and it controls growth of the cancer. For patients with non-functional or non-hormone secreting NETs, we can definitely consider somatostatin analogs, but we don't use it for hormone control. It's being used to slow down the growth of the cancer. So it's not required in everybody, but it's really a great early treatment, and in part because it's so well tolerated.
Yeah, thank you for that. Dr. Starr, there are a couple questions about supplements, and so I'll ask them together. One is, are electrolyte imbalances related to NETs, such as muscle spasms? And if so, would magnesium supplements help? And then also generally, what vitamins or supplements are recommended for NETs, specifically lung NETs?
Yeah, this is kind of a tough area in that there is a lot out there, right? That you can read on the internet, and or a friend's cousin's brother's, wife told you that this, graviola seed tea, or soursop, is helpful for this, that, and the other. And the way that I approach these questions with my patients is with an open mind, right? I don't know everything, and I am a Western trained physician, right? I'm a physician that kind of follows evidence-based, right, medicine. But there's eons before me in which medicine was practiced in villages, right? In medicine people, and these medicines worked, right? So I leave room for the things that I don't know, right? With that being said, I caution my patients on reading anecdotes or listening to podcasts. I won't mention the one in particular, but in which there can be some predatory behavior online with people kind of purporting supplements and trying to push supplements because people are making money on the other end. There are no specific supplements that I typically recommend unless a patient has a deficiency in some vitamin, right? If a patient has iron deficiency, I will recommend iron. If a patient has a B12 deficiency, I'll recommend B12. If a patient has low vitamin D, I'll recommend vitamin D. The other supplements are, again, I'll usually incorporate my pharmacist, my clinical pharmacist, just to make sure there's no drug-drug interactions with something that a patient's already on. But I'm very open-minded to saying, if it's not going to hurt, go for it. But I'm not a naturalistic
doctor. I don't know about all of these supplements. I wasn't formally trained in that regard. So I can't give specific advice, but I can help guide patients and at least make sure that whatever they're going to take is not going to be harmful.
Dr. Starr, thank you for that honest answer. I'm going to follow up with another common question that you probably get asked a lot, especially right now. What are your thoughts on taking ivermectin for neuroendocrine cancer?
Yeah, this is all definitely in the same vein. I get this question every day in clinic. And again, I approach it gently, and I'm not going to go on a soapbox, but I think that the ivermectin kind of evolved in the post-COVID. Hydroxychloroquine got popularized in the media, and people were saying, oh, you got to take hydroxychloroquine to either prevent COVID or treat COVID. And they did definitive studies that showed that it did nothing, right? And despite that, people still wanted to take it. Okay, that's their preference. The ivermectin got perpetuated mostly from a podcast called Joe Rogan, and there was a guest on named Mel Gibson. You may have known him, and he was talking about a family member or a friend who took ivermectin and their cancer essentially went away. There's no clinical data. There's, I think, one breast cancer study that was very preliminary. There's no clinical data that ivermectin has anti-cancer properties. That's clinical data. There is basic science data suggesting that ivermectin may interfere with growth pathways in cancer cells. I'll keep it kind of simplistic there, just to not go into the weeds. And the thing is with lab medicine, we've cured a lot of cancer in the lab that has not translated into humans because we're so complex and there's so much of an interplay between all of our systems and immune system, and our biology is so complex. So at this point in time, my kind of bottom line is ivermectin is not going to effectively treat your cancer. And I tell patients, I've had multiple patients take it. I don't prescribe it, and I have not seen it offer any benefit. So anecdotally, I've also not seen it do anything, right? Even though I've had a multitude of patients on it. So I can't with good conscience or with any level of confidence say, yes, you should take ivermectin. I would actually, again, I'm open-minded about it. I would probably say it is not worth pursuing outside of a clinical trial.
Thank you for your honest answer, Dr. Starr. Dr. Del Rivero, you are unique in that you're both endocrinologist and medical oncologist. And, patients can get really confused as to what kind of doctor they should seek when they're looking for neuroendocrine cancer care. So I was wondering your perspective, if they should seek a neuroendocrinologist, medical oncologist, endocrinologist. How do they make sense of these ologists for a second opinion? And then specifically in the space of lung neuroendocrine.
Oh, yes. And also a very important question, Lisa. And yes, I can understand sometimes, trying to understand different aspects of their care can be sometimes confusing, especially if we are discussing about the neuroendocrine tumor and it's producing hormones. But one thing that we always discuss about neuroendocrine tumors is that it needs to be discussed with a multidisciplinary team. And we always have discussed this in different meetings, that the management of neuroendocrine tumors is not a one size fits all. So we definitely need to discuss different aspects of their care with different specialties, and we have discussed that nuclear medicine, interventional radiology, surgery, medical oncologies, endocrinologies also is part of them, because there are certain syndromes related to neuroendocrine tumors that are managed by an endocrinologist. Like, for example, if a neuroendocrine tumor produces insulin, so we know that this excess of insulin causes a series of symptoms, very low blood glucose, and this very low blood glucose also causes a series of symptoms, and that's managed by different other drugs that are independently of the management of the neuroendocrine tumor itself, with the radioligand therapy, so with different systemic therapy. So some of these aspects is managed by an endocrinologist, or the primary physician, which often a medical oncologist will need to involve an endocrinologist. But like I say, I think there is in this field is like we are a multidisciplinary type of cancer where we need the input from many different specialties in order to provide the best care. And that's how we usually discuss and advise that it's important to see somebody who knows neuroendocrine tumors, because that person will definitely then discuss in tumor board or discuss with different specialists to understand what makes the most sense. I can understand that sometimes the care can be fragmented, and that's something that us, as being in the field, is something that I feel we need to do better in that aspect, that we need to kind of come together and in order to benefit our patients. Sometimes the patients who aren't more, not necessarily in an academic center, but that are more what we call in the community, seen by private physicians, and sometimes it's difficult to get access to different specialties. But that said, one thing that I always talk to patients is education. Knowledge is power. Try to educate patients about the different aspects of neuroendocrine tumors, being part of support groups, listen to all of the educational aspects that we have, like we have here with Neuroendocrine Cancer Foundation and others. I think it's important to keep yourself educated, to understand about your symptoms, understand about your disease. And that way, we can then all together provide the care that is needed. But I can understand that I do feel like we need the inputs from different specialties. Like I say, it's not like one size fits all. And that's an aspect that we all together need to work as well to provide the best care. I don't know if that answered the questions. And I think that there is an aspect that we need to understand how we can help those patients that are isolated, that are not necessarily in academic center, how we can help them. And that's something that I think as an organization, as also in the field, we need to work and do better on that.
Yeah, a work in progress. Thank you so much. Dr. Coons, let's talk a little bit about neuroendocrine cancer that people don't know where the primary it originates from. So this person in particular asks, my net cancer origin is unknown and has metastasized to my liver. Would a colonoscopy determine whether it began in the GI tract? Why or why not?
So we still, despite having excellent imaging, including DOTA PET scans, sometimes we'll come across patients who have a primary that we cannot determine where it started. And that's probably less now because our imaging is better, but it still occurs. When that does happen, we can sometimes consider both upper and lower endoscopy. So an upper endoscopy is called an EGD, and a lower endoscopy is called a colonoscopy. However, they do not cover the entire GI tract. So an upper endoscopy goes down into the stomach and into the first part of the small intestine called the duodenum. And a colonoscopy can go all the way through the colon to the cecum and something called the terminal ileum. That's right where the colon and the small intestine connect. And so if your NET originates in any of those areas that are covered, it could be found by an endoscopy. However, there's a big portion of the small intestine that cannot be reached by standard endoscopy.
I'm going to follow that up to ask, what about lung? What if it's not in the GI tract? How would you determine if it's in the lung or primary in the lung?
So again, I think back to PET scans, and Dr. Chen, I'm sure, covered this in some of her talk. I think with the advent and widespread use of either copper-64 or gallium-68 PET scans, the resolution is so much better, and we often will find small primaries that we cannot see on an MRI or a CT scan. So I would say that that has helped us considerably, and a lung NET could in fact be determined or found using a DOTA PET scan.
Thank you so much. Dr. Chen, I'm going to go to you specifically about the DOTA PET scans. When do you need to stop lanreotide or octreotide prior to copper or gallium-68 PET scan?
That's a great question. And there have been several studies looking at that, because the thought is the somatostatin analogs look just like dotatate, and so they will bind at the same receptor site. And the concern is that if you give the somatostatin analog, it will block the uptake at the tumor site and then make your dotatate PET scan essentially useless, because then you wouldn't be able to see those tumor sites. There have been at least 3 publications that I know that have looked at the timing of somatostatin analogs relative to when the dotatate PET scan was performed. And in all of them, it actually turned out they increased the amount of uptake we saw in the tumors because they decreased that background. So related to that pseudoprogression phenomenon that I was talking about before, in my talk, the somatostatin analogs tend to decrease the amount of background activity. And actually, in one of those papers, one of them actually suggested that maybe we should be considering somatostatin analogs prior to giving PRRT to increase the amount of drug to the tumors. I think the cost of designing a study to test that well is probably too expensive and not, I don't think anyone has the appetite probably to fund that at this moment. But generally for our center, at least, we made the decision based on that data and based on our experience in the cases that we review in our neuroendocrine tumor board. We decided not to institute a firm timeline when you had to stop your somatostatin analog before a dotatate PET scan, because it seems that more often than not, it actually increases the sensitivity of the dotatate PET scan if you give it to it even earlier than, say, like, if you're getting them every month, if you do the dotatate PET scan right after that monthly injection, or if you're on short-acting analogs, it doesn't seem to hamper our ability to see what we need to see on the PET scan. For PRT, we still stick with the recommendation that we wait until you're about due for your next monthly injection, and we will give the PRT prior to that. Again, because we don't have the data, and we don't want to interfere with the outcome of the treatment. So,
Thank you.
It's an area that would be interesting to explore.
Thank you. Very common questions. Dr. Chandrasekaran, this question comes up a lot and a source of anxiety for many patients. Do NET metastasis, like NET metastasis in the liver, can they be a source of metastasis? I've been told both, that they do and that they don't metastasize. Which is it?
Maybe tackling that with another question about even the primary, whether an intact primary tumor, meaning if your primary tumor was in the small bowel and we leave it in, does it continue to kind of send off those cancer cells in other areas besides what's already there, right? I mean, I guess it's in a way these two questions are often asked, and I think cancer progression or spread is a very complex mechanism. The construct we have, we use to explain it is through the blood, through the lymph, and kind of the simplistic fluid-based progression or spread. But probably there's more than that, because whatever the site of the primary is, wherever it started, once it's found a portal to get to another organ or location, which we refer to as a stage 4, it probably has favorable factors also at the organ where the cancer establishes, for example, the liver or the bone. And there's an interplay between what I guess we can call the host organ versus the cancer cell. So that simplistically, I think we try to think of it as a blood and a lymph flow, but probably there's a very orchestrated signaling that is still probably very not well understood by us. To say, listen, this is how it spreads, right? It's not a linear model like how we think, oh, it spreads here, so then it's going to spread to the next step. And I think that's another thing that people ask. So just because it's in my lung, is it going to show up in my bone? Is it a bad thing? Or is it going to show up in another area? Is it bad when it gets to this spot versus that spot? And the honest answer is we don't know, right? For some patients, it will never go anywhere but the liver. For some, it will only go to the peritoneum or the belly cavity. For some, it seems to be very bone dominant in presentation, which we do know somewhat of an aggressive subtype in some people. So we truly don't understand how all these signalings happen in one person versus another person. So with that background, the question of, just because it's there, is it going to spread to the places? No, I don't think we have any such studies or anything that we can demonstrate that. Because unfortunately, when I used to be in Iowa, we say the cows that left the barn, they left the barn, right? So then it's hard to kind of rein them in that situation by just taking the primary area out or that particular liver spot or something out. So it doesn't really have any merit to, in my opinion, to take out the primary alone, especially if there's no symptom, just to prevent further cancer spread or take out the liver just because we want further cancer spread. Now, we do that for other reasons. We do operate and do some things for many other reasons in this cancer, but at least from an oncologist perspective, that's not to change the course of this path the cancer may take.
Thank you so much. Dr. Del Rivera, I mean, you're an expert when it comes to functional tumors, and you mentioned just now about insulinomas and such. So if the patient's primary is unknown and they have a functional tumor, does the type of functional tumor, for example, gastrinoma, insulinoma, give a hint as a likely primary tumor location? And if so, can the treatment choices and likely outcomes be based on this hunch?
Yeah, Lisa, no, thank you. And yes, it's a very important questions about understanding the symptoms related to hormone excess and how it happened and what new type of neuroendocrine tumors. So, and just to describe between pancreas neuroendocrine tumor, small bowel neuroendocrine tumors, and lung neuroendocrine tumors. For pancreas neuroendocrine tumors, up to 30% or so tumors can be functional. And what hormones the tumor produce. It can be a series of hormones between insulin. So insulin is responsible for regulate the glucose in the body. So excess of insulin lowers the blood glucose. So even with very small tumors related to an insulin-producing neuroendocrine tumors, patients are going to have symptoms. So that's the reason that very often insulinomas are recognized earlier, just because the symptoms related to the excess of insulin. So those symptoms are very characteristic: low blood glucose, and all the symptoms related to low blood glucose, like sweating, dizziness, that they can only be normalized with having a very high glucose meal. Usually the glucose is rather less than 50. So that's kind of like very characteristic of the insulinoma. And also in those aspects, we need to do a series of hormonal evaluation in order to confirm. The same with the gastrinoma. Gastrinoma is excess of gastrin, and gastrin is responsible to produce acid in the stomach. So the excess of acid in the stomach can cause what we call a peptic ulcer disease, and that can cause symptoms related to that. It can cause ulcers, and in some patients even it can perforate because of this excess of acids. It can cause diarrhea. So there are very specific symptoms related to that. And the same with glucagonoma. So glucagon is responsible for the metabolism of amino acids in the body. It can also suppress the insulin secretion. So if those patients has high blood glucose, they can also have very specific rashes in the body. So all of that, depending on what the hormone the neuroendocrine tumor produces, there are very specific symptoms. And it is usually, in most cases, especially with insulinoma, because of that, it can be diagnosed earlier. Now, in talking about small bowel neuroendocrine tumors, we discussed earlier, it produces excess of serotonin. So the excess of serotonin is responsible for the carcinoid syndrome. I'm sure you heard throughout the meeting today about the different symptoms and how to treat it. And there are very specific symptoms related to that. Lung neuroendocrine tumors can also produce serotonin. Can also, and not in every patient, is less common than small bowel neuroendocrine tumors, but that can also happen. One other hormone that I kind of like, that happened in patients with low neuroendocrine tumors, and about 30 or 40% of patients with low neuroendocrine tumors, is the excess of cortisol. So cortisol is also an important hormone, and we discussed earlier is your fight and flight response hormone. And so this excess of cortisol has very specific symptoms related to that, like weight gain, high blood pressure. They have very specific skin characteristics that in some situations, sometimes patients doesn't notice that. And sometimes in cases that when it's diagnosed, it's kind of like in the later stage, but I think it's important to recognize the different symptoms. And I think going back to the question that you asked originally, I'm sorry that I'm, going a little bit more talking about that, but I think the question was, can you diagnose based on symptoms? yes, because depending on what the hormones the neuroendocrine tumor produces, it has very specific symptoms. And based on that, we can certainly work for that specific hormones that we think the neuroendocrine tumor is producing to make the diagnosis. And I think that was the question, right, Lisa? Sorry.
Yeah, no, this is a very complex topic. And for more information on this, I'm going to refer people back to the video presentation that Dr. Dario Rivero did on this topic, which is very excellent. So there's a lot more information about this as well. Thank you, Dr. Dario Rivero. Dr. Kuntz, I wanted to ask you about a sensitive topic. What is the impact of neuroendocrine cancer over sparing pelvic surgery, somatostatin analogs, liver-directed therapy, possibly PRT on fertility?
So also an excellent question. So when we see patients who are of childbearing age, we will talk about fertility preservation, in particular if they will be starting treatments that we think pose a greater risk to either sperm or eggs. And these include things like chemotherapy, radioligand therapy. And I think, sadly, the field of neuroendocrine tumors has not been untouched by seeing more patients with early onset cancers. I think patients under the age of 50, 45, I'm certainly seeing more of. And so this has to become part of our routine conversation. And so in general, somatostatin analogs don't pose a greater risk to risk of fertility, but I think we should broadly be having those conversations at time of diagnosis.
So important. Thank you for acknowledging that. Dr. Chen, is a dotatate PET scan immediately after PRT useful for evaluating treatment effectiveness, or is it mainly used for confirming the radiotracer uptake and distribution? And then how long should someone wait after PRT to have that follow-up dotatate scan to assess the tumor response?
Thanks. Yes, that is a very common question as well. How do we best use dotatate scans in the context of PRT? So generally we don't, so when you finish PRT, the way the radiation causes damage to your tumor cells, it can also cause inflammation and cause like a temporary increase in growth of those tumors before they shrink. So if you do a dotatate PET a little too early, or even a CT scan a little too early, the tumors can look bigger and a little scarier before they shrink. So we tend to not use dotatate PET right after the last cycle of PRT. I think generally most centers, I believe now, are waiting 3 months. Our center for sure is waiting at least 3 months before we get a dotatate PET scan to determine whether there has been any progression, or that's our first look at whether how well the tumor has responded to PRT. In addition, so the uptake itself, while it does tell us where the tumor sites are, it can also be a phenotyping tool. So you could also rely on just the CT alone and rely on RECIST, like standard anatomic assessments of response. The challenge will always be those sites like the bones, where sometimes you can't see the sites very well unless you get the dotatate PET. So generally we wait until later. I think, does that answer the question? Does that answer the question?
That's helpful to highlight the importance of waiting till later. I'm going to ask this last question to Dr. Chandrasekaran before handing it over to the second group. And this is a sensitive question, but something that I think we should talk about. Any suggestions or recommendations or resources to patients and family in the situation of advanced disease with neuroendocrine cancer when treatment is no longer working and acceptance has been reached?
I think it's, again, it's something we don't discuss definitely even in, I think, people who see a lot of volume of neuroendocrine tumors. Patients are always unfortunately told, oh, you have a slow growing cancer. Don't worry about it. You're not going to die from this cancer. And this thought is implanted like from the time of diagnosis. And the reality, unfortunately, is, as Dr. Kuhn said, it is a cancer. And if you're otherwise healthy with no other medical problems, there are situations in the future where you're going to be where the cancer becomes the cause of the person to pass away. And I think the other what's different about the cancer compared to other cancers is, again, this prognostication is so difficult. Even for clinicians who've been doing this for decades, probably it's a hard question to know what will happen, when will it happen, or when this point is so reached. And there is no research, again, on the timing of integrating palliative care. I think there is some research in other cancers, for example, like lung cancer. There are studies, this could be predating the immunotherapy era, but even regardless, I think it's very relevant that patients who have palliative care involvement early on at the time of diagnosis in general have a better quality of life, and sometimes maybe suggestion of increased survival time as well, which is incredible. And no such literature exists in neuroendocrine tumor situation because I think that, again, the varied presentation, and the duration of the treatments that somebody's on prior to a situation. In terms of resources, I think just remember that it doesn't have to be like a one-way street, or it doesn't have to be only the clinician suggesting it. Palliative care for me isn't really about any time along the way for any kind of a help you need with the team. So even the clinicians may get a help from the palliative care team for managing symptoms. So it can be, it's not a bad thing to bring up palliative care. I think that's the first thing to realize. Palliative care in the different setting may mean also just supportive care for better quality of life. And in the context of when a point of where tumor treatments are not working and the patient is affected comes around, I think your oncology team or your neuroendocrine team and your local resource are definitely the best place to start in your institution or your cancer center, the palliative care team. I think just like everything else, this also needs a longitudinal relationship. So I think early onset or early integration, the question is, where do you define early is, like I said, unclear, not maybe a diagnosis, because you could be looking at years of palliative care. But I think when a person or a team recognizes that there are maybe limited treatment options or the impact of the cancer is getting to be higher on the person in terms of quality of life, that could be at least a good timing for thinking about integrating these services. And I would always recommend for palliative care, especially local resources, because this needs a lot of hands-on management and interaction, knowing the patients and the care team's preferences, communication between all these teams for the best effective symptom management, as well as support physically, mentally, and psychosocially, as well as spiritually. So
Thank you for that really thoughtful answer. It's a whole team approach, and thank you all for being part of that team. Thank you, Drs. Chandrasekaran, Chen, Del Rivera, Kuhn, Star, for your really thoughtful and sensitive answers, honest answers, and for all you do on behalf of the neuroendocrine cancer community. I'm going to now hand it over to Josh Mailman, who will lead the second part of the question and answer session.
So we all reappear. I think we're all here. Oh, wow, Dr. Thor. You've managed to come back from your soccer tournament. How did it all go?
Not as good as I hoped for, but it could have been worse.
Well, good afternoon. I just want to recognize to everyone who's out there, we received, over 100 questions. We're not going to get to all 100 today. And so these are bases that NCF will use to have other programming, other things that are going on. So I just want to make sure people understand that we're not going to get there, but we're going to try. We'll go hopefully a little fast here, but we'll see what goes on. I think about this, Dr. Thor, you did a session on clinical trials today. A lot of questions about, certainly we have a plethora of PRT trials going on, whether it's an alpha trial or a beta trial. And so this question is, for a patient who's progressed on a somatostatin analog, should they consider an alpha trial versus going on the standard of care Lutathera as a next step? But also, I think, I'll broaden that question as well to how do you decide where to put people on clinical trials? And, one of the challenges for patients is also going on a first-line trial which we're starting to see more of, and how do you look at that?
So excellent question. So I think the first step is to just make sure that the trial is really the right trial for you. It's feasible, it works logistically, and it makes sense. And so if you have a good trial, be it the first line trial or for later line trials, if you have or your center has opened the trial, it probably is a good trial. There's a reason we brought it in. And so then you have to go through the uncertainties of being on a trial, the risks that sometimes are somewhat less well known than with standard therapy. And then at the end of the day, we've got to make a decision together. Is this something you want to do? And as for the alpha versus beta, so I will tell my patients that we don't have a lot of information on alpha particle therapy upfront. So in someone who's never had radioligand therapy or PRT-like therapy, we have really good data on lutetium. We don't have a whole lot of data on alpha particle therapy. And some of them, as you may have heard, have been associated with some unpleasant side effects, including kidney problems and esophageal or swallowing problems. So I think you just have to be really upfront with your patients that yes, alpha it's a new, shiny, exciting thing. I think it's going to be really effective. I think it's going to be safe, but we also have a really good standard option in the form of lutetium dotatate. So all of these things are just things we got to discuss, and then at the end of the day, we'll have to make a decision together that the patient and their families are comfortable with.
Anyone want to add to that?
I guess I would just add that, part of the question was, should you jump to a trial on like progression after an SSA? And I would not skip lines of therapy just because there's a trial out there. I mean, if someone gets referred to me for liver-directed therapy, I have right now 4 liver-directed therapy trials in the net space at my place. So I might offer you a liver-directed therapy trial, but I would not say, oh, you should go do our alpha trial. How cool. If systemic therapy is not the right thing for you. So just because there's a trial out there, you have to, I think Thor is very correct. Like you have to say, is this the right thing for me now? Or is there some more standard therapy that really is the appropriate thing for my disease right now? And I'll keep that trial on the back burner because maybe that'd be more appropriate later. Does that make sense?
Of course. And Dr. Sullivan, the next question really is going to you,
okay.
Which was, you talked about IR trials, but something that came rather quickly without much IR trials is histotripsy. And do we have more information about histotripsy? Because as Dr. Thorth said earlier, the bright and shiny thing that's currently available, that was the bright and shiny thing probably 2 years ago. Is it still bright and shiny? Have we learned more? Are there new trials that you're running or that are a part of?
Yeah, so histotripsy is an ablative technique that uses focused ultrasound to obliterate one or more small lesions in the liver. It's rarely appropriate in the setting of neuroendocrine tumors because they're mostly patients with many liver lesions. So, I mean, we do more standard forms of ablation, microwave, cryo, et cetera, as well. But we don't have much occasion to do that in neuroendocrine tumors. So given the generally limited role of ablation, period, as a strategy in NETs, I don't think there's much of a role. And, histotripsy has been excessively publicized in the lay press, shall we say, for its supposedly immune stimulating properties, which are, as was alluded to in the previous session, things that happen in cells and mice, but not in people. And what is less well known but becoming more obvious now is there have been a number of extremely serious complications and adverse events in the setting of histotripsy, including widespread dissemination of disease, kidney failure, injury to surrounding organs like bowel. So it's not a procedure that I generally recommend for patients, and nor do we offer it at our institution, although there are certainly plenty of other institutions in my general area that do.
With that going forward, I'm going to ask kind of stay on the clinical trial front, but also other therapies that are available. I get this one a lot, not necessarily for lung cancer, but are there advancements in treatment in Europe or other parts of the world that are promising that we don't have here? If so, can we find out about them? And I think of this also in PRRT, but in that realm, where are we in having pretty much the same treatments available globally? Dr. Chan or Dr. Greville, do you want to chime in on that?
Yeah, I'm happy to start off on this question. I think that increasingly the neuroendocrine community is more international, more global. There are studies that are, particularly when industry sponsored, occurring in multiple centers across the world. So I think we're on the same page and even doing the same studies. I think you will find, and this is even true within the United States, that there are some studies that are open at certain centers. But I think the questions that are being answered are quite similar. Some of the common questions are being asked both in the US and Europe. And hopefully we can combine what we learn in both areas to kind of get an answer that will help everyone. But yes, there are some trials that are going on in Europe that are not going on here in the US.
I definitely agree with Dr. Chan. I think we've come a long way compared to maybe like 30 years ago when PRRT was not available in the US and a lot of patients had to go to European centers. I think I do want to highlight, in addition to what Dr. Chan said, advocacy organizations like NCF play a big role in helping patients identify clinical trials. And I always encourage my patients to explore clinical trial options on their own. Clinicaltrials.gov, all you need is neuroendocrine cancer and the name of the city where you're located to see if there are any clinical trials available in that location or around that location. And then seek help from your multidisciplinary neuroendocrine tumor team and also patient advocates that you're working with to identify a clinical trial that you might be eligible for, and especially if in the context of your diagnosis and current clinical scenario, if that would be appropriate. I think relying on patient advocacy and your multidisciplinary team can really help you identify those clinical trials beforehand.
And Dr. Thor, I know that you highlighted the NCORA tool that we use for neuroendocrine tumors. We actually have been comparing it to using upfront Claude or ChatGPT, and it works rather favorably.
That's actually really great to hear, because even for us who live and breathe this stuff with clinical trials, even the NCI or National Cancer Institute website can be hard to navigate. So you may, if you put in a generic term like neuroendocrine, you may end up with like 100 different clinical trials, and maybe one or two of them apply to your situation. That's why we need AI-driven tools like NCORA. And I haven't actually played with Plot or the others, but I probably should. But I've been very pleased with the performance of NCORA.
Yeah, I think one of the challenges has been the metadata that gets tagged to your trials, and sarcomas get tagged to, in the NIH world, get tagged to neuroendocrine tumors. So just typing in neuroendocrine tumors will get you 3 times as many things that aren't neuroendocrine tumors. But that's for another whole presentation. Dr. Chan, you were obviously you were the primary investigator on cabozantinib. If you have a patient that already is working with or has symptoms of diarrhea, fatigue, and weight loss, and potentially kidney disease, how do you put them on cabo, and if so, how do you mitigate those symptoms?
Yeah, these are great questions, Josh. I think as we make decisions about what sort of systemic therapy to offer or to recommend, I think we do have to take into account a lot of factors, including baseline symptoms and other comorbidities. So we can select various treatments based on what we think people may be able to tolerate or benefit from most. When it comes to the specific example that you mentioned, there are some patients who may have underlying fatigue and diarrhea where we do have to be careful if we're going to be using cabozantinib. We may even start out with a lower dose. The usual starting dose of cabozantinib is 60 milligrams a day. Sometimes we can start with 40 milligrams, or even if we're really concerned, go lower and escalate if tolerated. But I think that's where we have to be cautious with dosing and also close monitoring once people start treatment, even just checking in, for that first week and then 2 weeks and going from there.
I think you would be the expert on this, being that you were the PI on the trial as well. So one of the questions that has come up a lot in the last year as we've talked about GLP-1s, and I think we're up to a third of the country is on GLP-1s. I could be off, so don't quote me on that. So I know that we have seen back to mouse models and things in the petri dish that we've seen some negative results with tumors that overexpress GLP-1. I know that it isn't a large percentage of tumors that overexpress GLP-1, but how are you advising your patients who are looking at GLP-1s? And I know there's more study needed, but what do we do at this moment in time? I'm opening this up to anyone. I know one of you had it in clinic this week.
Yeah, I just had a patient like this week who's got really poorly controlled diabetes. We've been struggling with this for years. He's also on an SSA, and finally, his endocrinologist is like begging me to allow him to start Ozempic. So I just did as Thora said, AI is great. Did a deep dive into Copilot in the office, and there was one large study of between 500 and 600 neuroendocrine tumor patients, and only 7% of those patients, their tumors express the GLP-1 receptor, which suggests that over 90% of patients don't, and therefore it would be fine to be on a GLP-1. And how do you know? Well, if you've had a biopsy and someone has your tissue, it can be stained for the receptor. So, if you can get your pathologist to check, you can even find out whether your tumor has a GLP-1 receptor or not. And if it doesn't, you should be okay. Now, of course, you have to have that state available. My hospital does not. So actually, my pathologist can't answer that question for me. Also, the interesting thing that came out of this several hundred patient study was that expression of the GLP-1 receptor was limited to certain types of neuroendocrine tumors. So, for example, not small bowel. So if you're a small bowel neuroendocrine tumor, you probably don't have the receptor, and it's probably fine for you to be on, Ozempic or Wegovy. So I'll just put that out there. That's as much as I learned this week about it. But that's kind of how we're approaching it now, is essentially going to our pathologists and seeing what we can do to get them to bring in the IHC stain for GLP-1 receptors so we can start. Because as Josh said, if a third of the population's on it, why don't we just screen the patients and see whether it's an issue for them or not? I'm happy to see what Thor or other people have to say about it.
I actually might hand this over to Dr. Grewal. And it's not like I'm trying to get out of this question. I believe he may have submitted something earlier today on this.
Yeah, I agree with what Dr. Sulin said, but one thing that's important to recognize is these are not all just one agent. There's, based on the receptors that they target. For example, Ozempic is a GLP-1 receptor agonist, but there's another agent, tirzepatide, which targets GLP-1 and also GIPR. And while we don't have a lot of reliable data for GIPR, the expression of GIPR is reasonably high in small bowel neuroendocrine tumors. And so those agents should be avoided for the most part in small patients with small bowel neuroendocrine tumors. Now, when it comes to testing tumors for GLP-1R or GIPR, we really don't know what that really means in terms of the oncologic risk associated with these agents. And also, we don't know if the risk is different in patients that have an underlying genetic syndrome, in which case we tend to avoid. There's also a black box warning for patients with MEN1 or medullary thyroid carcinoma or familial history of medullary thyroid carcinoma. So I think broadly, we have some preclinical data that shows that there is a risk in patients that have GLP-1 receptor expression, but there is also some population-based data that shows that the risk might not be there. I think it really boils down to understanding the indication for the agent. In some patients, it may just be weight loss. In some patients, there's comorbid type 2 diabetes where it is being used for the benefit with glucose control or also other cardiometabolic benefits. So working with an endocrinologist or cardiologist who may have started this agent, and then understanding the underlying disease risk, like does the patient have progressive disease? What kind of symptoms is a patient dealing with? A lot of our patients with neuroendocrine tumors may have a lot of weight loss ongoing, diarrhea, may have poor nutritional status, and those patients we really want to avoid. But other patients who are relatively fitter, don't have a lot of those symptoms where we worry about overlapping toxicities, don't have rapidly progressive disease, and we've established that there are clear cardiometabolic risk factors that would necessitate them being on these agents. I think it is relatively safer to use, but it has to be a nuanced discussion and a multidisciplinary discussion.
The only thing I'd like to add to that is that in patients with neuroendocrine tumors who are expected to have a long life expectancy, and they have these the cardiometabolic risk factors that Dr. Durrell was mentioning, the potential for benefits from these drugs may actually far outweigh any risk that right now is mostly theoretical. And but that said, if you have patients on these drugs, what I say, follow closely, use the lowest possible dose, and use it for the right indications.
I think the following closely part is, like, for instance, the patient I had just this week, I mean, I've been managing him for several years. He's on semi-annual surveillance. But I said, if you start a GLP-1, we're going to go to every 3-month scans on you again until we, for a year, until we know that your previously stable tumor doesn't take off on us. So the surveillance part is very important if you're going to try the drug.
I couldn't agree with you more. So this is a question from a patient who had a PNET that was metastatic to the liver, had chemotherapy and surgery, is no evidence of disease. So this is basically, I've had surgery and I've had pre or post chemotherapy and now I'm NED. How likely, what are our statistics on surgery? I know we don't have a surgeon on here, but from chemotherapy agents and surgery, getting to that point of having no evidence of disease, to what percentage of them will show up again? And I think we do have data on that.
I can start off on this answer, Josh. I think a lot of the data that has been published related to liver metastases and resection of liver metastases does suggest that there's a very high risk of recurrence. Even if you can resect everything, there's almost a 90+% chance that there may be some recurrence in the future. So, I think many of us don't necessarily think of surgery as curative because those rates of recurrence are so high, but there may be a very big or important benefit for longer term outcomes and increasing survival in the longer term. So I think that this approach that this patient went through, where there was clearly multidisciplinary evaluation to kind of think through the role of systemic therapy and surgery, is critical for everybody, because we do, even if we can't necessarily cure everybody, want to offer the best outcome possible.
I would agree with that, and that's why it's so important that when we recommend the liver resection or any liver-directed therapy, that it's not done with curative intent. Something will most likely show up in the next few years, and they will just point out a small study. This was 10 patients. It's from I believe from Norway. They looked at the uninvolved liver that came out with a liver surgery. So there's a tumor that came out, and then there was a piece of seemingly normal liver. So they looked really carefully at that. And then all 10 patients they looked at, there were tiny little clusters or neuroendocrine tumor cells sort of in the liver. But some of them, and they looked to see how did these people do over time. And after following them for like 4 or 5 years, 40% of them had not yet shown any tumor growth. So even if they are there in very small numbers and in very small clusters, they may not need any treatment for a long time. But you may have set the clock back by liver-directed therapy. And I would actually like to kick that over to Dr. Solin to say, what about like if you have liver disease and there are only a few little spots growing, what is the role of ablating those so you can sort of continue to observe or continue the line of therapy you're on?
Yeah, so I get asked that question a lot. You may have someone who has, for example, maybe they've been on systemic therapy, which actually often works quite well outside the liver and less well in the liver. And maybe there's 2 or 3 liver lesions that are practically, we call that oligoprogression, where everything else is stable, but just the liver is kind of perking up a little bit. And you ask, well, could you do something just for that? And the answer is, well, we can. Should we? Good question. But we often get asked to do it. And so I'll discuss that with the patient. In other cancers, types of cancer, treatment of oligometastasis and oligoprogression seems to be beneficial. So we definitely do it. And also you have the scenario where maybe that's all they have. Maybe they just have 2 or 3 little liver lesions. And you say, well, can you just ablate them? And I'll say, sure, right? I mean, I would resect them. So if you can ablate them, why not? But I tell them the same thing you just said, like, we're going to keep scanning you. Like the risk of recurrence is constant for at least 10 years. And even if I get rid of these spots today, you still need surveillance, maybe less and less often as time goes by. But, something may pop up again. And if we catch it early enough, maybe we can ablate that. And then we have these rogue lesions where they have multiple liver lesions and just one isn't behaving. And so that is a not terribly unusual scenario. Well, I get asked by a medical oncologist, well, is there something you could do? Like, I know there's 10 lesions, but could you just treat this one? Which seems a little odd. But in fact, that's the one that's misbehaving. So one thing, we always biopsy it because if one lesion is misbehaving, it's quite possible there's been a grade transformation or something unusual is going on there. So, but we'll definitely biopsy and then do a directed therapy to just that one lesion and leave the rest of the liver alone until it needs something. So I hope that answers your question.
Also, I would like to add, piggybacking off of what Dr. Heft Anderson said, I think the risk is practically 100% is what I tell my patients. It's a matter of like the biology, which will decide when that recurrence happens. And I also wanted to mention in patients with pancreatic NETs, where we see a couple of liver lesions that can be surgically resected and the patient can be rendered NED, once we have the results of SWOG 2104 available, it'll be nice to see if we can extrapolate from that and educate our patients if adjuvant CAPTEM might meaningfully alter that risk of recurrence.
Can you quickly explain 2104 to the audience?
Yes, so this is a clinical trial, phase 2 randomized, that is looking at adjuvant chemotherapy with capecitabine and temozolomide, 3 months versus observation, which is currently considered the standard of care. This only applies to patients that have a high-risk pancreatic neuroendocrine tumor that has been resected, and the risk is determined based on a score called US NET score or ZADI score. So we're trying to see if in patients with this high-risk disease, if adjuvant chemotherapy with capecitabine and temozolomide, which is a standard of care chemotherapy normally used in patients with unresectable or advanced disease, if giving this as an adjuvant, as an after resection therapy, would that modify the risk of recurrence meaningfully? Dr. Heloise Osoris is the national PI on this study.
Thank you for bringing up that trial as well. One of the things that there's confusion often about whether lanreotide and octreotide or chemotherapy or not, but I'm going to read this question off and we can discuss many aspects of this. This is a patient who's been on everolimus and had progression and then moved on to, it looks like they've had everolimus as a first-line therapy and second-line therapy, had octreotide and lanreotide, and none of these works. None of these have worked so far. Lutathera has been their best option so far. Does this mean that chemotype, and again, I don't believe that we classify lanreotide or octreotide as chemotherapy, but does this mean that chemotype therapies have a low probability on working in this type of cancer? I'm going to flip that around a little and say, have we gained any knowledge of when CAPE-10 might work better than others, or when everolimus might work better, or any markers or tests that we are helping us determine where to go next when something is not doesn't seem to be holding a patient stable.
So I can
go for it,
start.
Thor.
Yeah, so I think the most important thing is to know where this cancer originated from, because the two most common of these, pancreatic and small intestinal, respond very different to treatment. So the small intestinals do not respond at all or rarely to capecitabine temozolomide, also known as CAPE-10, while the pancreatic neurotumors look just the same in the microscope, can respond in 40 to 60 or even 70% of patients, depending on which study you look at. So that's the first thing. And then you have to look at the tumor grade and the expression of somatostatin receptors, because not all of them are created equal in that sense. Some of the pancreatic neuroendocrine tumors may not have a lot of somatostatin receptors, and you wouldn't necessarily expect that octreotide or lanreotide or even PRRT would work for those patients. You have to know that too. And then in terms of octreotide and lanreotide, although I consider them equally effective drugs, one of them is a little bit more challenging to inject. So the octreotide has to be injected into a muscle, while the lanreotide is injected under skin. And sometimes those injections are just not placed in the right location. So it's and then everyone is a little different in terms of this. I tell my patients the fact that you didn't have a response to treatment A doesn't not necessarily mean you won't respond to treatment B and treatment C. I have seen patients not respond to A and B, but have a great response to treatment C, which I didn't really expect. And so hard to predict. And then I wonder if my colleagues have any additional thoughts on that.
I was going to say, I completely agree with Thor. I think we don't really have great predictive markers. The ones that we will use in clinical practice are the ones that Thor mentioned: primary tumor site, grade, somatostatin receptor expression. There has been, and I think there continues to be work done trying to identify predictors of treatment benefit, because as we have more treatments that become available, it's nice to know which ones may be most likely to work for certain patients. When it comes to temozolomide, people have investigated whether expression or presence of a DNA repair enzyme, MGMT, is associated with response. And there's some suggestion that it might be loss of that enzyme, loss of activity of that enzyme might be associated with benefit, but it hasn't really been confirmed. So we're not using that in clinical practice, but I think it's important for us to continue to try to explore markers that can help us to better select treatments in the future.
And it's also important to realize that the context very much matters. So, for example, if you're using chemotherapy as a systemic therapy, as Thor described, it may work better in pancreatic nets than in small bowel nets. If you're doing liver therapy, doesn't matter. Liver therapy works equally well whether you're a lung net, a PNET, or a small bowel net. So, if for some treatments cell origin may matter, and other treatments it doesn't. Similarly, like I use a lot of capecitabine, CAP-10 when I'm doing radioembolization as a radiosensitizer to make the radioembolization work better. And again, it doesn't matter, like the small bowel NATs do just as well as the pancreas NATs when I'm combining the chemotherapy with liver therapy. So, context matters, how each treatment's being used. And as Dr. Chan said, predictive biomarkers, like we wish we had more of those. And one of the very interesting ones that just came out relatively recently from Memorial Sloan Kettering was actually a mutation that can be detected on biopsy. Two mutations actually. One's called DAX and one's called ATRX. And if you have that, it predicts that you're going to be sensitive to radiation. For example, in a very small series from there, as well as in a bunch of laboratory studies, it was shown that tumors with that mutation were much more sensitive to radiation exposure and radioembolization. Now, whether that's true for PRT as well, that hasn't been tested yet. But like knowing that would actually tip me toward a radiation-based therapy versus some other therapy. So we are making some progress in that area, but much more to be studied.
So any patient would be honored to have you as their oncologist or IR physician, but we know that 80% of patients are seen in a community setting and not seen by you, as much as I wish that weren't the case. How do you work with community oncologists, or how do you increase your catchment area or make sure that patients who live in more rural areas can have access to your knowledge, or that their oncologists and local healthcare providers have this type of information? Which is like a $64,000 question.
Yeah.
But
I think it alludes to the bigger question that we all address all the time, which is, if you're an endocrine tumor patient, you need access to a multidisciplinary team. Like you have to somehow get advice from a center of excellence. And depending upon where you live in the country, that may be an hour away or it might be 6 hours away. But forget what I do, what we all do, getting the best treatment plan really depends upon access to some place that has an endocrine tumor board and an expert multidisciplinary team. And that's the challenge for all of us, is to get that out there. Now, if you have access to that, you don't have to go there to be treated. So, obviously, if you make a plan for chemotherapy, then you can find your local medical oncologist can almost certainly administer your chemotherapy or even your octreotide or lanreotide, right? Things like PRT, you need some degree of specialization with a place that does nuclear medicine theranostics. But again, there are a lot of places that offer it that are not necessarily the neuroendocrine mothership. And for, liver-directed therapies like I do, these procedures are literally 50 years old, right? I was in junior high school when people started doing embolization of the liver, right? So as a technique, it's something that interventional radiologists in general broadly are trained in. So, even for my catchment area, which goes several hours in many directions, I will often tell people, okay, you need your liver embolized, and here's somebody in your community who does this. So, and so people can make the choice, doing what they want to travel several hours to get treated, or do they want to go local? And we all try to do that in each, whether you're in Boston or Minnesota or Philadelphia, we try to get people access to care as conveniently as possible. But, it's certainly a challenge. One of the facts is that 85% of the counties in the United States don't have an interventional radiologist, right? So access to care outside of the heavy coastal concentrations and the major Midwest centers can be a challenge for people. But the procedures themselves, most people, if you have a competent, practitioner in your community, they can offer it to you. That's the best I can tell you. I'd be happy to hear other perspectives.
From the sort of chemotherapy, medical oncology perspective, I tell my patients that when it comes to actually giving you the treatment, the chemotherapy or the targeted therapy, or even the PRRT, you're almost certainly going to get the same quality at home as you will with us. Where we can help the most is at the sort of decision point where something is happening or a change needs to be done because of tumor growth or side effects or something like that. So the system I have with us is mostly that my patients go to their local community oncologist, and it's very, very important that you communicate clearly with them in whichever way what works for you, and make sure that yes, you are going to give your opinion, you are going to recommend that they get the treatment at home, but you also tell them when something happens, if something grows, if there's a side effect, you will be there for them. And what we need to figure out a little bit better is how to make that work a little bit better in real time, because as you know, complications don't come on a schedule. They just happen when they happen. And so you may have to get someone quickly and where you didn't really have an opening, and you have to get a little creative. So I think communication is really the key. But when it comes to procedures like Dr. Sulan does, then it's a little more challenging. Any thoughts from my colleagues here?
I do want to add, I certainly agree with my colleagues here. I often tell my patients it's not just about one person. It's not about me. It's about the team. It's about the multidisciplinary team. And every time there is a major decision that needs to be made or a recommendation that needs to be made, of course, it needs to involve our patient and their loved ones, but also it needs input from a multidisciplinary group, discussion in a multidisciplinary tumor board, which sometimes our colleagues in the community may not have access to. So it's really the multidisciplinary expertise for which patients should be, working with an expert team or a specialized net center. And it's not just, clinicians like myself or a surgeon or interventional radiologist. It's also our pathology colleagues who review the slides and help us make an accurate diagnosis. So at very many levels, we can see the impact of working with a multidisciplinary team. And to answer the earlier question, Josh, how do we actually meaningfully engage with our colleagues? Of course, community outreach and interacting with our colleagues and making them well aware of what are the services or expertise available at our institution, but also through advocacy organizations, empowering patients to understand the impact and the importance of an expert consultation or working with a multidisciplinary team through events such as this annual conference today, so they can request a consultation from or a referral from their local oncologist. I think these are all meaningful ways of engagement.
Yeah, I agree completely with everything that's been said. I think this is also where these virtual tumor boards can be helpful, where, even if somebody is hours away, sometimes even just having that information, inviting the local oncologist to join us at tumor board, just to be all at the same table is very helpful.
Mm-hmm.
So I'm going to ask one last and final question to all of you, and it's going to have nothing to do with treatments. You all have been passionate here in this last 45 minutes. Every time I've seen you and worked with you in various different venues, you've been passionate about your work for neuroendocrine tumors. And neuroendocrine tumor patients. I want to know, because you didn't have to take this route. You didn't have to take the route of taking care of NET patients. There are clearly other diseases that, whether they're more lucrative or easier to publish in, et cetera, what is it about NETs, or why your dedication to neuroendocrine tumors? And I'll just start alphabetically. Dr. Chan.
I think, I've, as you mentioned, been doing this for almost a few decades now, and it has been pretty amazing to see the field evolve. I think it is exciting, actually, to have newer tools, newer questions, and even the community. Patients are engaged. My colleagues, the field keeps growing. So I do think it's just an exciting time, a lot of questions to try to answer together.
Dr. Grewal?
I would say, there's a phrase that a lot of my colleagues have used in the past, catching the net bug. I think this happened. Um, and the answer is like, if you ask me why, I would say why not? I mean, there's no reason why anyone would not be interested in helping our patients. When you look at the impact that you can have in a space like this, it's just huge. Like Dr. Chan said, there's so many questions that remain unanswered. So the potential for impact is just huge. And I also want to say patient advocates, like yourself, Josh, and others, really make the field what it is, even from a physician's perspective. And I would say kudos to all the luminaries on this panel who've been doing such great work that younger colleagues like myself really felt that there's so many opportunities for growth, and hence I chose this path.
I'm Dr. Thor. I remember when you were a young bug at an ENEX conference sitting with, I believe, Iowa colleagues back then. But what made you catch and I love the phrase net bug?
So in some ways, so I didn't find the nets, but they found me, and it's that you sort of fall into the wrong or the right crowd, and so I didn't plan on this. Actually, I wanted to be a hematologist, and then I just fell into the GI oncology, and then I was given a project on neuroendocrine tumors, on pancreatic neuroendocrine tumors to be specific, and when I was reading about this, I just realized how much is unknown still. And this is back in the octreotide and streptozotocin days, and that's pretty much the list of the drugs that we have, and the interferon. So I just saw there's just so much more that can be done and needs to be done, and so that's sort of what sort of got me involved in this. And I will also say to the younger colleagues and those who are not necessarily on this call, it's also I think a very friendly crowd. It's a very collaborative crowd. So if you are a young professional oncologist or radiologist, and you want to get into this, you will probably get to know a whole group of incredibly helpful and collaborative people. And it is truly becoming my other family. I'm just looking around to see if my wife's listening, and and she's not.
Dr. Sillin, I'll end with you.
Well, like Thor,
you had many bugs.
Yeah, well, like Thor, I did not find nets. Net found me. I mean, I've been practicing for 35 years. And I do liver therapy for lots of cancers. I mean, liver cancer, colon cancer. But the reality is the net patients live forever, right? So it's just ecological. All my non-net patients basically succumb to their disease. And over the years, my clinic became completely taken over by all my net patients. So the very first patient I ever chemoembolized when I came to Penn in 1991 was a net patient, and he lived for 25 years. And one of the things I really enjoy about working in the net population is you develop these very long longitudinal relationships with these patients you take care of for years, decades even. So I have many patients that I've been caring for 10 or 15 years now. And you get to know them, their families, you hear about their grandchildren, their dogs, et cetera, et cetera. So in that sense, it's a very rewarding area of practice because of these great relationships you develop with these people, as well as colleagues like the ones on the panel today who are really just a great group of people to work with. And as everyone else alluded to, it's also such an interesting field. Once it takes over your life, you realize there's so much going on. There's so many different types of net tumors and net patients, so many questions to answer. We have all these clinical trials going. It's so ripe for bringing students and residents into the field because there's so much going on. We just have a steady stream of trainees that we give projects to. We just started this week with our new crop of summer medical students who are all doing net research with us. So it's just, at the clinical level, the research level, and the teaching level, it's a very rewarding field to be in. And it just, it charges my batteries. What can I say?
Well, I thank you all for being here today and for being here for us all these years and for years to come. And with that, I'm going to turn this back over to the studio to my co-host for the Q&A session, Lisa Yun, and I think I'm turning it over to Dr. Hendafar as well. And so we'll turn that over now.
As we come to the close of today's conference, I want to extend a heartfelt thanks to our 22 speakers, panelists, and moderators, and to our patients, caregivers, and all the attendees who are making today possible. Today's conference highlights not just how much the neuroendocrine cancer landscape continues to evolve, from advances in imaging and treatment to supportive care and multidisciplinary collaboration, but also how much hope we can have in the future of neuroendocrine cancer care. So Dr. Hendafar, as the field continues to evolve, what gives you the most hope for the future of neuroendocrine cancer care?
Yeah, thank you for having such a wonderful conference. I think for a patient, and I'm speaking on behalf of our patients, I think it's never been better time to be in this field, to have this disease, especially from the provider perspective. As the field grows, we're learning more and more every year, having more and more treatment options. And we're very fortunate to have the support of the Neuroendocrine Cancer Foundation and other groups really helping push the field forward. My greatest hope and what I see happening is that there's so many younger physicians who are entering this field, who are learning how to care for neuroendocrine tumor patients. Every day I speak to my colleagues around the country, the more and more I realize that a lot of this knowledge that we've had and we've developed over the last few decades is being successfully transmitted to the younger doctors. And that's very heartwarming and makes me feel very hopeful.
Yeah, the next generation. Mary, what do you hope patients and caregivers take away from today about navigating this changing landscape?
Well, we've said it over and over, but the changing landscape itself is actually the beacon of hope for all of us. Today, the amount of doctors that you see dedicated at this conference tells you their dedication is only going to keep advancing our treatments and changing our lives. And really, one of the most important things we can do as patients to help them is participation in clinical trials. Katie's patient story shared that it's not just something you do, when you're at the end of options. You can provide cutting edge science to move the needle forward with our neuroendocrine cancer. And by participating, you help yourself and you can help future patients, advancements in care. So it's really meaningful to be a part of this. And I personally, with Dr. Hendafar, was actually involved in 2 separate trials over the last number of years. And it was one of the best decisions I made. I was stable for almost 13 years on the medication that was originally a trial, and now it's become a standard of care. So I can't stress enough how critical it is for the patients to get involved with our doctors to support them, and landscape keep moving in the right direction. Just don't underestimate the power that you have to do that along with our physicians.
Thank you for that inspiration, that call to action, that we can all be engaged in this and be part of this evolving neuroendocrine cancer landscape. Thank you, Dr. Hendafar and Mary, for your valuable insights and for taking the time to share your stories and from your heart. And we thank all of you for joining the Neuroendocrine Cancer Foundation's virtual annual patient conference. And we hope that today leaves you feeling more informed, connected, and more confident in navigating the evolving neuroendocrine cancer landscape. This program has been recorded and all presentations will be available to rewatch. Speaker slides can be downloaded from our website. You may receive a survey via email after this broadcast. We would be grateful if you could take a few minutes to share your feedback. Your input helps us understand what's most important to you and guides the development of future educational programs and resources. Join us for a future educational event. Save the date for Sunday, November 8th for our Net Cancer Day Symposium in Las Vegas. I also want to highlight some resources we offer. Our Clinical Trials Guide is an educational resource featuring several key clinical trials for neuroendocrine cancers. You can browse the site by type of neuroendocrine cancer or types of treatment. You will find patient-friendly videos and information about individual trials. We hope this guide will help you better understand clinical trials that might be available for you. NetVitals is a tool to help you prepare for medical appointments, Assess your understanding about your disease and communicate with experts and with each other. Check out our podcast featuring an interview with an expert on various topics, including types of neuroendocrine cancers or types of treatments. Go to our website for these and other programs and resources. And we want to thank our supporters, Novartis, Exelixis, ITM, Lantheus, Crinetics, Curium, and RayzeBio for making today possible. Today has been about sharing knowledge, finding connection, and empowering one another. And as we close, we want you to know that you are not alone. Our community stands with you, advocating for you, supporting you, and walking alongside you every step of the way. No matter where you are on your journey, we are stronger together. Thank you for being part of this community, and thank you for allowing us to be part of yours.
Thank you.